quite senior, but actually who is not aware of the protocol, they actually bypass few things. So that is one of the reason real life it is actually sometimes not followed unless until there is a trained person who is actually on the floor. Second, regarding the movie, yes, being in a lead role as an intensivist, I would be director of the movie for sure because I will guide. Because the person who's a lead instructor or an instructor, or who, when comes to the real life, real ACLS scenarios, he has to direct. He has to be team leader, and he has to direct everyone, like assigning the roles, assigning the responsibilities, and give commands to the all the team members during the resuscitation period. Uh, Second question was yours was.
Basically, you know, with the dramatic, entry, like how hero comes in, would you want to be one of them, or you want to be the director behind the scene? How would you take it from there?
Yeah, so basically, what happens like in real life, what we see whenever we come, there is a code in the hospital. Most of the time, it's a code blue, what we do follow in our hospitals. So, whenever there is a code, already people will be, started the basic chest compressions and airway part. When we comes, when like as I enter, definitely it becomes my responsibility that I take over the scene. I take over the scene means, uh, quickly assess the scene, what people are doing, and according to their position, immediately allot them the particular work so that there is a smooth, conduct of the CPR. So that will be my role.
Okay, so being the director is what you would go with, but do you think we need to sometime be the hero as well? Jump and start the CPR yourself?
Yeah, of course. I see. If it is a scenario where there is a lack of manpower, if I am the first responder, yes, I have to be the ground worker. So I have to start the compression because the success of the cardiac, ACLS algorithms is as soon as you start the compressions. So that is the success rate is decided by that only, for sure.
Absolutely agree. Thank you so much. Uh, the next question that goes to Dr. Kiran Verma. Dr. Kiran, in those first 3 minutes of cardiac arrest, it's basically the platinum minutes that we're talking about. What is that one decision that separates a good resuscitation from a great resuscitation?
Yeah. So that is not so easy to answer, first thing. Why means there are multiple things we need to consider pertaining to the CPR. As you asked to the sir, no one is a hero, no one is heroine in CPR. Everyone plays a equal responsibility. Output depends on the teamwork. It's all about a high performance team dynamics. Then comes to my question. 3 minutes. First thing is recognition and activation of emergency. That's the first thing. Then second one is CPR, high quality hands-on CPR. Then connecting to the defib. These are the three things which makes the difference in the first 3 minutes. We think about the drug later. These are the first three things what I consider. If it wants to be a great CPR, then rest of the things like giving securing the IV cannula, then giving the drugs, then consideration of 5H and 5Ts, those things are later. These are the first three things which I want to consider the first 3 minutes of initiation of CPR.
Well, I
Thank
completely agree with that. I think the first step that we generally miss is connecting the cardiac monitor. So that does make a lot of difference in resuscitation, I believe. So thank you so much for your inputs. Uh, my next question is to one of the aces of resuscitation, is what I would say, Dr. Venugopal sir. Thrombolysis during CPR, specifically, say if it is a cardiac arrest due to suspected pulmonary embolism. Now, I'm making myself clear, it is suspected pulmonary embolism, not been diagnosed. Patient has come in, history suggestive of a pulmonary embolism. Is it worthwhile to go ahead and thrombolyze, considering the possible complications, or probably hold, see, and then probably proceed with a definitive diagnosis? Sir?
Yes, if you have this, you putting the indexes and so the strong suspicion. It's not just suspicion, strong suspicion. This is a pulmonary embolism. This will work.
Dilemmas in this situation. We are suspecting very strongly that, okay, fine, this is most likely to be a pulmonary
Yeah.
embolism, but we are also scared that, it's ongoing CPR and we're giving a bolus of a thrombolytic agent, whether the patient would bleed to death, not from the embolism probably, but if it is a mistaken diagnosis.
Suppose it is, suppose a strong possibility of the pulmonary embolism. If you are not lice, no way get to get it, get patient back. If you are lice, there is a chance. So this
So I
is
think it's
my
one
take.
of the T's.
Yeah.
I think, but clinical scenarios, it's quite tricky because, like, I had a patient last 2 weeks earlier in my ICU with a DVT. She was like suddenly had a cardiac arrest around 74, 75 age with a lot of comorbid conditions. So we strongly suspected pulmonary embolism. Uh, by the time we could prepare, actually, we did not get a time to thrombolize her. But yes, I do agree. Strong suspicion. Mostly patient who have a good salvageable, outcome, and where it can be given early. Early means I think preferably within 10 minutes of starting CPR. I think that's good call. I think later on I'm not sure how it will work and what will be the benefit. But yes, it should be given.
I also want to share one
Sir.
my own experience. We had this is 10 years. There's an yeah 2014. One priest of temple, he came with acute dyspnea and arrested in the ED in our research bay, and we initiated the routine ATLS protocol, CPR, etc. It is not responding initially with a few cycles. Then we have that strong suspicion, and in between and a focus is also helped out so that there is the suspicion is added. And okay, definitely those time emergency people alone doing thrombolysis means bigger question. Those time 10 years back, they will kill us. We'll also take the cardiologist along with it, but cardiologist was little hesitant to do that. Then okay, I will stand along with it. You give it. Rest of the thing we will do that. And we given the lysis, and within another few cycle, we got.
We have also
we are
given, sir.
received.
I think Ajay can tell. We have given many situations in emergency where we have, given this. But I was just saying, like, it can be given little early. I think it is more beneficial. And because later on, if you keep on thinking, and then give, then I think it's very, harmful. I think harmful or probably not be benefit.
I was coming to the same point. We encounter many times that many young patients come in the ER, sudden unexplained cardiac arrest with syncope and all, and high suspicion of PE is there. So POCUS can guide us. And obviously, while considering for thrombolysis, definitely there's a dilemma that if you are giving thrombolysis, the risk of, you can say, bleeding and all, but risk versus benefit ratio has to be considered. And then if you act in that time, it will definitely improve the outcome of the patient. So
Yeah, definitely, life is, much more, to save than other
Right.
complications.
I completely understand.
And
Now, this
I
question.
want to add to this
Yes, Ajay,
because
please.
this is a double-edged sword, thrombolysis in a cardiac arrest. Because we also need to consider, as everyone told, clinically strong suspicion with supporting evidence of like POCUS or D-dimer. But again, we need to see the scenario also, what has happened, because I had a patient, a young chap, 27-year-old male, who was playing cricket and he fell down. He had multiple episodes of syncope. And when he presented to us, we were strongly suspecting pulmonary embolism. Did a CTPA, revived him, did a CTPA, and it was confirmed. He had a arrest. Again, CPR was started, thrombolysis was done, but he died because of embolism. But at the other side, he had a very small HDH was there because he had multiple times he had history of fall while playing cricket. So that also has to look. We need to see the clinical scenario also. If the patient has a history of fall or any head injury, even a small head injury, I think in those scenarios we should be more cautious.
Well, I completely resonate that. My next question goes to Dr. Neeraj. Uh, you know, he just mentioned something using of an ultrasound machine. Point of care ultrasound in today's resuscitation has become a not a adjunct but probably a mainstay thing that we want to use. So, in scenarios which are like not something which we are anticipating on a daily basis, like given an example of pulmonary embolism, What is your opinion about using ultrasound as an adjunct to ACLS protocol? You know, how does it help? Whether it is really helpful or it is just a myth that we are carrying along.
Uh, as common to that, when we are using POCUS to, you can say, diagnose PE or the cause of cardiac arrest, so other causes which we can address with the use of POCUS are to see the, you can say, component of, you can say, rush protocol, hypovolemia, to exclude any obstructive causes of shock, cardiac tamponade and all. Then we can also assess the real time, you can say, chest compressions, how the heart is contracting and all. It can guide us for a better, you can say, cardiac compressions during, I mean, CPR and all. And then we can also see whether at what time we need to stop after CPR to prognosticate with the help of POCUS. So it can guide us in that way.
Okay.
Just to add to on this point, there
Yes.
are multiple studies using a focus during CPR. Yes, multiple centers are using focus while they are doing CPR, but they are not interrupting the CPR. They are doing simultaneous. CPR will be going on one side, then they do the focus other side. They can check the left ventricle, then left ventricle outflow track. So how effective our CPR is? If left ventral compression is not so good, it means that there is no outflow track. So we are unable to maintain the perfusion to the vital organs. If that compression is not so good while doing so, it means it is one of the indicator to improve the quality of CPR. So there are many studies and it is well established. Yes, there is a role of focus in during during CPR.
So the next question I would direct to you only. What is the one challenge that you see while using POCUS? See, we still have emergency departments which are being called casualty. Usage of ultrasound is, even today, in today's era, I believe it's still very limited in our country. So should there be a policy where an ultrasound machine should be there during resuscitation? As a borrowed machine, you know, for that matter, not even dedicated to the ER, but or ICU for that matter, but can it be borrowed?
So developing countries like India, I could say that we are enjoying the golden era of emergency. In the olden days, it is very difficult to get our cannula. Some small thing we used to fight with the people to get the small thing, even X-ray. But nowadays, majority of the hospital, I am not saying that 100%, majority of the hospitals are having emergency department. Every emergency department is equipped with dedicated ultrasound machine. So it plays a crucial role, especially when dealing with emergency cases. So it makes the clinical decision. It makes the difference of differential diagnosis and to guide us to treat the patient in a better way. Then when it comes to CPR, as I told you earlier, yet it plays a very crucial role to make the diagnosis and to give the better care for the patient.
Well,
Regarding the ultrasound machine,
Right.
I want to say one again an experience. When 2007 I started emergency medicine in Kerala Aster. I asked ultrasound machine, but MD given one ultrasound machine, but he is locked in his room and assigned one assistant to get it. When I wanted, this girl will come and open it. And later in 2000, another 2 years back, then again I pursued the same same proposal, and even to get it that I need chairman to travel from Dubai and came and he's approved that one of the Macromax 3 Pro Macromax I got that time. But even those time I told because in corporate and all they will ask what's the income bill. I will ask them to put it some small charge. But even say if I am not make it at least like equal to your investment, you put it my salary back. This way I got it one. And now I am like developing few peripheral semi-rural rural hospitals we are taking up and managing emergencies. Now it is very easy, even in this single, okay, if I want to do this is an ED level, I need this. So because almost all my, there are 4-5 peripheral centers are there. All the peripheral centers are holding, peripheral centers mean it's a semi-rural or rural. They're holding an ultrasound machine in the ED.
See, the ultrasound has come up that way that in our ICUs now, we don't do any procedure without ultrasound. So the way is like that because the safety is too good with the ultrasounds. We take anything. Like during resuscitation, you take a line, you're diagnosing, undiagnosed cardiac arrest reason like tamponade. It's definitely very helpful tool. So we must have ultrasound now.
Well, I cannot agree more. So the other question is to both our critical care specialists. We use Apache score as a predictive parameter. We have Muse in the hospital where it's an early warning score. What is your opinion about usage of AI in predicting cardiac arrest? Whether it is just another gadget adding up to our already array of things that we use, or is it really going to be helpful in the future where a cardiac arrest is predicted by AI, by just kind of having the data, the patient data with them?
So see, we have one system in our. I'm not taking the brand name. We have a system which gives a calculated mu score, and we have a sheet with a little monitor which calculates patient's muse, and it reflects on the nursing desk all the time. It gives alert when there is a high mu score, and accordingly we have a RRT system which is activated when the mu score is higher side, as per the protocol. With this AI tool, what we are facing, like last almost 4 months, we are being using it in our wards. So I am not getting much help, frankly saying, because there are erratic reports, erratic, alarms which should not come. So that particular system is actually not helping us, and we are really thinking whether actually it is useful to us, and actually we are re-evaluating whether this system is actually helpful. It may be good where staffing is very low, probably where critical care setups are not in the backup, and where there is no system of RRTs, rapid response team. But still, I'll say in a tertiary care center, these AI tools which gives early warning signs may not be helpful much actually.
Okay. So, good news, doctors. We are yet not there where we will be replaced by AI. So, one good thing that I get from a very senior doctor that AI is helpful, but not up to the mark where we would be absolutely dependent on them. Well, uh, the other question, which is technically, you know, more towards the emergency departments where we do not get much time to think over a patient who was just wheeled in a cardiac arrest. So, Dr. Ajay, this question goes to you. Uh, you know, uh, have you ever had a code that was clinically perfect? You did everything, but it was emotionally very draining. How do you lead your team through such an experience where a young emergency physician or a young doctor who has just resuscitated but was probably not successful becomes emotional? We have been there. So, what is your opinion on that? How would you manage such a situation?
Actually, this has happened many a times, and the new residents who are there, they have performed wonderfully while doing the running the code. But at the end, if the patient didn't survive, they felt emotionally very bad that in spite of all my efforts, I'm not able to resuscitate. And I remember one of the my resident is here. One young lady was found lying unconscious on the road, and one of my staff nurse started CPR there and brought the patient, wheeled in the patient inside. And without wasting any time, we did CPR. We did everything for the patient, but still that patient couldn't survive. And it was definitely emotionally very disturbing for the staff nurse who started the CPR on the road itself and brought the patient in, and then the residents who were there resuscitating the patient. So we need to understand that we cannot get success every time. Everything is not in our hand. We can try, but everything is not in our hands. So we need to accept the truth, the real truth of our life, that we cannot succeed every time. And definitely, Almighty God is there, who is taking care of many things which is not in our hands. So we have to support each other. And then, because of such a stressful situation, many a times the teammates may get disturbed. So we need to have a closed room discussion or a debriefing session where we can find out what things went wrong or what things could have been improved during the resuscitation, and those things should not be repeated in the next resuscitation to get more chances of success.
Well, thank you so much
One
for that.
second.
Uh,
1 second.
sir,
Because we have the residents. Many institutes when we are going exam run, when I am asking, they will tell Some of them are not done their ACLS course or the structured courses. For my perception, I started from the very beginning. I asked all the residents to complete their three life support courses. That is the ACLS, pediatric life support, and advanced trauma life support in the first 6 months. So then only our patient will be benefited. Otherwise, if they take in the end of the course, it will be they will get a extended warranty on their certification, but our patients will not be getting. So what we all the teachers we have to insist get it not only like no again not only these residents, the core team members and our ER nurses should also undergo ACLS. Then only we'll get the common language, and that will definitely bring the good results.
I'm absolutely in sync with that, sir. Um, my next question goes to Dr. Neeraj. See, we in ER, we generally resuscitate. Post resuscitation, something is which always critical care comes into picture and they take over from us. Um, so, you know, my question to you is we save the heart, but sometimes in that process, we do lose the brain. You know, it's beyond our control many of the times. If the CPR is not good, or if the presentation is delayed, or if it's a very prolonged CPR, you know, we do lose the brain. Are we doing enough post resuscitation to protect the person, or just getting the ROSC is all we are looking into? How do we look into this prospect of ACLS?
Basically, resuscitation of the patient post CPR doesn't end there when we get the ROSC rhythm. It is much beyond that, because the patient in whom the ROSC might have been achieved with our good efforts of chest compression and drugs and defibrillation, he might far be away from favorable neurological outcome. So we need to definitely address that point of neurological rehabilitation of the patient in the form of balanced ventilation techniques, then targeted temperature management for the patient, and then nowadays in the update also of the 2025 guidelines, they have mentioned about the neurofilament assay as a biomarker tool to look for, you can say, neurological recovery of the patient. So our effort doesn't end there. It's far from, the patient is far from stable. So you have to definitely assess the neurological status of the patient.
If I say one thing, like post resuscitation care is still, I'll say it's not that much practiced, because the team celebrates once there is ROSC. Actually, the problem is that. So most important, what I feel is taking care of hemodynamics is very very important, because already we got a brain injury. I mean, during probably because of hypoxia during the CPR, and after that, if hemodynamics are not maintained, actually that decides the outcome. So one organ, yes, brain, but rest organs during post-resuscitation care, especially hemodynamics and oxygenation. Like if I say 100% oxygen, one ventilation is very harmful. We all know that, but still it is ongoing. Post-resuscitation, nobody is tapering it down. Many places it is not, and I will say nobody. So it is not tapering down, and still patient is having PO2s of 450 for no reason. So I'll say that oxygenation, hemodynamics, TTM, targeted temperature management, these are the must part. And important thing is the root cause of CPR has to be addressed immediately. Otherwise, patient who have a repeat cardiac arrest within 24 hours, they actually don't survive. They have a very, very poor outcome. So those four are the core points of post-resuscitation care, and I think they should be followed very strictly.
Well,
So just one thing here.
Yes, please.
Our end point of CPR is not getting ROSC. Our main, it is not a CPR. I could say it is in different way. Neurocardiopulmonary resuscitation, I could say. Our main intention is to have an intact neurological system. At end of the CPR, after getting ROSC, patient is getting discharged. Our focus is to get CPC score 1 or at least 2. If you are able to achieve CPC 1 and 2, that is the best CPR. That is the outcome. ROSC is not an outcome. Okay, then CPC patient is CPC 3 and all, there is no point. It's like almost more even. So our end point of CPR is achieving the CPSC 1 or 2.
Well, keeping the essence of time, my last question open to the entire panel here is, after years of running codes, what's one thing you do differently now, something you wish your younger self had done? Venu sir, you would be, the person who can really guide us. what do you do differently during a code now, which you would say that, when I was younger, say 20 years back, I would have done this, probably it would have been better.
Repeat your question. You are the core point of the question.
What I'm saying, sir, you've been working and, attending codes and CPR for,
Okay,
for
yeah.
ages now. So, what you do now is something which probably you were not doing 20 years back.
Yes.
Right? So you're an experienced person now.
Yeah,
What
yeah.
would you say to your younger self 20 years back,
Yeah.
that probably if I would have done it better at that point of time, things would have been different?
Okay. Now, still, I will tell my team, yes, quality CPR. Timely, just like focus their chain of survival. Now the new guideline, they added the sixth chain also. So this survival is not merely with the one man, or this. It is a complete teamwork, starting from early recognition, prompt CPR, prompt defibrillation if required. And it is not only mere there. If you want the patient coming properly with the full strength, critical care is playing the pivotal role. Because it is now, when suppose the patient is out of ventilator, again the rehab is also part of it. So again, still like even in the midnight, our people should be there able to give the quality CPR. I have that just couple of weeks ago, I have a big experience. So one of an ex-minister, he's my classmate, so he's arrested inside the hospital, 2 o'clock in the 2 o'clock in the early morning. And he had multiple problems. He had diabetic, autonomic neuropathy, and he has diarrhea, electrolyte imbalance, plus he has two coronary this thing. But he has promptly resuscitated midnight and with excellent ICU care, and then with the physio, now he is back to home and back to politics, and he is contesting in the upcoming election.
Well, I think the takeaway from what you just said is quality CPR. Well, thank you so much.
I would like to add one point here. If
Okay.
you ask me what I didn't do, what I want to do in the future. So I asked for metronomes and for real-time feedback devices, which gives us real-time feedback where we are lagging. So it's regard to quality of CPR, whether it is we are doing hypoventilating a patient or hyperventilating a patient, then all those things, if you embrace the technology, especially AI, if it gives us real-time feedback, so it would be helpful for us. It would save many patients who might be under impression that we are doing quality of CPR. In
So
fact,
a
it was
real-time
not.
feedback of what we are
Yes,
doing.
we
Well,
want to have feedback devices.
I completely agree with you, and I would like to conclude the panel for now. Thank you so much for your inputs, and I cannot be more enlightened after the panel. Thank you so much for the essence of time. I'm really sorry, I'll have to close the session.
No problem.
We'll have a chat.
Thank you, sir.
Thank you so much.
Thank you, Dr. Ravi.
Thank you all the panelists and moderator. I request Dr. Vishal and all the panelists, please felicitate our moderator, Dr. Ravi Pratap, with a memento. And I request Dr. Vishal, please felicitate our panelists with mementos.
For the next session, I would like to invite Dr. Akshay Shetty. He's a renowned pediatric intensivist and general pediatrician based at Rainbow Children's Hospital, Bengaluru. He is a pioneer in simulation-based training. He is a founder member of PediStars, Indian Pediatric Simulation Society, and has represented India in global pediatric critical care education. His contributions include international publications, invited lectures, book chapters, and editorship for the Journal of Pediatric Critical Care.
To chair the session, I request Dr. Vijay Makhije sir, Dr. Anup Verma sir, Dr. Onkar Khandelwal and Dr. Rakash Shivare. Please join the dais as chairperson. Over to chairpersons. I repeat, chairperson of the session, Dr. Vijay Makhija sir, Dr. Raka Shivhare, Dr. Anup Verma sir, Dr. Onkar Khandelwal sir. Over to chairperson.
Good morning to you all. So we would be moving to
I
the
request
session
Dr.
of
Vijay Vachani, please join the
cytokine
dais as
storm.
chairperson.
In fact, this cytokine storm is a not a very old phenomena or not a relatively new terminology introduced in year, I think, 1993 by James L. Ferreira. And since then, this mechanism, this disease, which is not so frequently encountered, but very important in a critical care situation, has been encountered. So, to throw more light on it, I would like to request Dr. Vijay Makhija sir to introduce the our speaker for the today, so that he can throw more light on it.
एक्चुअली साइटोकाइन storm अगर अपन बोलें तो ऐसा है एक प्रकार से सावन जो अगन लगाए उसे कौन बुझाए एक्चुअली साइटोकाइंस आर वेरी मच इंपॉर्टेंट इन द इम्यून सिस्टम एक्टिवेशन एज वेल एज इन्फ्लेमेशन एज वेल एज द ग्रोथ but they sometimes act adversely and they create a storm, and that storm can be life threatening, and this life threatening situation has to be obviously controlled with the help of the dexamethasone and various monoclonal antibodies, and supportive measures are also required. It affects all organs of the body. It causes coagulopathy, it causes cytopenia, and more will be told by our learned speaker, Dr. Raksha Sethi. Please, sir.
Thank you so much, sir. It's a very nice introduction, and thank you so much for the invite. So, what I'm going to talk today is essentially, like sir said, it's not an uncommon term, but I think COVID kind of made this term very popular. And the whole intent of presentation is to really put in a case whether we should consider immunomodulating children with sepsis, like what we did during COVID times. So, what do you mean by cytokine storm? Now, it's a very vague term. It might mean multiple things to multiple people, but I think we'd all agree that, like sir was saying, I mean, it's a condition where the cytokines levels are very high. But how do you recognize it clinically? This is a good publication which came from NGM, which kind of tells what cytokine storm is. And you would have acute systemic inflammatory symptoms. But more importantly, it's about identifying secondary organ dysfunction. So let's imagine someone has a pneumococcal pneumonia, but he has a lot of liver functions deranged, OTPTs being on the higher side. Then you know that that infection has a systemic manifestation because you cannot explain it just by pneumococcal pneumonia. You would consider that this patient actually has cytokine storm. So it's not a disease entity by itself. It's like saying someone has a respiratory distress or respiratory failure. There are multiple reasons why someone can have respiratory distress. Why can someone have respiratory failure? It could be pneumonia, it could be lung contusion, it could be aspiration. Many other reasons why someone go into respiratory failure. It could be asthma, right? So similarly, there are various conditions which can lead to cytokine storm. And today we are going to talk a little bit about in sepsis what happens. So now what we have understood is the importance of immunity, right? So severe sepsis means there is immune dysregulation, and oftentimes this immune dysregulation presents with cytokine storm leading to secondary organ dysfunction. So nowadays we say if there is an organ dysfunction, we call it a severe sepsis. But the issue is that we've been treating infection and severe sepsis in a similar way, making antibiotic as a cornerstone of our therapy and then giving supportive management and hoping the patients would get better. Now, of late, we've kind of understood that various infective organisms, whether it's a staph infection, whether we deal with rickettsial fever, whether we deal with viruses like dengue, like influenza, each one of them tend to have a different immunological imprint, causes immune dysregulation, and can have manifestations which can be kind of bit varied. So, for most part, when the patients die within 3 days of admission, oftentimes it happens because of refractory shock, hemodynamic instability, and its consequences. But beyond 3 days, oftentimes it's a consequence of secondary organ dysfunction, which happens as a part of cytokine storm. So I'll go through one quick case just to summarize this whole topic. So this is a 3-year-old girl child who came with fever for 3 days, had vomiting, had lethargy, went to nearby hospital, took some treatment, went home. But 2 days later, child became unresponsive and then finally came to the hospital. In the hospital, child was found to be hypoglycemic, hypotensive, severe acidosis. Child received a fluid bolus. When they did a blood gas, the pH was 7.08, bicarb was 6, base deficit was -19. And this is the CBC done then. So you could see the platelet count being 58,000. You could see ferritin being 18,000. You can see that SGOT and SGPT, both of them are elevated. Okay. So the dengue test when was done came positive. Rest of the tests were negative. So now question comes, does this child have a cytokine storm? So if you look at generally in sepsis, how the immune system works, so you have pro-inflammatory cytokines, like I was saying, it is useful, right? You need cytokines to fight infection, and oftentimes it is actually driven by interleukin-1. At the same time, it's like driving a car. So you have brake, you have accelerator. So both of them will make it steady. If one of them go off, you'll have a problem. So similarly, the immune system which gets activated kind of gets regulated by ongoing immune cytokines like interleukin-10, which control inflammation. Now, if everything works well, then you have resolved state. But if it does not, oftentimes you would see you can have sustained immunoparalysis, and during that state, you have a problem because you don't have an adaptive immunity, you have viral reactivation, and then the innate immunity might go into overdrive, and that's where you see more of HLH kind of picture and what we call a cytokine storm. The other issue also is that what happens is during these kind of situations, now whether there is increased pathogen associated molecule activation or increased DAMs, whatever the reason could be, sepsis or any of those conditions which are mentioned in the slide like pancreatitis, liver failure, cardiopulmonary bypass. Now this situation is associated with a reduced P450 metabolism, cytokine metabolism, which means the cytokines which are produced are not being actually cleared. Now that excessive cytokine, when it is present, it manifests with epithelial dysfunction. It presents with cholestasis, acute kidney injury, ARDS, endothelial dysfunction manifesting as microvascular thrombosis, mitochondrial dysfunction, or it could present with immune cell dysfunction like lymphocyte depletion, impaired microbe killing, and impaired tissue repair. So, how do we recognize it? Now we said that oftentimes cytokine storm manifests with organ dysfunction, and one of the studies which has been done by Pittsburgh group in children is to really identify if there are specific organ patterns which can help us identifying this particular situation. What they found out was 3 basic overlapping phenotypes. The most important phenotype was immunoparalysis associated multi-organ failure. Other one was thrombocytopenia associated multi-organ failure. And the third one was sequential multi-organ failure. So the immunoparalysis associated multi-organ failure is one of the common ones. And oftentimes you would see, the best way to identify that is by looking at the TNF alpha response to lipopolysaccharide. But generally, you would see the total leukocyte count. If total leukocyte count is less than 1,500 for 3 consecutive days, you should be really wary. The other way of doing is looking at the HLA-DR expression on lymphocytes. That could also tell us if this patient has immunoparalysis. Second important is thrombocytopenia associated multi-organ failure presents with thrombotic microangiopathy. The sequential multi-organ failure is not so important. There has been various studies of late which have tried to really look at phenotypes, but essentially if you were to look at 2 common phenotypes, what you would see, one which presents with thrombocytopenia picture, TTP like picture, which is like what we say as thrombocytopenia associated multi-organ failure. The other one is which presents like a hepatobiliary dysfunction. So liver dysfunction is one of the really key things in sepsis to identify cytokine storm. Oftentimes when they have this kind of inflammation, because the Kupffer cells are highly inflammatory in nature. So you would see initially portosinusoidal inflammation. You would see SGOT being more than SGPT. Then you will see the LDH and ferritin being high. Subsequently, there is lobular inflammation. You would subsequently see bilirubin going up. And if it persists, then coagulopathy and ongoing hepatobiliary dysfunction you would see. Now, many times when we say make a diagnosis of diagnosis of HLH or cytokine storm, we rely on established liver injury. It's really important to identify this early state, because once you have an established hepatobiliary injury, it becomes really, really hard. So, how do we then actually clinically recognize? I mean, this is about clinically phenotype, looking at liver dysfunction, looking at, like I just mentioned, TTP-like picture. The other one is looking at CRP and ferritin. This is again a beautiful study which just says how the CRP and ferritin response differs between infection. You could see here that with various bacterial infection, you would have more of CRP response, and more of viral infection, you have ferritin response. And if you look at that picture, the bacterial infection basically through interleukin-1 driven pathway increases interleukin-6, increases CRP, whereas viral infection through interleukin-8 inflammasome driven process increases ferritin levels. Now, interleukin-1 is a very important, has a very important role in various pathophysiological manifestations of sepsis. Now, what it does is that from endothelial cells, it decreases the platelet production from the bone marrow, and then through endothelial stimulation, it increases interleukin-6, and that increases CRP. So many times, many people order various interleukin levels like interleukin-6. You really don't need to do it, because the CRP is a good surrogate for interleukin-6. If CRP is high, it's very, very likely interleukin-6 is very high. It's an excellent surrogate marker. And not just that, the interleukin-1 also causes fever. That's the other part. That's about CRP. So if you look at the CRP levels, you get an understanding of what the interleukin-6 levels are, which essentially tells the interleukin-1 and interleukin-6 levels are high. Okay. Now, ferritin, like in condition like viral sepsis, typical example, the one which I gave was about dengue fever. What happens there is, there are two reasons why the ferritin levels go up. One is by direct macrophage activation, the ferritin levels can go up. The other one is through hemolytic pathway. So once there is hemolysis, that hemolysis through the CD163 receptors can actually trigger ferritin levels. So just by looking at the CRP and ferritin levels, you could have a understanding whether this patient has cytokine storm or not. Now, this is again a study done in pediatric sepsis. They looked at they grouped the patient into 5 groups. And what you can see here is, first group with normal CRP and ferritin had a 0 mortality. But when both CRP and ferritin went up, you could see a significant increase in mortality of 40%. This study is very beautiful, because what they also did was, they measured all the interleukin levels. And what you can see here, all those red things, what we see are the bad interleukins which have gone up. And you can see that there's very poor response to X5 or TNF alpha. So what you can see here is, just by looking at CRP and ferritin, you could get an understanding whether the patient is in cytokine storm or not. You don't have to do all of these levels. So what happened to this child? So this child had a high ferritin of 18,000. The lactic acidosis was worse, it was around 8. There was intra-abdominal hypertension. The child was being ventilated. We started this child on anakinra and NAC infusion. Abdominal drain was inserted. And you could see that the INR had gone up to 3.3. SGOT, SGPT was increasing. Okay. So now how do we manage this situation? So what, like we just mentioned, we need to understand the cytokine storm or HLH, what we see in sepsis is very different from what we see in rheumatological illnesses or even primary HLH condition. So here, the NK cell and T cell both are depleted. So there is reduced or absent interferon gamma production. This is very important to understand, because when we talk about primary HLH, it's often associated with high interferon gamma production. The ferritin response, what we see, is secondary to interferon gamma production, but in sepsis, it's completely opposite. So because it has a huge significance in the therapy. And like I just mentioned in the previous slide, it is through direct macrophage activation through inflammasome. So what happens in sepsis is the NK cells switch from high cytokine producing to low viral cytotoxicity phenotype, which means that the viral reactivation becomes a bigger problem in this, and this viral reactivation can subsequently drive up the innate immunity and cause macrophage activation. Similarly, the T cell also, like I just mentioned, they become reduced, and that again predisposes you to have secondary viral reactivation even in bacterial sepsis. This is the slide which I just mentioned. The difference that, of sepsis associated HLH or cytokine storm is that you have NK cell and T cell being low, you have low interferon gamma production unlike other conditions, and that is the reason therapies which involve drugs like etoposide, which brings down the T cell level, can be extremely dangerous in sepsis if you treat through HLH, because T cell levels are already very low, interferon gammas are very low, so it's like adding ghee to the fire. So just to restate this, now this is again an interesting study, and in bacterial sepsis, when they looked at ferritin levels, they found out that every time the ferritin went up, they found out the number of viral reactivation increased. So when it is more than 3000, you would see a significant number, including more than 2 to 3 viruses were identified in the blood. So a bacterial sepsis patient, when it does not get better and you see a ferritin going up, always look for secondary viral reactivation, because many times along with treating HLH, you might have to treat those viruses which have been reactivated. So this is again a beautiful study which looked at what sequence will make the immune response even worse, cytokine storm even worse. Whether it's a bacterial infection followed by viral infection or viral infection followed by a bacterial infection, what they found out is when it's viral followed by bacterial, the inflammatory response tends to be very, very intense, like shown in this diagram. The ferritin level, triglyceride levels, liver enzyme levels go skyrocket. This is what sometimes can happen with dengue fever. Like what they found out in dengue also is if the lipopolysaccharide levels are very high, those patients tend to have far poor outcome, much more intense disease. In fact, if you have secondary bacterial infection with regards to dengue, their mortality tends to be high because it is first a viral trigger followed by a bacterial trigger that drives cytokine storm insanely high and can increase mortality. So question is, how do we treat it? Now, we just showed in this patient that we treated this child with anakinra. What's the evidence for anakinra? Anakinra is the interleukin-1 receptor antagonist, right? So this is the initial report which came that there are a group of patients with HLH where it can be beneficial. This was followed by this report where they initially looked at role of anakinra in sepsis, and what they found out is those patients who had hepatobiliary dysfunction, anakinra made a huge difference. So they found out that overall they could not, but a subgroup with the hepatobiliary dysfunction with the DIC, that group of patients when were treated with anakinra, the mortality dropped from 64% to 35%. That was very similar to the rest of sepsis group. Okay, so this is why that the whole pathophysiology what I just mentioned, that hepatobiliary dysfunction as a manifestation of cytokine storm becomes very important, and that particular phenotype of group of patients respond really very well to anakinra. We used anakinra in during the COVID times initially as a part of MISSI. And subsequently, we also wrote an article in Archives Disease of Childhood considering the role of immunomodulation in those severe dengue, not every dengue, because some of the dengue respond really well, but some of the dengue, despite conservative management, have progressive liver dysfunction. They go into acute liver failure. No amount of fluid therapy is enough. They leak continuously. They bleed. So making a case for immunomodulation in those group. And then subsequently, we published our experience with role of anakinra. In some cases we use steroids, but it's mainly anakinra. This is a publication again published in Archives Disease of Childhood, and where we took an experience of our 45 children whom had very severe dengue, and we had a very strict criteria. So those patients who did not respond to fluid therapy needed more than 10 ml per kg per hour of fluids despite 3 hours, were continuously leaking, and have progressive organ dysfunction, especially the liver dysfunction, despite conservative management are the ones. So the mean ferritin levels in this group of patients were 30,000 plus, and there were 5 patients who had ferritin more than 1 lakh. So what we found out was the mortality, the survival was 80%. When I looked at comparable group published elsewhere, their mortality was close to 80 to 90%. Here survival was 90% when we use anakinra in this very specific group of children with severe dengue. So in a patient like dengue, and especially with hyperferritinic mods, how does all this work? Now basically, like I just said, the ferritin response happens in 2 ways. One is through hemolytic pathway, other one was direct macrophage activation. So the therapy like Plex can sometimes be very useful because it really clears out free the hemolyzed RBCs, which can actually make your inflammation go away. Limiting blood transfusions is also one helpful strategy. The inflammasome can be blocked by using anakinra, and the inflammasome activation stops, ferritin response stops. Now, what happens is the ferritin becomes like a feedback mechanism which keeps on inflammation active. IVH could be useful, but we have not been using IVH because we don't find it that useful nowadays. But then pathophysiological rationale is that it can block those virus particles activating TLR9 receptors. So this is how a hyperferritemic MOTS, which happens in patients like dengue, basically works, and a pathophysiological rationale about how we treat them. So, how do we manage them? So, basically, like I just mentioned, oftentimes there could be a coexistent bacterial infection. It's important to find them and treat them. And don't give too much of blood transfusion because free hemoglobin itself can drive inflammation. And considering anakinra in some of this group of patients and considering plasmapheresis in some of this group of patients, this might help in managing the cytokine storm in this group of patients who are really very sick. So what happened to this child? You could see that the STOT, STPT went up. The STOT went up to 15,000, PT went up to 3,000. Bilirubin also became high. Then the child was continued on anakinra. Then child also, in addition to anakinra, received pulse methylprednisolone for 3 days. And then by day 4, the transaminase started improving, sensorium started improving, and by day 5, child was extubated, and child was subsequently started on low-dose steroids. And then by around 3 days later, child was discharged. So I would just try to conclude this talk by saying in the initial part of illness, of course, the antibiotics, those things become really important. In patients like toxic shock, IVH becomes an important therapy. But then it's important to recognize the secondary organ dysfunction, the secondary to cytokine storm, and consideration whether certain group of patients really would benefit from immunomodulatory therapies. So with this, I'll just conclude my talk saying that immune dissonance leads to cytokine storm in sepsis. You don't need exotic interleukin levels to be done in any of those patients. All you need to do is just look at the platelet count, look at your WBC count, look at CRP, look at ferritin, and do a liver function test, really useful marker, and INR. That can help in most of the cases to identify cytokine storm. Now, I also mentioned that many of these patients have a decreased cytokine P250 activity, which makes the cytokine storm worse. Poor NK cell activity and lymphopenia leads to immunoparalysis. And this is really important to understand because the classical treatment for HLH, drugs like etoposide can be really toxic because they decrease the lymphocyte level. Okay, and that's very useful in a patient like primary HLH, but a disaster in a patient like sepsis. So, because a persistent macrophage activation is independent of interferon gamma, unlike in primary HLH, hepatobiliary dysfunction with DIS is a common manifestation. It's important to recognize this particular manifestation, and that particular condition is very amenable to be treated with anakinra. And I said a lot of these patients, even with bacterial sepsis, when the ferritin levels become high, if they're likely to be, if they're in immunoparalysis, secondary viral reactivations are common. So look for DNA viral reactivation. The free hemoglobin and DNA viruses itself can promote ongoing inflammation. So IVIG, anakinra, steroids, Plex, they are really useful therapies in certain group of patients which can help in managing cytokine storm effectively. So with that, I'll conclude my talk, and I want to acknowledge all my colleagues. So thank you so much for patient listening.
So we congratulate you for a wonderful talk. You have made a very complex topic very simple. Will you please elaborate on the relative significance of different drugs, IVIG, methylprednisolone, anakinra, etoposide, in your clinical practice?
Yes, sir. So I think IVIG is something we use when it's toxin-mediated disease. For example, like toxic shock syndrome, staph-mediated, toxin-mediated disease, we use IVIG. We also use IVIG not just for immunomodulation, but even in those immunoparalytic patients because their immunoglobulin production goes down. Then we give replacement dose of IVIG. That's like 0.4 to 0.5 gram per kg. But treatment dose like 1 to 2 grams per kg we give when it's primarily toxin-mediated disease. But when it is hyperferritinic, when the CRP and ferritin, and especially the viral-mediated cytokine storms, we use anakinra as our preferential therapy. The reason we choose anakinra is that it's very short-acting, it's very selective, it's not very broad like steroids. When it is primarily TTP-like picture, we use plasmapheresis as our primary option of management in those group of patients. And once we are absolutely sure that the antibiotics are very well covered, we have identified bacterial organisms, because there have been patients with dengue who come with Acinetobacter sepsis. We have had patients who have come from community with dengue with aspergillus infection. So once you are very sure that you have really covered with a good bacterial cover, we consider steroids if they don't respond well to anakinra. So that's the generally how we use or immunomodulator therapy.
When you use methylprednisolone,
So methylprednisolone in 2 doses. One, let's imagine low dose steroids. Other one is pulse dose steroids. Pulse dose steroids we use when we are very sure it's toxin mediated disease, or when we have used anakinra and we are sure that we have covered given antibiotics coverage adequately, we consider pulse dose steroids in them. Then there are certain group of patients, for example, say with uh, viral pneumonias, viral infections, where hemodynamically they are quite stable. We consider, say for example, even with pneumococcal pneumonia, we do consider low dose steroids in those group of patients.
So when you consider these therapies, immunomodulatory therapies, to whom you consider and what is your criteria to use the therapy?
Yeah. So I think the general dictum is that we use once a conservative therapy, whatever established treatment you have given, and still there's a progressive organ dysfunction, then we consider immunomodulated therapy in them. So like I just mentioned, we look at the trend of the hepatobiliary dysfunction, we look at the CRP ferritin levels, we look at the platelet trends, and the clinical course of the patient. So, see, for example, in dengue, it's a very difficult to give a very particular answer, because you need to be aware of the lag period of the investigations and the clinical course. So, you need to marry the clinical course, you have to marry those investigations, and then take a call about giving immunomodulator therapy in this group of patients.
And sir, what are the level of evidences and what the guidelines says about the use of these immunomodulatory therapies?
Yeah, so that's the reason we published this paper on dengue. But the way I see it is, it's not a disease condition by itself, the cytokine storm or a secondary HLH. It is like, see, someone with, for example, pneumococcal pneumonia, he can develop respiratory distress, he can get pneumonia, he can get ARDS, he can get ventilated. You will not say that what is the evidence for a pneumococcal ARDS to get ventilated, correct? I mean, we have a treatment mentioned for ARDS, we treat. We have a treatment mentioned for hypotensive shock and we treat with the noradrenaline, with adrenaline, whatever. So similarly, the immune distress is something, now for example, there's established therapy mentioned for HLH, cytokine storm. What I feel is you need to identify the clinical situation and treat the way you treat respiratory distress and shock, that, okay, the immune dysregulation is severe enough, it needs some amount of support to regulate itself. Okay, so rather than looking at every disease specific, every condition, looking at how is the immune distress? Is it going to regulate on its own or is it progressive? Based on that, we make that judgment, because the treatment for HLH, secondary HLH, is established therapy.
So apart from
thank you, sir.
physiological doses of steroid, what is your next choice?
Sorry?
What is your next choice in this patient, refractory sepsis patient?
I think what we do, like I said, a lot of this we use anakinra as our first choice, because its safety profile is much better than steroids. It's much more shorter acting. We add steroids later if we feel that the patient is still not responding to anakinra. So we use anakinra as our first choice.
Thank you, sir. Thank you for a wonderful session.
Thank you, sir. I request our chairperson, please felicitate our speaker with memento. And I request our chairpersons, please collect their memento from the memento podium. Now, I request all the speakers and chairperson, please stick the time. Now move to the next session. I invite Dr. Ajay Mohan Sahai sir, Dr. Smith Srivastava sir, Dr. Firoz Memon, Dr. Murli Badwani, Dr. S.P. Sahu, and Dr. Raka Shivhare to chair the session.
The next session on cardiac dysfunction in ICU shall be presented by Dr. Anirban Home Chaudhary. He's a director, professor, and head of Department Critical Care Medicine of Safdarjung Hospital, New Delhi. He has almost 95 publications to his name. He's an author of multiple books. He is also an examiner for AIMS NB. He is on expert committee of National Medical Commission, National Board of Examination, and has multiple awards to his name.
Over to chairpersons.
I think for the sake of time, we start with the lectures.
Thank you, sir. At the very onset, I wish to thank Dr. Vishal and the entire organizing team of Criticon Raipur 2025 for inviting me and giving me this opportunity. It is splendid to see this house gathering on a holiday. And for the next 20 minutes, I will see it's a very huge topic, cardiac dysfunction in an ICU. Whenever we talk about sudden cardiac dysfunction, the image that flashes before the eyes is of Shefali Zariawala or Michael Madsen, who suddenly died following a heart attack. Nobody could do anything. But how important is this cardiac dysfunction in ICU? This also needs to be known. I bring to you my greetings from Safdarjung Hospital, Vardhaman Mahavir Medical College, the largest central government institute of the country. So why cardiac dysfunction is so important in the ICU? If you ask me, I will enumerate this according to my category, that if you don't recognize the cardiac dysfunction, the presence of cardiac dysfunction, then shock resuscitation becomes blind and potentially harmful. Because a lot of time, the basis of your shock resuscitation are the fluids and the vasopressors. So if you don't recognize cardiac dysfunction or its presence early enough, then you go to the form of fluid overload and the patient can go into failure. And similarly with vasopressors, if you don't recognize cardiac dysfunction, you put the patient at risk of arrhythmias and the patient may collapse and eventually die. Next is that, therefore, to give a tailored therapy with fluids, vasopressors, and vasodilators to reduce the afterload if it is a failure. So this is very important. The knowledge is important. And it changes both immediate management and long-term outcomes. And understanding the status also helps us to optimize the therapy. Cardiac dysfunction is a systemic amplifier of critical illness. So whatever outcome was supposed to happen, that can happen much earlier in a patient with cardiac disease. So this is a fairly common problem. It may vary from 1 in 3 to 1 in 5 patients with some degree of cardiac dysfunction. And half of them, it may be severe enough that if they are not intervened early enough, that can lead to be an additional cause of mortality. The difficult thing in ICU, when we consider mortality, we consider all-cause mortality. So it is sometimes difficult to figure out which of the patients had actually because of cardiac dysfunction with mild or moderate dysfunction. But with severe dysfunction, it is much easier. So mostly the kind of cardiac dysfunction that are witnessed in ICU patients is because of sick or sepsis-induced cardiomyopathy. There is a good number of right ventricular dysfunction, particularly in the backdrop of pulmonary embolism. There can be cardiogenic shock in patients undergoing cardiac surgery post-infarction. And some, of course, Takotsubo is a known entity, but it occurs less frequently, more common in women, and all other causes can be combined for the rest. And the evolution of the good thing is that with the evolution of point of care echo and multimodal monitoring, we have been able to recognize much of these conditions much earlier than what it used to be recognized before. And we have been able to guide individualized therapy because the therapy undergoes change. Let us see a prototype case. A 56-year-old male with pneumonia in septic shock, despite norepinephrine adequate fluids, lactate remains elevated. 2D echo shows dilated LV with ejection fraction of 30%, global hypokinesia, normal coronary perfusion. BNP shows 5,000, troponin mildly elevated. So how to proceed? Now, very important to remember that whenever a patient is having cardiac dysfunction, we need to identify at least the phenotypes, because the phenotypes are variable and the individualization of therapy is according to the phenotypes. One phenotype can be septic myocardial depression, which is transient, reversible, often accompanied by low SVR, because sepsis is a vasoplegic state, so everything is dilated, so SVR is reduced. So here the management focuses on source control and optimized perfusion. Another can be a mixed state, mixed shock, where there is coexistence of both cardiogenic component and distributive shock. So they require careful balance of the fluids, vasopressors and inotropes, because we also need to improve the stroke volume in these patients. Another can be pure cardiogenic shock, that is like post-infarction, post-surgery, post-myocarditis. These patients may require an early mechanical circulatory support, MCS. So this is again a different phenotype. Another phenotype can be RV failure dominant shock, which is associated with high PEEP on the ventilator, so the right ventricular dysfunction. So these patients will primarily require preload optimization, pulmonary vasodilators. So to prevent the back pressure effects. So if we are able to identify the phenotype, we will be able also to tailor therapy according to the phenotype. Now this helps. Is it possible to approach it stepwise? Immediately when we assess, first, as usual, we go for the ABC and perfusion, keep as SpO2 target, consider either HFNC or intubation if there is increased work of breathing, reduce fall in the PF ratio or altered ventilation. Look for the perfusion adequacy by mapping the skin temperature, looking into the capillary refill time of more than 3 seconds, mentation, urine output and lactate. If it looks like a refractory shock, then you have to confirm it. How to confirm it? By looking into the map. If the map is still below 65, even after fluid challenge, and norepinephrine exceeding a dose of 0.2 mics per kg per minute, unless there are contraindications of giving this much of fluid challenge, etc., you label it as a refractory shock. When you refractory look at, then you look for some of the red flags. So one red flag is that cold, clammy extremities with pulmonary edema. So going towards cardiogenic. If you see ST changes, focal wall motion abnormality on your echo, go for a proper ischemia workup because it is going towards cardiogenic. Jugular venous distension, clear lungs, high PEEP, RV dilatation, it is going towards RV failure called pulmonary. So if you approach it stepwise, you will be able to clearly see that which part of the heart is at fault and where is it leading to. In point of care also it is same. If you see the ejection fraction end diastolic dilatation, if there is global hypokinesia, LVOT, VTI less than 16, then it suggests low stroke volume. So the cardiac component is there. So you will have to think in the back of mind that you need to improve with the inotropes. RV size, or if you see that no septal D-shaped, then it argues against dominant RV pressure overload if you are not getting the flat septum, etc. The IVC plethora versus collapsible, depending, so it will show whether it is volume responsive or non-responsive, etc. It is very important also to realize that responsiveness and tolerance are different. A person may be responsive to volume, but may not be tolerant. There will be organ dysfunction if you give the volume. So these are the finer things. The valves and the pericardium should exclude tamponade or severe valvular lesions. So now let's for the diagnosis. Whenever you get such a diagnosis, that is sepsis-induced cardiomyopathy, you will have to say that this is a reversible, there is global LV depression from sepsis, and there is mitochondrial dysfunction. So all of this, the source control becomes so important that if it can be done early, all of things changes very fascinating manner. And the patient recovers like he had never ever had this sepsis-induced cardiomyopathy. But you have to keep in differential type 2 MI from supply-demand mismatch. So you look for persistent troponin rise along with ischemic changes in the ECG. So that you will have to look for. If you get a echo pattern in the apical or basal variants, you have to keep aside, exclude Takotsubo. Fulminant myocarditis, if the patient is having fever with high troponin arrhythmia, they may require a cardiac MRI also, there are myocarditis. And mixed shock, as you know, which has components of both septic shock and cardiogenic shock. So you will have to manage your fluids and inotropes in a properly judicious manner. So what should be our resuscitation targets? Initially, you keep a map between 65 to 70. Now almost it is always certain that it is no good in keeping a higher map, although some people advocate that if the patient is hypertensive or having chronic kidney disease, to keep a slightly higher map, maybe 70, 75. But most of the studies starting from sepsis spam till date have found not much of benefit. Perfusion, you target a lactate to be cleared or reduced by 20% every 2 to 4 hours, and target the capillary refill time to come below 3 seconds. If it was higher at the baseline, warm extremities, maintain normalizing, and try keeping a urine output of more than 0.5 ml per kg per hour. Echo, if the VTI you target more than 18 to 20 or a 10 to 15% rise from the baseline after the therapy. So at least you know that you are proceeding your treatment in the right direction. SCVO2 more than 70%, or if you are looking into the PCO2 gap, target a PCO2 gap of less than 6 millimeter mercury. Take the venous sample, check the PCO2, take the arterial sample, see the gap. Very simple. These things can be done by non-intensivists also. So if you go stepwise, the same things I will elaborating to make things more simpler. In the step 1, fluids, only if responsive or tolerated. IV is small, collapsible, VTI variation more than 50%, give 50 ml of balanced crystalloid over 10 to 15 minutes with an echo, VTI, and check for the VTI. Stop fluids if there is rising JVP, you get new B lines on ultrasound of the lungs, worsening oxygenation. If the VTI fails to rise more than 10% or RV starts dilating, then the right side of the heart needs to be seen. Second, step 2, vasopressor backbone. Titrate norepinephrine to target your MAP. Commonly it is a wide range, 0.05 to 0.5 mics per kg per minute. If the dose requirement increases to 0.2 or 0.25 mics per kg per minute, you add vasopressin. Vasopressin, everyone it is a fixed dose, 0.03 to 0.04. So when people say that I'm titrating, there's nothing to titrate. It is not on basis of per kg. Either 2.4 ml per hour or 1.8 ml per hour. Consider epinephrine only if profound hypotension with low cardiac output and the combined pressure therapy. You have to watch for lactate and arrhythmias, both of which can increase if you start epinephrine. Step 3, if it is a low cardiac output associated with sepsis-induced cardiomyopathy, at that time you start dobutamine once the pressures are settled. Again, the dose is a little lesser wide, but it is still wide, 2.5 to 5 mics per kg per minute. Titrate it and bring it down while monitoring for the heart rate, ectopic MAP and VTI. We try to get a desired response within 2 hours of increasing in VTI by 10 to 15%, SCVO2 to increase more than 70% with reduction in lactate, etc. And a stable MAP if arrhythmias or if there is, or if a MAP drops then you will have to again titrate your dobutamine. So in that case, you reduce dose, reinforced with any or add vasopressin. Milrinone we rarely use nowadays. It was used once upon a time very extensively, particularly in post-cardiac surgical patients. But in other patients, it's not making much of a difference. Levosimendan, likewise, it was used a lot. But now we also use in selective cases. But we can skip the boluses. Boluses we don't give. And we can give a continuous of 0.05 to 0.1 mics per kg per minute over 24 hours. But be careful enough to see the blood pressure can fall suddenly, too much. Step 4 is the heart rate control, because heart rate is very, because if a patient is having cardiac patient, you can't keep a patient on a heart rate. And if a patient on sepsis, at times that is the only sign which is visible at that monitor at that point about that patient is becoming worse or improving. So if the heart rate is more than a 110 to 120 with good BP control, and then we can consider for ultra short acting beta blocker, esmolol is the choice. And some people give metoprolol. There is not much of evidence, but it works, as they say. So only after ensuring you have to see that the cardiac output is adequate. So you will go for a VTI on your point of care, and if you see that your SCVO2 is more than 70, lactates are also rising, and only when they're done, then you should go, otherwise be careful. And stop if the MAP falls or the VTI falls. So what to recheck and when? At 30 to 60 minutes after any change, fluids, vasopressor, inotropes, you can go for a mini echo, see the VTI, see the ejection fraction trend, see the right side of the heart septal shape, etc. Numbers, you look for the MAP, heart rate, you look for the rhythm, SCVO2, lactate, urine output, and the capillary refill time. Lungs, you go for auscultation, and also you can go for ultrasound to look for the B lines or if there is an effusion. Every 2 to 4 hours until stable, you can look for lactate, CRT, urine output, and titrate your medications accordingly. And daily, or if the patient is unstable sooner, go for a full echo to document trajectory in the sepsis-induced cardiomyopathy, because you should expect an improvement by day 3 to day 5. and near normal by day 2, day 7. If that is not happening, you have to be sure that you are not missing out anything. So whenever the patient is improving, you have to follow a winning strategy where you win the inotrope first. If VTI and SCVO2 are stable, lactate falling, you taper dobutamine first, 1 to 2.5 mg per kg every 2 to 4 hours. Keep watching for the MAP and cardiac output surrogates. Next, you win your vasopressor. Once off inotropes, then you target MAP consistently with improving perfusion. Reduce NOR-AP by 0.02 to 0.05. We usually write with a single strength dilution, you start with 0.3 ml per hour, like that we tell our residents. Maintain euvolemia, start diuresis if congested and hemodynamically stable. And what are the important things when things don't add up, or pivotal points where you see that you are not getting results, no improvement in VTI, SCVO2, lactate, despite giving inotrope. So you reassess the preload, whether the patient is underloaded or overloaded. If there is any hidden bleeding occurring somewhere, occult ischemia, so you report the ECG, do a proper 12 lead, get it read once again by an expert. Consider cardiology, consult with coronary imaging if there are other changes, and look for the RV function more accurately if there is any tamponade is developing, or if there is any coexisting valvular diseases. So a thorough, more microscopic or more careful magnified examination is necessary. Consider mixed shock from ongoing vasoplegia with myocardial dysfunction. So you add hydrocortisone, you can go up to that is 50 mics, sorry, it is milligram, 50 mics if that is refractory vasoplegia. And escalating arrhythmias on dobutamine or AP, you have to think about the electrolytes, look for potassium and magnesium, reduce catecholamines because they will sensitize the myocardium to the effects. So, and consider amiodarone if there are no other contraindications. If there is worsening of the RV size or hypoxia with high PEEP, you lower the PEEP if it is feasible, evaluate for PE, and consider inhaled pulmonary vasodilator. Now, there are certain common pitfalls like over resuscitation. We may give too much of fluids, too much of other vasopressors. So you have to, that can worsen pulmonary edema and the LV compliance. So you have to fix it by going up VTI and guided boluses. And if the patient is not responding, stop early. Chasing BP with vasopressors like cardiac output, while the cardiac output remains low. Again, you have to check your VTI, SCVO2 and add and titrate the inotrope in patients with low cardiac output. Mislabeling sepsis-induced cardiomyopathy as acute coronary syndrome. That is common if there is troponin leak. And you see that troponin and you diagnose that no, but in spite of there are no ischemic changes, you still label. So that is wrong. So you will have to look for focal ischemic changes and see the trend in troponin rather than single value. Ignoring right ventricular function when PEEP is high or oxygenation worsens. So you will have to focus your attention on the RV and reduce the PEEP, consider vasodilators. If tachycardia is left unchecked, it worsens the supply-demand ratio. So there will be problem. So you will have to fix it with analgesia or give a good sedation, careful beta blockade after confirming adequacy of the cardiac output. So we usually expect the ejection fraction to normalize by day 10, earlier in large number of patients too. And prior to ICU discharge, you should always do a proper echo and before sending them to ward. And if the EF is still less than 50%, then plan a cardiology follow-up in the next course. And counsel on post-ICU cardiac symptoms like exercise tolerance, palpitation, arrange for rehab. That, of course, cardiologist will do it. So to summarize, you will have to look for the phenotype. If it is a septic myocardial infarction, there are certain typical features like low ejection fraction, high cardiac index, low SVR. Focus should be vasopressor and inotrope balance. If it is a mixed shock, again, your focus should be guided fluid plus vasopressor titration. If it is a pure cardiogenic shock, inotropes, and also you can require a mechanical circulatory device. RV failure, you have to reduce PEEP and give RV specific support. So my take home message is that cardiac dysfunction in ICU is actually multifactorial. Sepsis, catecholamines, and ventilatory mechanics that we said all interact dynamically. So the process doesn't remain static. Every time you may get a new finding over a span of time. Bedside echocardiography is indispensable for the diagnosis and ongoing assessment. Biomarkers provide context, but they are not for standalone diagnosis. A single isolated value of proBNP does not mean anything. Management hinges on perfusion optimization, fluid balance, and judicious vasoinotrope use. Reversibility distinguishes sepsis-induced dysfunction from structural heart disease. Don't forget to exclude them. And early recognition and timely mechanical support can salvage otherwise fatal cases. Thank you very much for your patient listening.
Yeah. Thank you, sir, for finishing on time. I have two comments. One is that one should not forget dynamic LVOT obstruction that comes with use of excessive inotropes. And that also sometimes results in renal impairment, renal impaired perfusion, and then it, we often miss it. The blood pressure is down, and we try to increase the inotropes further and still worsen the condition where it should be down. Other thing is that in post-tubercular patients or post-cardiac surgery patients, there are chances that even a 10 ml or 20 ml or 30 ml of tamponade can cause a localized tamponade, particularly in oblique sinus, compress the LA.
Yeah, this
and
used to
cause-
be of much concern earlier, but now we are become so confident with point of care and when the bedside echo is available. So we are able to detect this much earlier. So these are usually not frequent misses, but yes, you are right. Earlier, these were frequent misses.
So, and the question is, there is no role of Swan-Gaines catheter now?
No, there is no role of Swan-Gaines catheter now.
Thank you, sir, for doing such an academic justice to wise topic, a very wide topic. And what you have done, summarizing in the phenotypes, that gives us a very good message how to go ahead. I have just one question for a resource setting person, people in a remote area. What are the ECG signs to differentiate a cardiogenic shock versus, because there are so many signs which you say that even in non-cardiac patients you get confused with the ECG changes.
With ECG signs, you cannot comment anywhere in the world, low setting, intermediate setting, high setting about cardiogenic shock. Shock cannot be told by ECG is only on whether the patient is having ischemia or not. That much you can. If you have to tell shock, it should satisfy your shock index. You have to see the contraction. You need to do an echo and see what is the ejection fraction. You have to see what is the wall motion. So your cardiac index has to be 2.2. So it is not possible to look into the ECG and say that this patient is in cardiogenic shock.
Yeah, Deepesh.
Mike, please. Open the mic, Dr. Dipesh.
See, I get your question that there is some element of, I had shown you that the mixed shock is nothing but a combination of distributive and cardiogenic shock. This patient has sepsis and the myocardium is compromised, septic cardiomyopathy is there. Alongside, there is also cardiogenic shock element. So it is very important to realize that these patients, you have to start inotropes early. So you have to, don't get started because if they will, stroke volume will get compromised. Even if you see the patient is achieving a mean pressure of, say, 120 by 80, the patient's perfusion will not get because the cardiac, so you will have to start dobutamine early once the volume settles down. And look for the lactate. If the lactate is falling at the rate of 20% 2 to 3 hours, you are on the right track. So, first and foremost is that you start inotrope early. Second and important is that stop giving excessive fluid because of these patients. They are in already vasodilated state because of septic shock and because of the element of cardiogenic shock. They cannot hold more fluid. So you will have to stop giving too much of fluids early. And the third important thing is that whenever you are giving an epinephrine, see that they are the myocardium is sensitized. So they can have arrhythmias. So you have to detect arrhythmias at the earliest. If you follow these three, all your mixed shock patients will get some amount of direction. So it will improve.
Hello. Good afternoon, sir.
Sir, in refractory septic shock, where a tachycardia is very detrimental to at least maintain the optimal cardiac output. So at that point of time, how
See,
to whether to
tachycardia.
choose ivabradine or low dose esmolol?
See,
Can you brief?
Ivabradine you can give. There is no harm in giving.
Yeah,
We
yeah.
all give Ivabradine. But point is that you have to know that if a patient is having a pre-existing or a continuous cardiac disease, as he questioned,
Yeah.
then a high
That's why
tac
we are limiting to the septic,
only
septic
septic shock.
myocardium. Yeah,
Only
yeah,
septic shock, then you can. Only you
yeah.
think that, see, sometimes that tachycardia, which at times may be the only indication of your patient
Although we are
worsening or
having, although
deteriorating,
we are
that's
having
get
iris
blocked.
trial, although we are having iris trial where the
We are
decrease in the
giving, we are
10%
giving, we
iris
are
rate.
giving. We can give Ivabradine. I
Then
think that
what
is.
about low dose esmolol, sir?
Low dose esmolol also we are using. Low dose esmolol has been used for longer time than Ivabradine. Ivabradine effect is for a longer duration.
Yeah.
So that becomes the problem. In esmolol thing, it is quick, it is ultra short acting. But I don't use metoprolol. That is something I want to avoid.
Oh, thank you, sir.
Hello? Hello, sir. Here. Sir. Dr. Neeraj here. So sorry. Sir, very nice overview. We had one patient in the ICU last week. He was an elderly male post-op IT femur operated post-op day 4. So in the morning he had a hypotension with no any ECG changes as such. Echo was also normal. LV was fine, no RV dysfunction. Later that afternoon he had worsening hypotension, had a cardiac arrest and got intubated and then was on triple support. And there was no any obvious focus of any sepsis or that his PCT was mildly elevated and no as such focus. Only background was of MDS and aplastic anemia. So and no echo changes again even after post CPR. Echo was fine. So in this context would have been CAG would have been feasible to.
See, this happens most commonly with if there is massive P. Well, what is the thing? So you have to see what was how much was the drop in saturation at the time you had.
Okay.
So if the patient has a hemodynamic collapse, it is massive P.
But the PE features was not there in the echo.
Echo, it was not
No,
there.
it was not there. The echo was normal
Okay.
also.
So
Post
if
CPR.
echo is normal, there is no
Even
P.
after post CPR, the echo was normal.
So the patient went into straightforward hypotension followed by arrest.
Yeah.
So
we had done CAG.
So what was the EF and what was the movement?
We have 55-60%, no TAPC was good, no other dysfunction.
You had
Everything
seen
was-
the TAPC?
Yes, I have seen. Post arrest also I have seen the TAPC.
So that's a complicated. It is not possible to give a quick diagnosis just listening to these 2-3 things. It is important to see and how things were. Because sudden cardiac, that means there were some. Are you sure there was no valvular structural defects?
No, sir. No underlying also there was no history of any IHD or any.
We need to close the session.
Okay. Thank you, sir.
Thank you, sir. I think personal question,
Thank you,
please
thank you.
discuss personally. I request our chairperson, please felicitate our speaker with the memento. I again request all the chairperson and speakers, please stick to the time.
There has been a slight
I think
change.
I have stick to the time. Thank you. Thank you.
Yes, give a big applause to the speaker.
There has been a slight change in the chronology of sessions. So the next topic is on focus in critical care and it shall be presented by Dr. Deepak Govil sir. He is Director of Liver Transplant and Hepatology Critical Care at Medanta, Delhi. He is a teacher and examiner at National Board of Examinations and Indian Society of Critical Care Medicine. Sir has been past president of Indian Society of Critical Care Medicine. He has multiple awards, papers, and editorials to his name.
I request chairpersons, please collect their mementos from the memento podium. And I request Dr. Vishal and Dr. Santosh, give a memento to the chairpersons. To the next session, to chair the next session, I invite Dr. Sonal Vajpayee, Dr. R.K. Patel, Dr. Arif Memon sir, please join the dais as a chairperson. I request Dr. Arif Memon sir, please join the dais also. Dr. R.K. Patel sir. Over to chairperson.
Respected seniors and dear friends, good morning. First of all, I would like to thank Dr. Vishal for inviting me here and giving me this opportunity. So in next, rather than 20 minutes, in 15 minutes, I'll try to explain the use of POCUS in critical care and can keep another 5 minutes for question answers. So how we define POCUS? We are listening this word since in the morning. We are having a nice panel discussion on the use of POCUS in ACLS and the emergency department. NEJM has defined the POCUS as a point of care ultrasonography, that is ultrasonography performed and interpreted by the clinician, not by the radiologist, by the clinician at the bedside. It does not mean we want to replace the echocardiographist or the ultrasonologist from the ICU, but the thing is here we want a quick answer of the quick problems like patient is having dyspnea, patient is having hypoxemia, patient is having shock. What is the cause of that? So we want a quick answer to correct that physiology. So gradually the ultrasound has becoming the ultrasound stethoscope. Like we use a stethoscope in the clinic practice, same way we are using ultrasound everywhere. Another paper which was published and they defined as a deep impact of ultrasound in intensive care unit, and they said it's a ICU sound protocol by using ultrasound in each and every patient while assessing the initial assessment, and while whenever there is a change in physiology, maybe it's a tachycardia, maybe it's a decreased saturation, maybe it's a decrease in blood pressure or any change in the physiology, so you use ultrasound. And what they have said that in transthoracic ultrasound examination can be used to diagnose a multitude of abnormalities. Helpful modality, it is a helpful modality. Admitting diagnosis in 26% of the patient led to change in the medical therapy in 18% of the patient and prompted invasive procedure in 22% of the patient. So in close to 25% of the patient, we are able to change the admitting diagnosis and to modulate the therapies. Another paper which was published again in NEJM recently, it says that POCUS facilitated the confirmation of suspected clinical diagnosis in up to 50% of the cases and supported a change in the initial diagnosis in 23% of the cases. Just imagine, 23% of the cases which were diagnosed something else were changed, the diagnosis was changed because of the POCUS, and in 50% of the patient, half of the ICU patient, it helped in giving the right diagnosis. So it becomes an invaluable tool in our hand. How we can use POCUS in ICU? So there are multiple usage are there. We can use to identify endotracheal intubation, to identify Ryle's tube insertion, to identify difficult anatomy, to do tracheostomy that leads to the use in the airway, in the breathing. We can use it to identify pneumothorax. We can use it to identify atelectasis, pulmonary edema, differentiating different type of pulmonary edema, cardiogenic or could be ARDS, and identifying the consolidation. In circulation, we can identify the different type of shock. It could be a hypovolemic shock, could be a vasodilatation, could be a pericardial effusion. So all those things can be differentiated very easily with the use of ultrasound. Then we can use ultrasound in identifying the hemorrhagic shock as well, whether patient in trauma is having hemorrhagic shock or not. And certainly we can taking help of the ultrasound to identify those patients who are fluid responsive and who are not fluid responsive in the ICU. Certainly we can help it, its help by helping in the different type of procedures where we can have almost zero complication while doing procedures with the help of ultrasound. So this was the sorry, it's stuck up. Can you check what happened?
Can you hold the time? Dr. Ujjwala, can you hold the time?
Can you hold the timer, please?
I request Dr. Sonal to initiate some discussion with the audience regarding the topic. We have some more experts who can respond to that on the same topic?
Really sorry
Okay,
for this
sure.
inconvenience and the interruption. So now we have restarted. So till now I showed the single organ focus. Now if we integrate the different organ like airway, breathing, circulation into one, and then we can have a multi-organ focus. So this multi-organ focus, as you can see here, it can differentiate the cause of respiratory failure by looking at the lung aeration, by looking at the effect of the proning, looking at the hypovolemia, can be used for assessment of shock. It can identify the source of bleeding in a trauma patient, and it can be used for assessment of the sepsis. And of course, by using VAXes, we can take it help in the renal failure patient as well. So I'll just distinguish all these features in a case. So there was a 54-year-old male, 70 kg, diabetic, smoker, alcoholic, having high-grade fever with chills for 5 days, upper abdominal pain was there. He is having temperature, tachycardia, low blood pressure, and high respiratory rate. His urine output decreased since last night. Already received 3 liter of normal saline prior to referral to the ICU in emergency department. His SpO2 is borderline 94% on 4 liter of oxygen. So he is already in the respiratory failure. How to proceed? There is no doubt this patient is having severe sepsis and septic shock. Tachycardia is there, temperature is there, shock is there. So we all know the management of severe sepsis as per the surviving sepsis campaign guidelines. Initial resuscitation, already received 3 liter of the fluid, and patient is having still hypotension. So we do a focused ultrasound assessment by looking at the lungs, looking at the heart, and looking at the IVC. So what we find, the lungs are dry, A pattern is there, heart is empty, briskly contracting, and IVC is having some variation. So it means that patient may require some fluid. So patient was given another 2 liter of normal saline, but he continues to be hypotensive. CVP line was placed, mixed venous saturation is quite low, 45%. His lactates are little high, 5 millimole per liter, and he is having base deficit of -8. So what to do now? The big thing, whether to give more fluid, whether to give more vasopressors, whether to give inotropes, we don't know what is happening. As we have already heard the previous talk about the myocardial dysfunction in the sepsis. So nobody knows whether this patient is vasodilated, that is why he is in shock, or some cardiac dysfunction is happening. So look at the endpoint of the resuscitation, CVP, MAP, or we look at the fluid intolerance in the form of desaturation, crepitation, worsening of X-ray chest. They all come little late. So by the time the already patient has already deteriorated. So we repeated the ultrasound examination. At this point of time, you can see without doing any measurement, his heart is not contracting very well. So this patient is having some sort of cardiac dysfunction because of the shock, because of the sepsis. His lungs are coming wet, and his IVC is not having any variability. So now at this point we know if we give further fluid to this patient, this is going to be harmful for the patient. So appropriate vasopressors and inotropes were started at this point of the time. Patient is having wet lung, hypokinetic heart, and distended IVC. So no more fluid. The judicious use of inotrope and vasopressor were started. Now looking at the diagnosis, once the shock has been corrected, then we look for the diagnosis. What is the cause of this septic shock? So with ultrasound, we could identify a big liver abscess sitting right there in the liver. So this abscess was drained with the ultrasound guidance. Patient continued to deteriorate. Worsening respiratory parameters were there. Patient was intubated, put on the assist control mechanical ventilation with high FiO2 and high PEEP. Bilateral chest X-ray shows infiltrate. So what could be the worsening of the respiratory parameter after the adequate source control? We have to see. We have already done the source control. Still my patient is worsening. What could be the cause? Could be CHF, secondary to LV dysfunction. His heart was not functioning well. Could be gone into ARDS. So we again repeated the ultrasound of the lung, heart, and IVC. As you can see here in the ultrasound finding, you can see there are patchy distribution of a scattered B line. Anterior subpleural consolidation was there, which is very well suggestive of ARDS. But look at the heart. Heart has improved. His ejection fraction has improved. Heart is contracting briskly. So the diagnosis was made of ARDS. Patient was managed with a lung protective ventilation strategy. In view of refractory hypoxemia, lung ultrasound was repeated. And as you can see, lung is totally hepatized, what we call as a hepatization of the lung because of the consolidation. So in view of refractory hypoxemia, predominant basal consolidation and collapse of the lung on ultrasound, patient was proned at this point of time. And you can see here with the proning what happened, some aeration has started taking place in the lungs. As you can see here, some aeration has started taking place. Here the B lines are started appearing and the pleural surface has started coming up. So after 48 hours of the proning sessions, multiple proning sessions, patient started showing some improvement. His FiO2 decreased and vasopressor requirement also reduced. Organ functions were improving. Patient was supine and patient tolerated well this supine position. On day 5, patient again deteriorated. So patient started desaturating, became hypotensive. So what could be the cause? It could be a new hit, could be because of the lines induced, or could be a ventilator associated pneumonia again, could be LV dysfunction, could be pulmonary embolism, could be any other cause. So to differentiate, we repeated the ultrasound examination. And in this ultrasound examination, you can see there is a beautiful lung point which indicates the pneumothorax. His veins are compressible, so PE is ruled out. You can see the heart, briskly contractile heart, no RV, RA distinct dilatation. So practically with the absence of the DVT and the good contractile heart, no change in the RA, RV, the pulmonary embolism is almost ruled out. His IVC is showing variability. So diagnosis of pneumothorax was made in this case at this point of time. ICD was inserted and real-time visualization of resolution of pneumothorax was done. Patient saturation and hemodynamics improved. So eventually the patient underwent a percutaneous tracheostomy under ultrasound guidance on the day 8, gradually weaned off the ventilator, decannulated on day 14, and discharged in stable condition on day 18 from the hospital. So coming back to the role of point of care ultrasound, it elucidates the etiology of deranged physiology, why my physiology is deranging, what is happening to the patient. You can identify, you can see that real-time insight into the response to the resuscitation. You are giving resuscitation and looking the response immediately. You are giving fluid bolus, looking at the heart, looking at the lungs, looking at the IVC. You can see the response, whether your patient is responding to that fluid boluses or not. You can do re-evaluation any given point of time very easily at the bedside, and you can titrate and tailor-made treatment according to the needs of the patient. So finally, POCUS is a limited examination. It is not a replacement to the clinical examination. It is extension to the knowledge of clinical state and physical examination. I have seen this practice in many young budding intensivists, that they feel that they have done POCUS, now there is no need of clinical examination. I always teach them it is not a replacement of clinical examination. It is an added armamentarium in our knowledge. It mainly, in ICU, it is mainly qualitative, semi-quantitative, and repeated assessment. What radiologists do, what echocardiography do, they do a quantitative examination. Here we do a qualitative examination. Our aim is not to identify whether the EF is 62% or 58%. It doesn't matter to me. My aim is to identify whether the patient is having cardiogenic shock or a distributive type of shock. It may appear complex. You all have seen the ultrasound machine, so many knobs, so many functions. It may appear complex the first sight, but simply requires a change in the thinking. Once the process has been learned, a step-by-step use will make it as a routine. Sometimes it is obvious, sometimes it is not. When it is not obvious, please ask for the help. Thank you very much.
Thank you, sir, for this nice lecture, sir. And ultrasound has changed the practices very well, sir. And sir, one question is, sir, what is the role of TCD, transcranial Doppler monitor ultrasound?
So the TCD
for
again,
focus, sir?
you can have identify TCD in two ways. One TCD, dedicated TCD machines done by the neurologist at the bed in the labs or bedside, and another use of TCD used by the intensivist in the ICU. We are using TCD very easily and very well in most of the patients who are having an encephalopathy or those patients who are at the verge of coning. TCD is very helpful in identifying that the cerebral edema in this patient is worsening. But if you want to identify the exact different vessels and want to quantify the flows in that, then you should have a dedicated TCD machine.
Yes.
But in ICU, most of the patient, we can work with our routine machines by doing the TCD bedside and prognostication and identifying, like how many times you can send the patient to CT scan. Maybe once a day, twice a day. It is very difficult. Patient of hepatic encephalopathy or any encephalopathy showing some sign of deterioration, at that point of time, shifting that patient to CT scan. TCD is very easy to perform. You can identify, you can compare the previous TCD. The main thing in POCUS is comparison with the previous examination. Standalone examination has got not that great. So repeated examination, compare the value of TCD of the previous, you can see now the flow pattern is changing. You know something wrong is happening.
Similarly, sir, ONSD is also
ONSD also is there.
helpful
Yeah,
for that.
yeah.
Thank you, sir.
Thank you very much.
I request the chairpersons to felicitate Govil sir. And I request Dr. Imran to felicitate the chairpersons at the Momento counter. The next topic is by Dr. Manoj Goel sir on pneumonia in immunocompromised host. He is Director and Head of Department of Pulmonology, Critical Care Medicine and Sleep Medicine at Fortis Hospital, Gurugram. Sir is also a member of Expert Committee on Indian Guidelines on Bronchoscopy, EBUS bronchoscopy, thoracoscopy. The chairpersons for this session are Dr. Rangnath, Dr. Akanksha Sharda, Dr. Varsha Vishwanath, Dr. R.S. Bisen, and Dr. R.K. Patel, sir. Dr. Vivekan Pillai, Dr. R.K. Panda, Dr. Amit Asati, and Dr. Roshan Singh Rathod. यही है. Dr. Vivekan Pillai, sir, Dr. R.K. Panda, sir, Dr. Amit Asati, and Dr. Roshan Singh Rathod.
Can we start with the permission,
yes,
Chairperson?
please.
Thank you
Definitely,
so
sir.
much. So thank you, Dr. Vishal, for inviting me here. It's a great time I'm having here. And also thank you for allotting me a topic which is very close to my heart, that is pneumonia in immunocompromised host. Majority of these patients are referred to us from the oncology units and the transplant units. And the greatest challenge in these patients is to diagnose the specific etiology of the pneumonia. And that is going to be the focus of my talk today. And also, I'll highlight the importance of the bronchoscopy in the as a diagnostic tool in this group of patients. So there are general considerations, which we tend to apply to, this group of patients. We have to remember that multiple simultaneous infectious processes are common in these groups of patients. For example, there could be dual infection with pneumocystis jirovecii and cytomegalovirus infection. There may be superimposition of other processes. For example, the patient may have drug toxicity or organizing pneumonia or radiation pneumonitis. And there could be sequential infection. The patient may present to us viral infection, maybe influenza A, influenza B, or H1N1. And this would be followed by bacterial infection and fungal infection. This is, again, not very uncommon as a matter of fact. The early diagnosis is extremely important. Therefore, we must do an early CT scan, especially HR CT scan of high quality. And we must go for early bronchoscopy in this patient and try and do a bronchoscopic biopsies if possible, which may be a little difficult in critically ill patients. The initiation of empirical therapy is also extremely important while we are awaiting the microbiological report samples. And the empirical therapy must be started based on available data. We have to look into the prior microbiological history of the patient. We look into the previous course of antimicrobial agents and also do the clinical radiological correlation. Many times we are able to diagnose this patient based on their previous clinical records because these patients tend to keep coming to us repeatedly. It's also important to possibly reduce the overall level of immunosuppression in this patient because this could be as important as antimicrobial therapy in the ultimate successful treatment, and possibly keeping them a smaller dose of steroids would be a good idea till the patient passes through this storm. Another important aspect is to interpret the lab results cautiously. Please take into account the clinical context of each patient. For example, detection of galactomannan or CM in bronchial lavage fluid do not necessarily represent invasive disease. And please do not forget that these patients may be having disseminated disease, including involvement of the central nervous system, for example, in Aspergillus, mycobacterium, nocardial infections. A variety of pathogens may be responsible for the infection of these immunocompromised hosts. The commonest would be the bacterial infection, which may become required, where the focus may be the Streptococcus pneumoniae or H. influenzae, or atypical infections like Mycoplasma, Legionella, Chlamydia, etc. And there could be hospital-acquired pneumonia, where the focus of infection might be the Klebsiella, Sternotrophomonas, and Burkholderia. But this kind of distinction between the community-acquired pneumonia and the hospital-acquired pneumonia is little blurred in these patients. Majority of these patients would come to us with multi-drug resistant gram-negative and gram-positive bacterial infections. As for the fungi concerned, three most important causes of fungal pulmonary infections are Pneumocystis jirovecii, or previously known as Pneumocystis carinii, Aspergillus, and Cryptococcus neoformans. But please don't forget mucor, which is also a very common cause of fungal infection in these group of patients. Amongst the viruses, cytomegalovirus is the most common virus of concern, but other viruses such as influenza, parainfluenza, respiratory syncytial virus are being diagnosed with greater frequency with the availability of the multiplex assays. As for the parasites are concerned, they're not so commonly involved in the etiology of the pulmonary involvement in these group of patients. However, infection with strongyloides and toxoplasma are important diagnostic considerations. Coming to the specific infections, first talking about the invasive aspergillosis, which in itself is not very easy to diagnose in these group of patients because the signs and symptoms are often non-specific. We know that aspergillus is a colonizer, therefore it's difficult to distinguish between the colonization and infection of various cultures and the stains. The blood cultures are practically always negative because aspergillus is a large fungus. It can invade the vessel but doesn't circulate into the blood. And therefore, the fungal cultures of aspergillus are invariably negative. And it's difficult to perform invasive procedures to obtain biopsy samples, which may actually be needed for a proven IPA diagnosis. The URTC MSG criteria can help with assessing the probability. Majority time we are treating the probable IPA based on the positive galactomannan test with compatible radiological features in a susceptible host. The diagnosis of proven IPA is usually difficult and is not achieved because of the lack of the histopathological evidence. The radiological features are not specific, but they are quite suggestive of invasive aspergillosis. The classical would be the halo sign, where you can see there is a central nodule, which is a patch of consolidation, then there is surrounding ground glassing. So it's very typical of invasive aspergillosis. Then you can have a peripheral wedge consolidation. Now, SPS causes angioinvasion, therefore it causes infarct. So if a patient comes to me with a history of chest pain and hemoptysis, and you find this kind of picture on the CT imaging, then I would seriously consider the possible invasive aspergillosis in this patient. Then you have this air crescent sign, which is sort of a nodular cavitation, which occurs in the late process of the disease, usually in the phase of the resolution. A number of biomarkers available like galactomannan, aspergillus lateral flow assays, beta-D-glucan, and aspergillus PCR in blood and bile, but we generally send galactomannan in blood and bronchial lavage. The optical density index cutoff of galactomannan serum is equal to more than 0.5, and bile is either equal to 1 or more than 1. And we know the detection of galactomannan bile is much more sensitive than serum, both in hematological and non-hematological patients. But we have to be mindful of the false positive galactomannan results, which may be positive because of various antibiotics like amoxiclav combination, piptazo, cefepime, cefepime, sulbactam. Even carbapenems and colistin ablation and other fungal colonization can give rise to false positive galactomannan results. The bronchoscopy plays a very important role. This could be the diagnostic tool for the proven invasive aspergillosis. You may have a positive culture in the bile, coupled with demonstration of hyphal invasion or histopathology. Just for an example, this patient presented with a mass with a consolidation in the left lower lobe, which is you can see the PET of it. We performed the bronchoscopic cryobiopsy in this patient. You can see there is a poorly differentiated carcinoma, but also there is an associated coexisting aspergillosis. As you can see the fungal hyphae seen there in the histopathology specimen, which was much more clearer in another section. The aspergillosis can also present in necrotizing tracheobronchitis. You can see it is offensive, like looking like trachea. There is mucosal denudation, necrosis, a lot of exudation is there. The trachea, mucosa seems to be like sloughed up. And we performed the biopsy, the forceps biopsy, and you can see this slough-like biopsy specimen. Again, it was positive for the fungal hyphae of aspergillosis. Mucormycosis is another very important fungal infection. usually present with rapidly expanding pulmonary lesions like this, and they generally also have often involvement with the orbit in the palate. So a generalized examination can clinch with the diagnosis. Again, the radiological findings may not be specific, but they may be quite suggestive of mucormycosis. For example, this is reverse halo sign, again, quite, sign which is quite suggestive of mucormycosis, which is actually the reverse of the halo sign. Here, what you see is the area of ground glassing, which is surrounded by a ring of consolidation. This is reverse of the halo sign, which you see in aspergillosis, but this is quite typical of mucormycosis. Then you can have the bird's nest sign, where you got a reverse halo sign with irregular and intersecting areas of stenus. So here you can see it looks like the nest of a bird. Again, the bronchoscopy plays a very important role. The culture of and the microscopic examination of the bile specimen could be the gold standard, but unfortunately the sensitivity is low. And therefore, the bronchoscopic biopsy is extremely important, which can establish the diagnosis very, very quickly in these patients. This was a patient of uncontrolled diabetes who presented to us with right upper lobe consolidation. We performed a bronchoscopic guided cryobiopsy, and the biopsy specimen showed the typical ribbon-like hyphae of mucormycosis. And this is the chest X-ray before starting the treatment. This is after 2 weeks of initiating the isavuconazole. You can see there is significant improvement in the radiological picture. The mucor can also be present as endobronchial pathology. So we performed a bronchoscopy in this patient. As you can see, there is a cauliflower-like growth in the bronchus intermedius. There was a strong suspicion of a malignancy in this patient. We performed the cryobiopsy under the bronchoscopic guidance, and the biopsy specimen showed mucor, where you can see again the ribbon-like hyphae. And this is a bronchoscopy after 1 month of the treatment with isavuconazole. You can see there is significant resolution of the endobronchial pathology. Another case, known case of HLH on immunosuppressive therapy, presented with a lymph node enlargement at station 11L, which is the interlobar lymph node station, and looks like a mass-like lesion. It's a necrotic mass-like lesion, and there was a pretest possibility of a malignant pathology. We performed the EBUS-guided bronchoscopic biopsy in this patient, and this showed mucormycosis of the lymph node. So this is how bronchoscopy really helps you in diagnosing these patients. Another case, FDG avid lobated soft tissue mass lesion in the right upper lobe with the right paratracheal lymph node. And the bronchoscopy showed a whitish regular growth in the apical segment right upper lobe. We took the biopsy from there, it proved to be mucor. But interestingly, we performed the EBUS TBNA of the right paratracheal lymph node. We showed adenocarcinoma. So this patient had actually a dual pathology of adenocarcinoma with mucormycosis. Another case of necrotizing mass lesion on both sides of the lung. You can see the necrotic mass lesion with surrounding bird's nest sign. And we performed the bronchoscopy, which was really offensive, as a matter of fact. You can see the bronchial tree is being eaten away by the mucor. You can see there's a lot of slough, a lot of debris, and the bronchial tree is eaten away. So what we were seeing on the CT scan was actually the bronchiectasis. It was not the lung parenchyma, it was the bronchiectasis which was seen, and the bronchi eaten away by the fungus. And this showed the dual pathology of mucor and aspergillosis. You can see the ribbon-like hyphae of the mucor, and then these septated hyphae of the aspergillus. Now coming to pneumocystis jirovecii, again, a very important consideration. The risk of pneumocystis jirovecii pneumonia is most significant in the first 6 months after transplant and during periods of intensified immunosuppression. The pneumocystis occasionally strongly associated with cytomegalovirus co-infection. This is possibly because the CMV inhibits the alveolar macrophages function and also causes T lymphocyte dysfunction. The hallmark of infection due to pneumocystis jirovecii is the presence of marked hypoxemia, dyspnea, and cough. But if you examine this patient, there would hardly be any physical signs. And PCP is generally acute or subacute infection. It would be there for about weeks. So an HIV patient would come to you with a prolonged history of hypoxemia, dyspnea, and cough. And the typical radiological finding would show diffuse bilateral interstitial ground glassing, often with perihilar predominance. And the intriguing feature is that it is often associated with cystic opacities. You can see the small cyst within the background of the ground glassing. Another case where you can see the patchy consolidation ground glassing with cystic opacities. The Synapse BDG is a quite useful supporting diagnostic tool with a sensitivity of 92.8%, and nested PCR and quantitative real-time PCR has a very high specificity and sensitivity of more than 90%. And again, the bronchoscopy becomes very important. The Grocod, Gomori, methamine, silver stain has a very good diagnostic of more than 90% in bile. You can see these the pneumocystis there. And in fact, you should not do a transbronchial biopsy in this patient because these patients are at higher risk of pneumothorax if they are having pneumocystis carinii. Coming to the pulmonary candidiasis, the cases of pulmonary invasion are extremely rare even in immunocompromised hosts. But when we do a bronchoscopy or do this sputum examination, many times the cultures are positive for candida. But these patients are not to be treated, and these kind of samples have to be ignored. But we have to remember that hematogenous seeding of the lungs during fungemia can occur with candida species. We had one case where we had the septic emboli in the lungs from the candida endocarditis. So this kind of presentation of candida may be there in some of the patients. Coming to cryptococcosis, usually the cryptococcosis presents as asymptomatic infection in the lungs and appreciated when an asymptomatic pulmonary nodule or lymph node enlargement is appreciated on a routine chest imaging like HRCT scan. Occasionally, subacute consolidation with influenza-like symptoms may be noted with pulmonary cryptococcosis. The most frequent symptoms are shortness of breath, cough, and fever. It's very important to remember that an aggressive diagnostic evaluation must be initiated even for asymptomatic patients with cryptococcosis because the lungs are the portal of entry for disseminated infection, which frequently involves the central nervous system. The cryptococcal antigen BAL has a very high sensitivity of 82.6% in HIV patients, but even in HIV negative patients, it has a good diagnostic yield. Bronchoscopy again becomes important in this group of patients where the microscopic examination and culture could be the gold standard, but again, the sensitivity is poor. Now, this is a patient of cutaneous cryptococcosis in a post-renal transplant patient, and the radiological surveillance detected a small subpleural nodule. Of course, the patient was asymptomatic. And this patient, we performed a radial EBUS-guided cryobiopsy. Now, you can see there's such a small lesion. Now, we have the technology where we can sample these lesions and take the biopsies from there. So, you can see the kind of samples that we get. It could be, as large as a surgical biopsy specimen, and this proved to be a case of pulmonary cryptococcosis. Histoplasmosis is a granulomatous fungal infection. So if you do a CT scan and find a mediastinal lymph node, so besides tuberculosis, you have to think of histoplasmosis as a fungal infection. Again, the culture and microscopic examination could be gold standard, but the yield is poor. We generally send the urine histoplasma antigen and the histoplasma serologies, which can add to the diagnostic yield. And I show you just an example. Patient presenting with miliary tuberculosis in a post-renal transplant patient. He also had mediastinal lymphadenopathy, was on ATT for 1 month and was not responding. We performed a bronchoscopy in this patient, also performed the EBUS TBNA of the lymph node stations. And both the bronchial lavage and the EBUS TBNA showed these extracellular and intracellular tiny overlays of histoplasma. Nocardia is also a possibility, especially if you've got a large non-resolving pneumonia. So in these kind of consolidation, nocardia is a possibility. And if you do a modified Zeal-Nansel staining in this patient, you find these, the filamentous long acid-fast bacilli, which is pathognomonic of nocardia infection. The nocardia-specific PCR has a very high sensitivity in BAL of up to 88% and a good specificity of 74%. Coming to cytomegalovirus infection, usually occurs 1 to 4 hours after the transplant. Typical presentation would be a bilateral, symmetrical, peribronchovascular and alveolar involvement, predominantly affecting the low, but the intriguing finding, the characteristic finding would be the sparing of the subpleural space. Another case where you have got this area of consolidation ground glassing, but typically you will find the subpleural space is spared. So this is quite pathognomonic of CMV infection. The CMV DNA PSR in blood and BAL are commonly used and they add to the diagnostic yield. Coming to parasitic pneumonia, the toxoplasmosis and the strongyloidosis can be a possibility, but the definitive diagnosis of pneumonia would be identified by finding these parasites in the respiratory specimens, especially the BAL. I had one case of strongyloidosis in my lifetime diagnosed with the bronchial lavage. So the take-home message is microbiological diagnosis pneumonia in immunocompromised patients remains a challenging evolving process. HRCT chest may not show you the specific findings, but it can show you the findings which could be quite suggestive of a specific infection. And with clinical correlation, you can start a initial empirical therapy. The combination of molecular methods and antigen testing might enable early detection, but they have to be again clinically correlated, and they are routinely done, as a matter of fact, to add to our diagnostic tool. What I want to stress, the early bronchoscopy should be considered. Bronchoscopy biopsy, although seems difficult, but it's not impossible. And every attempt, if possible, should be made to do a biopsy of this patient, because it can tell you the invasive disease, it can prove the diagnosis in 2 days' time, and then you can be very specific in your treatment. Please remain watchful of the polymicrobial and disseminated disease. And last but not the least, do not forget the non-infectious causes of lung pathologies. Like you can have a GVSD, acute lung injury, chronic lung injury, interstitial fibrosis, bronchiolitis, BOOP, organizing pneumonia, ARDS, alveolar hemorrhage, congestive heart failure, pulmonary edema, all kinds of possibilities are there, which may be as an isolated phenomena or may be coexisting with the infective process. Thank you for your patient hearing. Thank you.
Thank you, Dr. Goel, for an excellent discourse. And I would like to ask just one simple question. How often do you see that a bronchoscopic culture turns out to be positive for a particular organism and all the antibiotics are resistant to it? And then how do you guide your antimicrobial therapy empirically then, especially in the immunocompromised patients?
So 2-3 things. I mean, I deeply look into the radiographic picture of this patient, as a matter of fact. That really narrows down my diagnostic possibility. A close discussion with the radiologist is important. I would always like to send a multiplex PCR nowadays in these patients, as a matter of fact. Of course, you know, there are lovers of multiplex PCR, there are people who do not like it. But in a clinically difficult situation like this, they can actually guide you to the type of treatment. Generally, if you got multiple organisms, resistant bugs, resistant to all kinds of antibiotics, it's generally colonization. I mean, I would generally discard this kind of a report, but I would definitely have to look into the clinical radiological correlation in this group of patients.
And which category is the maximum pneumonia you see, whether it's a primary immunodeficiency or it is a solid organ transplant or a hematopoietic transplant or HIV?
So actually it's all both. And we talk of the specific infection with the, I did not cover that because the constraint of the time. You may have the humoral immune defect, there could be decreased cell-mediated immunity, and there could be specific organisms related to both. But that kind of picture is actually blurred, as a matter of fact. I mean, you don't really see the encapsulated Streptococcus pneumoniae in immunodeficiency patients, right? Similarly, I mean, we have to keep our eyes open, and we just cannot be very dogmatic about the classification of community-acquired infections or hospital-acquired infections. We really need to, focus on the past history of how the patient has, behaved, the epidemiological data of this patient, and of course, I would like to do a early bronchoscopy to get an answer.
I declare the house open for the questions, please.
How would you prefer to do a bronchoscopy? Do you intubate a patient, to avoid the oral contamination? Are you using a disposable bronchoscope in a patient of immunocompromised? Because there's a lot of queries, debate regarding the, cross-contamination using a reusable bronchoscope. So these 3 things. And how are you going to talk with your microbiologist? There is innumerable causes of bacteria, fungi, and viruses causing the infection. Now, picking up every kind of a bacteria, virus is difficult in a tier 2 or a tier 3 cities. How are you going to, apply these things when you're doing a bronchoscopy? There must be some pre-thought when you're going ahead with the procedure,
Right. Again, clinical radiological correlation is important. My radiological imaging is extremely important. I come to the question whether to use a reusable bronchoscope or a reusable bronchoscope. Especially if it's a transplant patient, I would like to use a disposable bronchoscope, right? Single-use bronchoscope, as a matter of fact. But otherwise, it's not very cost-effective. Right, majority of patients, ICUs must be using the single-use bronchoscope, but they're reusing it, which is not correct, as a matter of fact. You're not cutting cost in any ways. So that's why it's a transplant patient. I will use single-use bronchoscope. Otherwise, we'll use our contemporary bronchoscope. That is point 2. Again, the answer remains the same, sir. Answer remains the same. Clinical, radiological correlation with your bronchoscopic findings becomes important. And communication with the microbiologists, communication with the infectious disease specialist, which is now a good add, as a matter of fact, in our armamentarium, as a matter of fact. That really helps. So what we do, we have come with a long experience of, seeing these patients, their radiological pattern over period of time. So just looking at the CT scan measure time, we are able to tell these are the 2 or 3 possibilities. Then we speak to our infectious disease specialists. They also give their input. So currently at this point of time, our job is basically more of diagnostics. But when we get the results, we all come together, including the infectious disease specialist and the microbiologist, to reach to a conclusion. Anyways, it's not very simple, right? Many times we keep escalating rather than de-escalating. The answer is not very clear-cut, but we must try to get a specific answer. That is important. We should not restrain ourselves from doing bronchoscopy and biopsy if it is possible.
I think we should wind up the session. Yeah.
Thank you, sir.
Thank you so much.
Thank you. I request our chairperson, please felicitate our speaker with the memento with big round of applause. And I request our chairpersons, please collect their mementos from memento podium. And I request Sushil Jain sir, please felicitate our chairpersons with mementos at memento podium. For the next session, I request chairpersons for the topic, Dr. Rajendra Banthia sir, Dr. Dipesh Maske, and Dr. Ravi Tiwari sir. I request.
So the next topic on mechanical ventilation in critically ill septic patients shall be presented by Dr. Marcus Schulz, sir. He is a professor at University of Amsterdam and an honorary at Oxford University. He has co-founded the Protective Ventilation Network. His main research interest area are mechanical ventilation, lung injury, and pneumonia. Over to the chairperson.
I request Dr. Ravi Tiwari sir, please join the dais as a chairperson.
So thank you very much again for inviting me. It's really a pleasure to be here and to enjoy all these pieces of India that I have received over the last days, including a very nice dinner I was having yesterday evening. So I was here in the venue trying to find the group where I was belonging to. I was having some very nice conversations and nice food until somebody asked me, what is your relationship to the just married couple? And then I realized I'm at the wrong place. So I said something about connection in the past, etc. And I think I got away with it because they offered me some nice dinner thereafter as well. And then serendipity, I met up with some colleagues who took me to a very nice place here in the city, a chapel where there was a ceremony happening, and I joined that evening very much. So this is then my disclosure for today. Now I'm going to talk a little bit about mechanical ventilation, and you saw already on the previous slide that it's about critically ill septic patients, but the subtitle is giving what is more about. I'm going to talk about the relationship between lung injury and acute kidney injury and how they relate to each other in a mechanically ventilated patient. Because I think it's very important to realize that we do apply mechanical ventilation not only to the lungs that can be sick or cannot be sick, but to a whole body, which is also having other organs that are being affected by the critical illness and can be affected by the way I ventilate my patients. So what I will discuss with you today is the following, in the following order. I will discuss how we treat acute hypoxemic respiratory failure, how we set the ventilator, for instance, to prevent further harm, but also how we think about preventing further harm to the kidneys. And then I will talk a little bit about the cross-link, if you like that word, between these two organs to see if there is some overlap in the critical illness and to understand why, and that's the next topic, it could be so different when you have a patient with acute kidney injury, how you ventilate a patient. And finally, we'll spend some words on the techniques or the strategies that we now apply to prevent ventilator-induced lung injury, asking myself the question, is this also preventing VICI, ventilator-induced kidney injury, or is it actually harming the lung? And finally, we'll wrap up with some recommendations and future ideas. So, thinking about the first topic, I think everybody here in this room knows this study. So the use of low tidal volumes as compared to very large tidal volumes in patients with ARDS is leading to a lower morbidity and a lower mortality. A clear signal, a beautiful study, but we have to realize one thing here. It's a study of 25 years ago, and that was a time in which we ventilated patients or treated patients quite differently. Realized that these patients were deeply sedated and having muscle paralysis for many days, and it's another situation from what we have today. And this might explain a little bit why a second study on this topic, a second large study on this topic, not patients with ARDS, but the lungs of these patients were in most of the cases quite sick and close to ARDS, was a neutral study. The tidal volumes were more close to each other, but still there was a large difference, 6 to 10 milliliters per kilogram predicted body weight, but this was a complete neutral study. And there is more evidence against the use of low tidal volumes, and that is this recent study. It's a too early stop study. Only after some 100 patients, the study was stopped because of financial reasons. But this study in patients with completely healthy lungs, the use of a low tidal volume was actually associated with harm. So how to explain this? How should we look at this? Well, some information might come from this large IPD meta-analysis, an analysis of the individual patient data from in total 6 randomized clinical trials and 1 observational study, showing what happens if you apply low tidal volumes to a patient that's having a low compliance, that's on the top, or a high or reasonably high compliance, or a better compliance if you like. You can see here from this picture that the effects are opposite. So when you use a low tidal volume in a patient with a low CRS, a low respiratory system compliance, there is benefit. But the opposite is true. There's harm actually from using a low tidal volume in a patient with a higher respiratory system compliance. I will come back on this later, but this slide may help you to understand what I try to say now. So on the bottom, you see a patient that was maybe a patient 25 years ago, a patient that was completely ventilated by the ventilator, so no spontaneous breathing activity from the patient. That means that the diaphragm is going upwards. That means that the lung volume is much lower. This is the low compliance that you see in these patients. And you can understand why it's important to use a low tidal volume. There is not so much space. So you use a low tidal volume and that might be beneficial. While the opposite is true in the patient on the top of this slide, that's a patient that is spontaneous breathing. There's much more space and you can probably apply a larger tidal volumes and maybe it's even more beneficial. And why, I will explain in some of the next slides. So what about PEEP? I think we can have a whole day of discussions about PEEP. There are many studies out there and all these studies show that there is maybe some benefit, that there might be no benefit. This is, I think, one of the most important studies. Unselected use of a high level of PEEP in aggressive recruitment maneuvers. I was in favor of this strategy until the study came out. Is associated with harm. It's actually harming the lungs of our patients. And I think a Bayesian analysis using the same data from this study, by the way, showed very nicely how we should look at these results. So a patient that is having recruitable lung tissue, there it might be beneficial to use a higher level of PEEP. That makes sense, right? If you are an older intensivist like me, if you ask me the question, a patient with a dense pneumonia, would there be a beneficial effect of a high level of PEEP? I probably would have said no. And this is actually shown on this slide. So the Bayesian analysis is suggesting that we should only apply PEEP when there is recruitable lesions in the lung parenchyma. Talking about tidal volumes or tidal volume size, I am often a bit puzzled by why are we expressing it normalized for predicted body weight. It does not make too many sense. Holding in mind what I showed on one of the slides showing the lungs of patients, I think it's making more sense to normalize it to the available lung tissue for mechanical ventilation. And that's actually the respiratory system compliance, right? So if you divide tidal volume by compliance, actually you get the driving pressure. And this is one of the, well, not anymore new kits on the block. It's already out there. We are using it to look at how we ventilate our patients, and we're using it now as a target of some of our randomized clinical trials. As shown here, for instance, this IPD meta-analysis clearly suggests, clearly shows actually that there is a strong association between the driving pressure and the outcome for our patients. If the driving pressure goes up, I will not talk too much in detail about the analysis done here, but what you can see, what you can read from this slide is when the driving pressure goes up, there is a stronger risk, a higher risk of mortality in these patients, suggesting that a lower driving pressure is better. And another way to look at lung harm or ventilator harm is coming from the mechanical power discussion that we are having over the last couple of years. For your information, and you probably know, mechanical power is related to the indexed tidal volume, respiratory rate, and the pressures. There are different formulas or equations to calculate this, but this is what it basically says. And there is an important role for respiratory rate, but looking at the data that is out there, periods of high mechanical power are associated with a bad or worse outcome of our patients. And even, and that's nicely shown in this study, even very short periods of 50 minutes to 30 minutes, there is an association with a worse outcome. So we should try to lower the intensity of our way we ventilate our patients. Coming back to this slide, I showed this slide just before. Just to recall, this was the analysis in which we compare patients with a low respiratory system compliance and a high respiratory system compliance. Now, if we do some calculations, you can actually understand what is happening here. So a tidal volume reduction in the one group is reducing the harm to this very small rest part of the lung that is being ventilated, even if the respiratory rate goes up. But if you look at the bottom, these are the patients with a higher compliance, you can see that there's also a rise in respiratory rate, but this rise in respiratory rate actually is causing a higher intensity. Mechanical power in this group of patients goes up. And I think that's why we are having these results in this IPD meta-analysis. And the respiratory rate, I repeat, is probably very important now to hold in mind when we are setting the ventilator, and studies are ongoing as we speak. But this is a similar analysis as shown for the driving pressure. It's a complex analysis. In respect of time, I will not discuss it in too much detail. But what you can see here is that when the respiratory rate is low or is going down, then the mechanical power is lower, and it's even associated with a better outcome. But this is retrospective analysis of large databases, and we cannot conclude that it's a strategy that we should apply. We need randomized controlled trials for that. So what is the evidence that we have at the moment? Well, we use a low tidal volume, at least in patients with a low CRS, a low respiratory system compliance, but in a patient with a higher respiratory system compliance, probably we can use a higher tidal volume. I'm not advocating 12 or 50 milliliters per kilogram predicted body weight, but 10 could be reasonable as long as the driving pressure stays low. I'm not in favor anymore of using a high level of PEEP, at least not in all of my patients, and only as a rescue therapy in patients that are having recruitable lung tissues, but that might be difficult to find at the bedside. To decide at the bedside what is the best strategy, you have to evaluate how the lungs are responding to the high level of PEEP. And maybe, and I put here maybe because randomized clinical trial evidence is still lacking, we should go for a lower intensity, and maybe we can reach that through a lower respiratory rate. But there is something we have to remember here, that it could come with permissive hypercapnia, and it might be bad, especially for other organs. Now, what about kidney protective strategies in the ICU? So in septic patients, a lot of our patients are having acute kidney injury. How do I protect the kidneys in my patients? Well, the list is actually quite small. And although I'm not an expert on this topic, when I try to read about it, actually this is the list I can find. There's not so much things you can do. You avoid nephrotoxic medication, you try to have a better hemodynamic, which is not only the macrohemodynamic, so preventing hypertension, but also preventing loss of microcirculation. And you prevent progress of the disease and you treat it. But that's all we can do. And I wonder now, is there a way to protective ventilation and also to protect the kidneys in these patients? Because there is a clear crosstalk. And this crosstalk has been explained or has been hypothesized in several ways. There is the biotrauma ID, there is neurohumoral regulation IDs. I will not discuss this second one. And there are circulatory effects of hemodynamic ventilation or mechanical ventilation. So the biotrauma ID is based on the idea that there is a huge inflammation in the lung, and by applying mechanical ventilation, we are even worsening, making this local inflammation stronger, and then there is spillover to the circulation, and these cytokines and other inflammatory factors can harm distant organs, including the kidneys. Several studies have focused on this. Mainly, this is animal work. This is nicely summarized here in this slide. Many of the cytokines and inflammatory markers are only tested in animal studies. This is a very nice overview, if you like, but it's already very old. And since then, there has been not so much progress. This is an interesting study. I will discuss it 2 times. Let's focus on how inflammation can be diminished or can be minimized when you apply a lung protective mechanical ventilation strategy. It's a small study. In this study, there was a comparison between high tidal volumes and a low level of PEEP, and low tidal volumes and a high level of PEEP in black dots and in white dots. And you see that the protective mechanical ventilation strategy resulted in a bigger increase, or I should say a less increase in cytokine levels. In this case, it was IL-6 shown here in this slide. And related to that, there was also less distant organ failure. It's one of the small studies, one of the single and small studies that suggest that this crosstalk is happening through cytokines. And probably it's not only the one way we're talking about, so lung inflammation, exaggerated inflammation through the way we ventilate the lungs, and then distant organ failure, but also the other way around. Due to kidney injury, there is maybe a fluid overload. It's getting more difficult to ventilate patients with a fluid overload, and there is more intensity of ventilation, and then the circle is round. So the circulatory effects are multiplural. There are several ways how you can think about this. Hypoxemia and hypercarbia by itself cause hypoperfusion, and that's, I think, one of the most important reasons why the kidneys are at risk in our patients with ARDS or patients with sepsis. And here also there is this circle of death in which you see that kidney injury is then leading to fluid overload and finally resulting in a more difficult to ventilate patient. But there is more, and something that we sometimes say about a high level of PEEP, that is causing hypotension because of its effect on the left ventricle. We also have to realize that the right ventricle is also under trouble, and the backflow to the heart is troubled by a high level of PEEP, especially when the lungs are having a higher compliance. So they can have, due to the higher level of PEEP, an effect on the backflow to the heart, because the vena cava inferior is compressed by this. It's nicely shown on this picture, and it's nicely discussed in this paper. And it's one of the ways we are thinking about how PEEP actually can cause harm in our patients. Now, let's take the next step. What do we know about ventilation in patients with acute hypoxemic respiratory failure that have acute kidney injury? This is a somewhat older analysis from my group. This is a meta-analysis using individual patient data from 3 randomized clinical trials. All patients were not having ARDS, by the way. It's nicely showing that there is an effect or an association, I should say, between driving pressure and mechanical power and not tidal volume and outcome. And we looked in this group of patients how the patients were ventilated and how their driving pressure and mechanical power was different. So this slide is giving all the data that were there with regard to mechanical ventilation, but actually the most important information is coming from these 2 panels showing that Patients with pneumonia are usually ventilated with a higher driving pressure, which makes sense, right? They have a more stiff lung, so you need a higher driving pressure to get the tidal volume in. But interestingly, when you look at patients with pneumonia or patients with pneumonia and sepsis or sepsis, they have a higher mechanical power. And this is purely related to the higher respiratory rate that we need in these patients. Usually these patients having a metabolic acidosis, and we want to compensate for that. And then the mechanical power of ventilation goes up. And the same we found in another study. This is a large worldwide observational study, or actually 4 worldwide observational studies put together, in which we see actually the same signal. If you look at driving pressure and mechanical power, they go up, the mechanical power goes up in patients that are having acute kidney injury as one of the organs that are failing. So can we prevent Vili and can we prevent Vicky at the same time? There's one important point that we should not forget, and that is that we try to be not so liberal with our fluids anymore. This is an older study already, also from the ARDS network group, several years ago, showing that less fluids or a lower fluid overload, that's a bit of complex way of saying it, actually meaning being conservative with the fluid administration, that there is a better pulmonary outcome. But there was a lot of worry about the kidney outcome in these patients, but that was not found in this study. To be honest, it was just one of the secondary endpoints, and it was not well captured. We are trying to solve that by doing this study. It's a study that's almost at its end. We have to do another 150 patients or so. We are repeating this study in non-ARDS and ARDS patients, by the way, and we are focusing not only on pulmonary outcomes, but especially, that's one of the key secondary outcomes, the kidney failure or kidney function. Some last words then on ventilation strategies. So tidal volume reduction. I already showed this slide. Remember, this was low versus high tidal volumes in the cytokine response. What they also looked at is the different organs that were failing. And what you see is that with the lower tidal volume, acute kidney injury was actually happening less in these patients after 3 days. So it's a small study suggesting that there is benefit with regard to the kidneys when you're using a lung protective mechanical ventilation strategy. But this was not found in this study. This was actually one of the prevent studies, one of the studies I showed before. Here we looked at different markers. We could not find any effect of a low ventilation strategy. And it's in line with all these other studies that are actually showing no benefit except for the Italian one that I referred to. There's one group in which there is a strong effect, and that's an effect in patients that are actually receiving a very short period of mechanical ventilation, post-operative after cardiac surgery. In this group, they are at risk of kidney injury. There is, again, benefit from low tidal volume. With regard to PEEP, I can say, look at this slide. This was an important one. The Bayesian analysis and the way we think about how PEEP could work, I think we have to be very careful with titrating PEEP to prevent lung injury and also to prevent kidney injury. Maybe this is the number one question that we had at the moment. So if we're going to look at mechanical power, what is this association with kidney outcome of our patients? And especially if we lower the respiratory rate, and this is one of my last slides, this is a study that is in the planning. We have now done several pilot studies to test the intervention. Intervention means we're going very low with our respiratory rate in critically ill patients, hoping that we will end up with a low mechanical power. Primary endpoint of the study is again pulmonary outcome, but key secondary outcome is kidney injury, as we have concerns whether the hypercarbia that will develop in these patients may cause harm in these patients. So, in conclusion, acute kidney injury is extremely common in patients that receive mechanical ventilation in the ICU, and I think lung protective strategies may protect, but at the same time could harm the kidneys of our patients. And unfortunately, it's also my way of looking at the data. We turn a blind eye to the kidneys in our research so far. This really have to change. We have to look beyond the lungs when we're applying mechanical ventilation studies. And here's where I would like to stop, and I'm happy to take any questions either now or after the session. Thank you.
Thank you, Professor Marcus, for such a wonderful talk and reiterating that there is a long way gone in the management of septic patients in terms of ventilator, and ventilator mechanical ventilation is like a necessity evil. It does do good. It can also do harm. I just have one question to you. What is the current concept regarding the self-inflicted lung injury? After the COVID, there is a lot of talk regarding self-inflicted lung injury, especially patient who are in mechanical ventilations, patient getting weaning off from the mechanical ventilation, they're suddenly deteriorating because of a lung injury. And the question was that is it because of the patient's own respiratory drive that is causing the lung harm? How do you really identify and how do you manage?
So can you repeat the question?
The self-inflicted lung injury, silly.
All right, yes. So I'm a bit skeptic actually about self-inflicted or patient self-inflicted lung injury, because most of the studies that are suggesting that there is PSILI, as we abbreviate it, is from patients that are not receiving mechanical ventilation. They are not on a ventilator. At best, they are at non-invasive ventilation, and this might be a very different group. However, I think that there is the potential for causing harm through this idea that patients can have huge pressure swings resulting in harm because of that. The big issue here is that you actually need esophagus pressure measurements to understand better what these pressure swings really are. And next question could be, how do you do that at the bedside? Well, at the bedside, I'm just looking at my patient, trying to understand how well he is ventilating. The use of accessory muscles, for instance, is a nice indicator, but it's not that precise as using an esophagus catheter. Esophagus catheters are simply too expensive. I cannot afford to use them in my setting, for instance, and I think that's a problem worldwide. And the use of esophagus catheters in the right way is quite complex. It's not that easy as it looks, what some people are saying. So PSILI may exist. I'm not so happy with what we have for evidence at the moment. But in my mind, I'm looking at the patient with the idea of self-inflicted lung injury. Sure.
Any one or two questions from the house, we can take it. Others, you close the session.
Thank you, sir.
One last question.
Hello. Dr. Sul, I wanted to basically ask you if you are discussing PEEP. One of the method that we say to optimize the I would say delta PS or delta PC, what you call ventilatory power, because power includes two, the one driving pressure as well as the one respiratory, just like cardiac output, total power. So what about using that inflection points, because it generally increases the PEEP?
So I was already afraid of a question like this, because we can have a very long discussion about PEEP and titrated PEEP. What is the best way to do it, and if it's working in the end? Let me give you two answers. The one is, if we look at patients in the OR, so not in the ICU, but intraoperative mechanical ventilation, all the studies that have been performed thus far, randomized clinical trials that titrated PEEP on whatever measure they used, like the inflection point, as you were suggesting, or PEEP titration strategies on compliance, or the driving pressure, they are all neutral. All neutral with regard to the endpoint postoperative pulmonary complications, which is a measure of lung injury in the OR setting. There's even one study coming out quite soon. It will be presented in Canada in a month. That's one of my own studies, designation, 1,200 patients, driving pressure guided PEEP. It's a complete neutral study. Now, if you go to the ICU, actually, when you look at this, it's a bit the same. We have not too much evidence, and the risk is that we are causing harm if we are applying the titration in the wrong way. So you can use the inflection point if you are skilled in using that, but you usually need to paralyze a patient for that, and that's something I hardly do nowadays. You can use the driving pressure, but driving pressure is also not so easy in the ICU to titrate against. There's one study, DRIVE is the name of the study, coming from Canada, and hopefully in a couple of months, that study is finalized, and that will give us the answer if that's the right way. But then, of course, the discussion again will be, How should we do it then? Should we do it as they do in DRIVE, which is driving pressure-guided PEEP, or the inflection point? Some are looking at some other markers of the recruitability of the lungs, for instance. I'm not sure. It's a very difficult question. And I can say, while I, as a young intensivist 20 years ago, was much in favor of using high levels of PEEP, over the last years, with all the evidence that came in, I started to become very, well, not neutral for high PEEP, but skeptic about high PEEP, thinking sometimes it's maybe better to accept that there is atelectasis, and if it's compensated by some more oxygen, that's fine. And if it's not compensated by a higher FiO2, then I apply a higher level of PEEP. But very, very, yeah, in a not aggressive way as I did in the past.
One more thing I would like to ask, like, lung protective ventilation basically means accepting certain things. Certain like permissive hypoxia, permissive hypercapnia. Now, there might be condition where you don't have ECMO or ECOR, and you have to choose whether you are letting patient die in an hour or whether exceed the limits and let the patient survive for a day and see what happens later.
Yeah, I'm not sure if I can give the right answer to your question now, but I like very much what you're saying about we have to be more permissive. I think 25 years ago, we were very aggressive. We wanted to normalize everything, like a normal oxygen level and a normal CO2 level, and to have a maximum open lung and show that everything was looking very nice, only finding that it was harmful. Remember that the high tidal volume strategy was there to improve oxygenation, right? This is something we often tend to forget, but we used that because we wanted to have a better oxygenation. And it was in the end very harmful in patients with ARDS. I think there's clearly, and I took the slide out actually, there's clearly one elephant in the room, if I may say it like that, and that is ECMO or ECOR. This is a new approach. We're starting to use it much more, and it's helping us to prevent the patient from deteriorating further where we cannot apply lung protective mechanical ventilation at the cost or the high price of its side effects like hypoxemia or hypercarbia. And I think the next 10, 15 years will be used to understand better how we are going to use ECMO to prevent this. But, and I called it the elephant in the room, ECMO is also having side effects and can also induce kidney injury by its side effects. So there's a lot of work to do.
And one thing I think...
can we have the discussion later, because there is a time constraint.
Are we...
I think we have to continue. So maybe we can have a discussion after. Yeah?
Sure.
Happy to do that.
Just wanted to tell regarding whether association does not mean causation, that most of the time we forget. We might be just treating association, leaving the cause
Correct.
open.
Absolutely agree. And I think that's why we do randomized clinical trials, right? So all the evidence, and that's why I said maybe, because all the evidence that we have is coming from associations, and an association is not maybe a causal relation. Applause for this suggestion.
Thank you, Professor, once again. Now I would like to close the session because of time constraint.
Thank you, our chairperson. I request our chairperson and speaker for assemble for a group photo. And I request our chairperson please collect their mementos from the memento podium. I request Dr. Ajit Sadani to present the mementos to our chairpersons in the memento podium. Now we move to our next session of sepsis. I request chairpersons Dr. Rajesh Agrawal sir, Dr. Achal Tiwari, Dr. Rajiv Chandrakar, Dr. Pramod Binaike sir, Dr. Sanchita Nihal madam, and Dr. Manoj Lal. Dr. Prerna Verma also joined the dais as a chairperson.
I invite Dr. Yatin Mehta sir to share his thoughts on management of adult sepsis in resource-limited settings. Sir is chairman in the Institute of Critical Care and Anesthesiology at Medanta. Sir is also a past president of ISCCM with up to 200 publications and 250 presentations at international and national conferences.
Thank you, Vishal and team, for organizing this wonderful meeting at Raipur. I've had a long association with Raipur. 20 years back, we had started cardiac surgical program in the medical school as a part of our responsibility, which went on for many years. And two of your past CMs are my patients. I know them quite well. Okay. So from driving pressure to resource limited setting, it's an interesting jump. Bring your greetings from Medanta. We do get patients from here. Some of you must have visited. Otherwise, you're welcome to come and visit us. We know it's a humongous problem worldwide. 50 million patients get sepsis, and out of which 11 million are going to die because of sepsis and septic shock. And by 2050, it's going to kill more patients than stroke, cancer, and myocardial infarction put together. So what are the most of the deaths and most of the incidents of sepsis is contributed by low and middle income countries. And this is the data which you can see, 80+% are because of that. This was the one of my old papers with the International Nosocomial Infection Consortium. Victor Rosenthal and I have done a lot of publications together. And this is primarily focused on the developing countries. And this was the data over a 5-year period. And incidence of, now this included Asian countries, Africa and South America, and very much higher incidence of hospital-acquired infections. And you can see that the only places in the world which beat us are sub-Saharan Africa. So I think nothing to really be proud of. This was the INDICAP 2 study, Chiki Divetia. He was supposed to come here, but unfortunately not able to do that. And again, we found that this was over a 4-point prevalence, 4 different points in that year we did all over India, public hospitals as well as private hospitals. And overall, 50% plus patients were septic. Half of them were septic, quarter of them were septic when they were admitted, and the rest were developed hospital-acquired infections. The mortality of septic shock was okay, but sepsis itself, mortality was higher. What are the challenges primarily in the developing countries, low and middle income countries? If you look at that, we begin with infrastructure. The beds are limited, the space is limited, the staff is limited. Okay. Delayed diagnosis and treatment, microbiological support is not there in many of the institutions. Patients are sick when they already come. Economic and social issues are also a major problem. Antimicrobial resistance is killing us. There's a high incidence of hospital-acquired infections. I'll come to that a bit later. Demography is changing. Patients' population is getting older with multiple comorbidities. We are the diabetic capital of the world. And training is also an issue. We have limited staff, nurses as well as doctors who are adequately trained in that. We must keep it in mind, the unique challenges associated with the developing and low middle income countries. Dengue fever, common influenza during winter season, malaria, falciparum malaria, I'm sure you get it in this part of the country also. Mycobacterium is getting resistant to most of the first-line therapy drugs, rickettsial diseases, leptospira in rainy season, and so on and so forth. So these are additional problems. HIV, I see quite a bit of HIV in my hospital. Many of them young patients. I just lost a 19-year-old boy with HIV because I think it is, although it's getting a treatable disease, but the diagnosis is late and people are, because of socioeconomic issues, they are hesitant to reveal it. There are certain specific problems which are related to LMIC, which are, you can see some parts of the country, you'll see amyloidosis, we fortunately are quite far from the sea and the water, so we in Delhi don't get so much of that. But bacterial infections, the first thing we think of, viral infections is increasing, parasitic infections is also increasing. What is a nutritional status is relatively poorer, many of them. Comorbidities are multiple. Um, access to healthcare is limited in some parts of the country. And the best doctors are the chemists in many parts of the country. You can buy on off-label, you can buy the medicines over the table. There are demographic challenges. As I said, there are long distances of transport of the patients. Triaging facilities may not be there in the emergency department. And human resources, the most important part of healthcare, is deficient in many parts of the country. AI, we have had a lot of discussion about AI. Maybe we may be able to use it more in future, but let's see about that. This is certainly not, this is one of my ICUs. I have 12 ICUs like this. You can see this is definitely not resource limited. Staffing, again, is a major problem. Many of them are open ICUs with the curtains. We hope that the bacteria stops, the curtains stop the bacteria. Unfortunately, it does not. One nurse jumps from one bed to the another with the same hands. Hand hygiene compliance is poor. Physician ratio, there was today's newspaper, there was a WHO has denied that this is what they have claimed, but the ratio is pretty low in this part of the country. Many ICUs, even you must have seen in the smaller nursing homes, and they just call it ICU. They put a monitor, they put a ventilator, and they think it's become an ICU. The family members look after the patients. They're supposed to do the suctioning. Lesser said, the better. We have some foreign dignitaries here. I do not want to tell too many dirty stories to you. Telemedicine, I think that is underutilized in this country. We must expand this facility, and this is where the role of the government as well as the senior staff comes into picture. You can see the incidence here. The global burden or prevalence of healthcare associated infections, 17.4% prevalence in India compared to, say, France of 4.4%. So four times more than that. Staffing, I already talked about. There is a shortage of trained personnel. Resources are limited. Trained personnel, there's too much of rotation. There is no way we can compete with Saudi Arabia regarding the money which the nurses make there. So they stay with us for a year and then move on. So there's a turnover is pretty high. And as I said already, ICU infection rate is very high. This was an article written after COVID-19 about critical care training in India. And as you can see, this is 2-3 years old, 4 years old. But still, for a country of 1.4 billion, we have only 20,000 people who can claim to be trained in critical care, which is humongously low. There were only 24 years back, there were only 20 DM seats and about 225 DNB seats in critical care. So this is grossly insufficient numbers. Diagnostic limitations are there. We talk about antibiotic stewardship, antimicrobial stewardship, but we don't talk about diagnostic stewardship. The scarce laboratory facilities, many smaller nursing homes do not have that facility. It's not 24/7 available. There's a high cost to it, particularly if you look at the PCR or based technology. Turnaround time is long if you have to send the samples outside. Errors can happen. Contamination can happen. Interpretation can be defective. So that's a problem. I found on the data which was presented on a monthly basis, the incidence of false positive blood cultures was going pretty high. So then we have dedicated now phlebotomists in a few ICUs, and there was a significant reduction in the blood culture positivity. So you can imagine that is the skin staph epidermidis is a contaminant from the skin if it is not adequately properly collected. This is one of our own patients on ECMO and CRRT and ventilator. This is again not resource limited. This is what not we are looking at. So we had made the surviving sepsis guidelines 2021. I represented Indian Society of Critical Care Medicine, and people from all over the world were part of this. More Europeans and Americans than obviously the rest of the world. But this was representative of the whole world. So some of the recommendations are based on that. And these are the main factors which we look at. Infections, there is source control, antimicrobial appropriate use, initially empiric and then targeted. Stewardship is extremely important. We need to develop that, which is not adequately present in many of the hospitals. Resuscitation, which fluid to give, when to use, vasopressors, when and how to give, and mechanical ventilation. We had a pretty good discussion on that. So as I said, treatment challenges are limited. Fluid resuscitation initially, how do you monitor it? If you do not have monitoring facilities, you will maybe harm the patient by giving too much of fluid. So if you do not have invasive monitoring in these patients for assessing the fluid responsiveness, you can harm the patient. But should you not fluid resuscitate? That's a question which needs to be answered. Central line insertion, if the complications of insertion of the line or possibility of bloodstream infections because of poor care of the line or line bundle, then should we use them or should we not use it? So these are again the issues. These are the two, rest of my talk is based on these two papers. One is the Indian Society, ISCCM position paper on resource limited settings. And second was this recently published intensive care medicine of management of adult sepsis in resource limited settings using Delphi method. I'm an author of, I think, both these papers. So what does it do? Will you transport the patient, but is adequate transport facilities available? And how good the roads are, how the weather, how the conditions of the ambulances, these are important. Virtual consultation should play a more important role. That means video conference and all should be done more frequently. Imaging facilities, now we had good talks on POCUS. But again, if the interpretation is not correct, you have to be certified to be able to do it. So we do not have at the moment that certification, adequate certification. Source control is important, but do you have interventional good radiology to put the drains? And do you have adequate staffing for interpreting the perfusion of the patients or for hemodynamic data interpretation? Again, while you are waiting for the ICU, some therapies can begin in the emergency room. Each hospital, it takes several hours before the patient gets admitted and shifted to the ICU. So one should know when the patient is deteriorating, when to shift the patient to the ICU urgently by doing manipulating some beds. Q-SOFA maybe has an important role in this part of the country. Very simple, it's completely idiot-proof. And you may get a few false positive alarms, but does not matter. It's better to have more code oranges than to have more code blues. If you do not have facilities for monitoring more inflammatory biomarkers, then CRP is also a decent marker. It's pretty cheap. It's available everywhere. If you do not have facilities for lactate, at least capillary refill time should be used more often, which we are not doing. And urine output is a very cheap monitor. And if the kidneys are perfusing, by and large, you should be okay. How do you test? The dynamic parameters are better. Everybody knows that. We have had several discussions on that. But how do you do dynamic parameters unless you have stroke volume measurement? So there are certain measurements. If you have an arterial line and if you have pulse pressure variation, if the patient is on mechanical ventilation, that's okay. Because Sheila Mitra has also published a few papers on tidal volume variation and its effect on pulse pressure variation. So that may be enough to do that. If you have more advanced monitoring facilities, yes, that's better to use dynamic parameters for assessment. But one thing I must emphasize, passive leg raising is a very good test to do. You're not really harming the patient, and we should use it more often than what we do. Balanced salt solution, multiple guidelines have recommended balanced salt solution. Biochemically, it is better. Mortality benefit is questionable, but No question, physiologically balanced salt solution is better. Cost is an issue. Ringer lactate is all right, better than normal saline or abnormal saline. If epinephrine is not available, sometimes it may be possible. Norepinephrine is not available, or vasopressin is not available, and you require a vasoconstrictor, then epinephrine may be used. Also, do not delay your administration of these medications because you do not have a central line or you're waiting for the patient to be transported to the intensive care unit. You start it in a diluted form at a smaller dose through a peripheral line. Safely can be given for 10 to 12 hours. No issue there. In urine output, I've already talked about. Non-invasive ventilation, it's better to use it earlier than later. NIV is always available in most of our places. So antimicrobial therapy and respiratory management, and NIV already talked about. Antimicrobial now will depend on which part of where the patient is coming from. And for the management of patients, septic shock and HFNC, now many of us have available. So HFNC is good, particularly for hypoxemic respiratory failure. HFNC is a good device to use. I already talked about antimicrobial therapy, then you can de-escalate. Glucose control, you can keep between 70 to 150, it's all right. DVT prophylaxis, you start early. Enteral nutrition, again, nothing like the gut functioning, and it is cheaper. So, but yes, kitchen feeds is a problem, more in a peripheral center. Contamination, possibility of infections is higher, so use commercial feeds. Sedation, pain relief important, and finally wean from the invasive ventilation. This was a enteral feeding guidelines which were published many years back. Nothing like your own gut utilization. Even if the patient is on vasopressors, as long as they're not too high, you can use them. This was a paper, the randomized control trial which we had published, PREVENT trial. Yasin Arabi and I was one of the authors. It was a randomized control trial in which you combine pharmacological DVT prophylaxis along with mechanical ventilation. Because if you have both the devices, then, and we had shown in this unequivocally, also in multiple papers after this, in subgroup analysis, it has no benefit. So either you use your pharmacoprophylaxis or you use mechanical prophylaxis. Pharmacoprophylaxis is obviously superior. Treatment failure, we do get treatment failure. Why is it happening? Is it because of MDR or XDR or PDR? Insufficient dosages, you are not monitoring the suboptimal dosages, you are not doing drug monitoring. So what are the other symptoms? Is it patient is some other source of infection? So that needs to be kept into mind. Dhruv Chaudhary's this paper, threat of gram-negative MDRs, which we all know that. So use your antimicrobials properly, based on certain guidelines. These were the Indian guidelines by the ISCCM. This was a paper which we published and which we showed Klebsiella and Pseudomonas and Acinetobacter crab was pretty high in Indian ICUs. This was a large study, multinational. So these were the guidelines of antimicrobial prescription. So use it guidelines-based prescriptions. I have 2 minutes more to go, I think. Yeah, almost. And this was iconic guidelines which we had published about MDR. How does one treat MDR? So Iconic 2 also has now come out. NDM is important in India. One has to keep that in mind. And this Iconic one was published before the certain newer antimicrobials came into the market. So that has to be kept in mind. Don't forget, prevention is the best cure. So we must follow the proper strategies for prevention of healthcare infections, particularly hand hygiene, and hand hygiene. Don't forget that. Future directions. We need to collect more data, from multi-center data from all over the country. We have to have tailored approaches for tropical infections. Dr. Narendra Rungta was here somewhere. He's one of the authorities. And tele-ICU network we must promote, and we must have the adequate infrastructure for improving it. So recapping, I've discussed what needs to be done. Poverty elevation is happening. Healthcare is getting better, but we have to judiciously use the resources which we have. Don't waste your resources. Don't overkill, if that is the terminology to be used. And a training by the Indian Society of Critical Care Medicine and the Government of India must improve. So this was the Surviving Sepsis Guidelines team. And you can see from the developing countries, I am there, and then the Flavia Mercado was there from Brazil, and few others were there from Philippines and Thailand also. Concluding, international guidelines, for example, surviving sepsis require careful adaptation to low and middle income countries, considering limited diagnostics, treatment staffing, and affordability. Early recognition, protocolized supportive therapy, and locally adopted guidelines have proven to lower sepsis mortality, yet enormous unmet needs and research gaps persist. Mobile health technology, remote learning, and international partnerships can supplement skill building, but face sustainability and funding challenges. Thank you very much for your attention.
Thank you, Mehta sir, for excellent presentation. And now topic is open for discussion. Any question is there?
Sir, now we are in the crossroad. 20 years down the line and 20 years now, 2025. Now, critical care department as a subsidy is growing up. Now, where are we in the crossroad? There are many hospitals coming up in the tier 1 smaller cities. They are giving support to the patients, and many patients are surviving because of that. But the opposite of the dark side is that because of mismanagement, overuse of antibiotics, not following these bundles, there is a rising in the healthcare associated infections and increased mortality. That is the one paradox. How are you going to tackle this in the current scenario and in the future ahead? From your thoughts, sir.
The government can play a better role. ICMR is already coming up with the good data and recommendations about antimicrobial prescription and so on. But I think we still misuse the agents or antimicrobials in the agriculture sector or poultry farming. Colistin is still being administered to chicken. So think twice before you eat chicken for your dinner. I think we must cut this down. We must stop this. Also, training must get better, and we must have more meetings like this. I think I must thank Vishal and company. I think awareness, because what happens is when the patients come to our hospital, they have already been admitted to some other facility. I'm not trying to blame anybody, or I'm not trying to say how clever we are as compared to guys in the peripheral, but there is a misuse of antimicrobials. And you think more you give, better the patient and faster he will recover. And even if the patient is getting better and you got some microbiological or molecular diagnostics telling what is the mechanism of the resistance, still you continue with everything, thinking the patient is getting better, why to de-escalate? So big daddies talk a lot about de-escalation, but it's not happening in real life. I think we all have to pitch in together to control this.
If no more question, let us conclude this topic. Thank you, Mehta sir, for excellent presentation.
Thank you, sir. Thank you. I request our chairperson, please felicitate our speaker with big round of applause. And I request our chairperson, please collect their mementos from the memento podium. To present the memento to chairpersons, I request Dr. Sarvesh Lal. Dr. Sarvesh Lal, please present the mementos to our chairperson and memento desk. Now we move to the next session. I invite chairpersons Dr. Ashish Dubey sir, Dr. Ashish Dubey sir, Dr. Nitin Sharma, Dr. K. Srijan, Dr. Chinmay Panda, Dr. Varsha Jawar madam, Dr. Rahul Goel, and Dr. Bhisham Sadani. Please join the dais as a chairperson. I repeat, Dr. K. Srijan, Dr. Varsha Jhamar madam, Dr. Chinmay Panda, Dr. Rahul Goel, and Bhisham Sadani. Over to chairperson.
For the next session on neuromonitoring in acute brain injury, I invite Dr. Kapil Zirpe sir to share his thoughts on the same. I request Dr. Varsha Zawar ma'am to introduce sir.
First of all, I would like to thank Dr. Vishal and the team for giving us this privilege to chair the session. And it's a proud moment for me and Dr. Rahul to share a stage with our own mentor. So, Dr. Kapil Zirpe, sir, is a head of department and director at Ruby Hall, Neurotrauma Unit, Ruby Hall Clinic, Pune. He is ex-president ISCCM and he has more than 100 publications on his name. Recently, he is doing a lot of work and awareness for the organ donation and organ transplant and cadaveric transplant, and is setting up the guidelines for the same. Over to you, sir.
Yeah, thank you, Vishal and the team for inviting me, and thanks Dr. Varsha for the very kind introduction. Now my job is two. I'm a neurointensivist, so I have to keep my patients awake and alert, and simultaneously at the 12:30 I have to keep you awake as audience. So let's see, next 15 minutes I able to succeed you in creating an interest in a neuromonitoring. When we talk about the neuromonitoring, the common question comes: why, to whom, how much time we should do that, how to do the monitoring. And there are so many other questions comes into the mind, whether every patient needs the neuromonitoring, and if he needs the neuromonitoring, how frequently needs the neuromonitoring, which way we can monitor him to keep him awake. So the first question is, why neuromonitoring? Simple way. Whatever that happens to your traumatic brain injury, SH, stroke, and the IC bleed happens in first 24 hours. Within 24 hours, the majority of the trauma victims deteriorate, majority of the IC bleeds worsen, majority of the CT scan shows the worsening of the underlying bleed and the infarct. So earlier the better. We talk about the time is brain. Now we say tissue is brain. We are now moved from time is brain to the tissue is the brain. We want to save each and every neuron of the patients. And if you see the primary impact and the secondary impact is worse than the primary impact. There are so many hypos and hypers happen when the patient get admitted in ICUs or in critical care areas like hyperglycemia, hypoglycemia, hyponatremia, hyponatremia, hypothermia. There are infection. There are so many things we do or we do not monitor them or we miss them, and that leads to the worst secondary impact than the primary impact. So it lands with the longevity in ICU, it lands in the more morbidity and more mortality. And then we start running around to save that patient. Now, first thing, what is mean by deterioration in a neurological condition? Very frequently asked question, what is mean by my patient is neurological deterioration? So there has to be the drop in GCS, or there is any new motor deficit is happening, or someone noticed, generally junior doctors who are at the bedside or the nurse noticed that there is some motor deficit is a new one happening in a patient, or there is a pupillary size increases, or there is a pupillary asymmetry increases, or asymmetry appears, or there is a change in the vitals like heart rate, suddenly there is a tachyarrhythmias, bradyarrhythmias, hypertension, hypoxia. There are so many things happen. And if you see, except your physiological parameters like a pulse, BP, respiration, and oxygen saturation, all are not continuous monitoring. You have to go to the patient. You have to examine the patient. You have to do the frequent neuromonitoring. Then you can only pick up the drop in GCS or any new motor deficit or any pupillary change or any size in change in the pupils or the reactivity. Only the blood pressure, heart rate, ICP, these are the generally tried, which gives you the idea that it's a continuous monitoring and you can pick up the neurodeterioration. Now, what is the average time they generally deteriorate? Generally, if there are so many trials, they show from 12 hours to the 72 hours is the maximum deterioration, but up to 10 days they may deteriorate. So your patients gives you the idea that how long you should continue the neuromonitoring. You can't say that the first 24 hours there is a maximum deterioration, so after 24 hours you'll withdraw because cost is increasing. No, you need to go through the patient. You need to find out whether this patient might need another 1 week of the monitoring. Few patients may need 24. So your neuromonitoring starts with the 12 hours, may increase up to the 10 days. Now, which are the neuromonitoring techniques? GCS is still gold standard. Whatever the scoring systems are developed and coming, but the GCS is a still gold standards in a strongly recommended GCS. You need to follow the GCS of the patients in all neurological emergencies like traumatic brain injury, SH or IC bleed, and the strokes. Numerical pain scales are the still strongly recommended to know that what is happening with your patient. If your patient is unconscious or if the patient is in a vegetative stage, then you can apply the NCSR score. This is very specific, this thing. Or you can apply the RAS score to know that what is the level of the sedation. Now, why it matters? It matters because there are so many limitations. If you see, except your physiological parameter, the ICP is a continuous neuromonitoring, but your all other deteriorations are the not continuous. You have to go at the bedside and check the neuromonitoring. And what are the issues in ICUs? Issues in ICUs are too many. First thing, the level of consciousness is ever changing. There are a lot of altered level of sensorium happens in a neuro patient. Second thing, there is somebody is doing some procedure, they give sedation. Patient is moving for the imaging, they give sedation. Patient is going for any other procedure, they are giving sedation. So there is a lot of variability in a conscious level to monitor. And the most important part, in the morning, the junior most residents see the neurological condition. In the afternoon, the senior residents see. In the evening, the nurse see. Again, there is a lot of subjective variation. There is no continuous sustainable neuromonitoring in your ICUs and in my ICUs also. Nothing, no difference in tertiary care and at the PSC level. Everywhere, the neuromonitoring is done by whoever the available, irrespective of his experience, irrespective of his knowledge, irrespective of whether he's aware how to do the neuromonitoring. And on that basis, we have to judge, we have to come to the conclusion that the patient is neurologically deteriorated or patient is more or same. So how ideally neuromonitoring should be done? Neuromonitoring is the umbrella of the monitoring system. It is not the one system. I cannot say that I will only monitor the ICP. I will only monitor the TCD. I will only monitor the optic nerve sheath diameter. It's an umbrella. It's an art. You have to choose your monitoring device as per the patient diagnosis, deterioration, his age, and the imaging finding. There are so many things besides. Like if you want to monitor the only pressures, like in a traumatic brain injury, ideally the ICP and CPP, they are the related with the pressures. If you want to monitor the blood flow, TCDs are there, local as well as the global. If you monitor the metabolism, cerebral metabolism, you have to monitor. If you want to monitor the oxygen pressure in that particular region, you have to monitor the partial pressure of the oxygen in the tissues, of the brain tissues. Or if you want to monitor what is the functional status of the brain, you have to do the EEGs. Now, in a single traumatic brain injury patients, I may do the ICP monitoring, I will do the CPP monitoring, I may do the partial pressure of the oxygen, I may do the EEG, because that particular deterioration, I need to find out what is exactly happening with the patient. I will come to this with the very nice example how these various monitoring helps to pick up the deterioration. You have to pick up the deterioration as early as possible so that we can prevent the worsening and maintain his neurological status. Now, I will not go into the detail of the various ICP monitoring techniques and the sites. All these are textbook. What's more important thing is how really, in real ground level, you are doing the neuromonitoring. Like one of the commonest is the interventricular shunt, because it is the way where it is the both way you can use. First thing, it is easy to do. Bedside you can also put. Second thing, you can give the diagnostic as well as therapeutic, like you just measure the ICP, your ICP is raised more than 25, you can drain the CSF, your ICP will come down. So it is a diagnostic as well as therapeutic, but it has its own side effects. One of the major is the invasive procedure. It leads to a lot of complication, bleed, and itself is a source of the infection. So if the ICU has a high rate of CRBSI, this is relatively contraindicated. It is one of the quality markers in a neuro ICUs to do the infection rates in interventricular drains. Now you need to understand the relation in between the both. Like there is no always linear relations. Like after the certain stage, your ICP will raise and suddenly it will go to the peak. The brain has a capacity to compensate for the pressure and the volume changes. And it changes as per the age. What do you mean by that? Look at the three.
in pediatrics age group, it has a less compensating mechanism. On the rise, when you become the more older or in a geriatric patient, it will have the less impact. It can compensate a lot of pressure changes in the brain. So geriatric patients will deteriorate less rapidly as compared to the pediatric patient. And we are all youngsters and the adults are in between. So you need to understand the relationship of the age with the change in the volume and pressure of the brain, and how fast they can deteriorate or how late they can deteriorate, and what are the compensating mechanisms. Now, at least, like we all talk about the ventilatory graphics. We talk all about regarding the various pressures, alarms. The same thing ICP, it is so easy to monitor. So there are the 3 waves which can easily, you can identify on the, it's like a ECG monitoring, like a PQRS. So there is a P1, P2, P3. P1 is always on the spike. It is representative of the arterial pressure. Okay. Your patient is deteriorating. You can pick up from the waveform. Your P2 is higher than the P1. That means P2 is spiking more than the P1. That means your ICP is raised. And if your P2 and P3 both are spiking more than your P1, that means your ICP is critical. And if you're not able to identify the P1 and P2 and P3, and there is just linear correlation, that means the patient has reached to its highest ICP. Might be he's heading towards the coning. So your simple monitoring, like a ECG monitoring, you can pick up whether your patient is deteriorating. No need to see your readings. Like we know that the ICP threshold is 25 now. So if the more than 25, I can treat, I can give additional doses of the osmolar therapy, I can do the prop dop, I can give the additional doses of the paralyzing agent, and I can go ahead with the barbiturate coma also. But look at the monitor, Monitors gives you the idea very clearly whether you are dealing with the raised ICP or your ICP is under control. And the simple graphical analysis can give you the idea about the ICP raise. And there is a limit. If you see the ICP raise, when it goes to the peak, like suppose ICP raised to 50, it is its limit. It will not go above the 50. After the 50 or the highest, or when it reaches to the peak, your cerebral autoregulation takes into the picture. They take the control and it start dropping the ICP. Then you will get the plateau and then you will start. In fact, after the certain raise ICP more than 50, your ICP will start dropping. That means patient has been coned. So this type of the images gives you the idea of what way you are dealing with the neurodeterioration. Now the next question, very frequently asked question, how long we should do ICP monitoring? Now the problem with the ICP monitoring, I'm talking about the invasive ICP monitoring. It's a costly. It has to be the infection risk is always there, complication rate is high. We cannot go for the independent period. Ideally, it should go for the maximum 72 hours, because in that 72 hours, prognosis decides either patient will survive, patient will improve, or patient will deteriorate. Or even as fast as possible, within 24 hours, if your imaging is reducing revealing the reduced ICP, you can go ahead with the withdrawal of the ICP. Because see, we are having a lot of problem in ICUs in monitoring the invasive ICP, the cost factor, infection risk, complication, and we have a lot of phobia. That the problem with the invasive ICP, it is a still gold standard in the management of the traumatic brain injury, but we have technical, financial, skill, person availability. We have a lot of problems with the ICP monitoring. That's why nobody talks about the invasive ICP, leaving aside very few centers like a Medanta. And we should know the difference. Now somebody will say the ICP monitoring, invasive is the gold standard. There are 2 ways. Either you can have an intraparenchymal bolt or you can have an intraventricular this thing. Both has advantage and disadvantage. Intraparenchymal bolt, they are the more accurate. But the problem with them that infection rates will be high. Intraventricular this thing, they have diagnostic as well as the therapeutic application, but the infection rates is high. So they are more accurate as compared to the non-invasive. They are more costlier than the non-invasive, but the infection rates are very high. And just now the Dr. Mehta finished how to control the sepsis. And if our current status of the sepsis in all Indian ICUs is this one, Can you imagine how to do the ICP monitoring in those settings where your CRBS rate is more than 2.5 or 5? Then you are in a trouble. You are not offering the good solution to the patient. You need to go for the non-invasive techniques. And there are so many non-invasive techniques. Now they are time tested, they are reliable. They, at least you can use excellent screening unit. What I say as a non-invasive ICP, like you can do the optic nerve sheath diameter, you can do the pupillometry, you can do the transcanal Doppler, you can do the EEG, you can do the CT MRI. There are also the ICP monitoring non-invasive ways of the knowing the ICP. And if you look at that, the pupillometry stands high. It's a portable. It's not very costly. At present, it's costly, but it will come down. It is easily one can get trained. And there are so many other advantages, and you can do the more frequently with the ICP monitoring. So optic nerve sheath diameter, pupillometry, and the transcanal Doppler are the time-proven, evidence-based, non-invasive techniques of the ICP monitoring as compared to the EEG and the imaging. And now that's what this next paper, which was recently published in the Neurocritical Care Journal, pupillometry, TCD, and your optic nerve sheath diameter. These are the three techniques, are evidence-based techniques. By the expert has given a consensus on that. Now, when to do it, how to do it, what are their timelines, what are the parameters, how frequently we should do it. That's what entirely very nicely elaborated in this paper. I will advise you to go through that. And they had given the guidelines, like if your pupillary index is more than 4, that means the patient is better. If your TCD is less than 22, patient is better. Optic nerve sheath diameter less than 6 is, then your patient is doing well. Your pupillary index is less than 1.3, increase. So when you are doing the regular pupillometry, if your index is dropping, that means ICP is raised. Something is happening with the patient. It has to correlate clinically. In day-to-day setting, patients are edematous, there are the orbital trauma, there's a subjective variation. I told you now, in the morning, junior resident, in the afternoon, senior resident, and in the night, somebody else is doing, then there is a problem for the pupillary activity. ICP already I explained. Cerebral autoregulation, I will discuss this at the end with the one of the excellent example where we are now, and we should aim for that in India soon. Brain tissue oxygenation, yes, it should frequently done. Now there is a myth. ICP is not the global representation of the brain in a traumatic brain injury. ICP is local. So ICP normal doesn't mean that your patient is don't have the raised tension and there is a aerobic mechanism. There is a recently CETAL guidelines for the traumatic brain injury in 2020 are published in the Intensive Care Medicine Journal. Please go through that. They are very nicely categorized into the 4 group: normal ICP, normal oxygen brain tension, normal ICP, reduce oxygen tissue, raise ICP, normal your tissue oxygenation, raise ICP, and then raise that. They have divided the all traumatic brain injury into the 4 quadrants, and accordingly you have to target. So your normal ICP doesn't mean that your patient is doing well and he will not deteriorate. And your increased ICP doesn't mean that your patient is heading towards it. You need to do the combinations of the neuromonitoring technique to get the real idea about what is happening to the brain, whether it is a local or whether global problem with that particular brain. Cerebral formating already I have discussed regarding the transcanal Doppler. EEG must. Every ICU should have EEG. EEG is not for the only diagnosing the epilepsy. If your patient is not waking up without any reason, always suspect the NCS in the neuro ICUs. Do the EEG. Your rewarming patients in a post-cardiac arrest, you should rule out the NCS by doing the EEG. So there are many indications where the intensivist can play major role in diagnosing with the help of the EEG. I will not go into the much detail about the cerebral metabolism or anything. I want to discuss a very nice example. This is what done in a Cambridge University. Now look at in this patient. This is very nicely done. This patient of the severe traumatic brain injury. CPP is near normal, 50-60. ICP is near normal, less than 25. Your PR index, it is known as a perfusion reaction index. is high, it is more than 1, it is a marker of the cerebral autoregulation. That means this patient has lost the cerebral autoregulation and there is a problem in the cerebral blood flow adjustment by the brain, and his tissue oxygenation is low. Now, if you see, ICP, CPP, and these things are doing well, but your patient is not doing well. So what they did, they just added the noradrenaline. They added the 5 ml per hour noradrenaline titration, raised the BP to the 130, and look at your CPP is raised to the 70, 80, fine, no issue. Your ICP is almost in a range, fine, no issue. But your perfusion reactive index comes to the 1. That means the brain has reversed its autoregulation and patient did well. And that is what the beauty of the neuromonitoring. You need to choose your device from patient to patient and as per your neuromonitoring, as per your clinical judgment, and give him the best chance for the survival. Yeah, that's what the aim. We have to do it in time. We have to do it within 24 hours. You have to choose your devices, monitoring devices, combinations as per the situation, and you can prevent the secondary brain injury. Our targets in all neuro ICUs should be to prevent the secondary injuries to the brain for the better survival of the brain. Thank you. Any questions?
Thank you for the brief detail about the neuromonitoring. Now the house is open for questionnaire.
Okay, thank you, sir.
Yeah, thank you.
Thank you for a nice presentation. I request our chairperson, please felicitate our speaker with the memento. And I request our chairperson, please collect their mementos from the memento desk. Dr. Manoj Gujjar, please present mementos to our chairperson in the memento desk.
The next session is antimicrobial panel, and we invite Dr. Harish to moderate the session. He is a director at Kaveri Hospital, and we all know him for his online masterclasses.
And the panelists are Dr. Yatin Mehta sir, Dr. Kapil Zirpe sir, Dr. Pradeep Rangappa sir, Dr. Manish Chauhan, and Dr. Pankaj Omar sir. Please join the dais as a moderator. Over to you, sir.
So, good afternoon, all. So, we are aware, like in the last 1 decade, so lots of different permutation combination of antibiotics came into our clinical armamentarium, but some like vanished very quickly. So, we have a different resistance pattern, clinical utility. With this background, we'll initiate our first question to Dr. Yatin Mehta. So, as I told, like newer agents we got, but what do you feel why they are failing in terms of like the restriction is because of the resistance, toxicity, cost, or maybe something else? Because we are still having the burning issue of drug resistant organisms. We are not able to tackle them at the bedside in a very good way. What do you feel? What may be the problem still we are having?
See, one has to. Yeah, one has to look at it holistically. Some of the newer antimicrobials, which undergo R&D and clinical trials in the West, may not be that effective here in this part of the world. For instance, if you look at the new carbapenem combinations, I'm not going to name any particular ones, but Weber-Bactrim and Zinobactrim along with some other carbapenems, that is primarily effective against KPC. That's not going to be effective in the Indian scenario because KPC is hardly existent in India. So I think one has to look at it from that point of view. Also, cost is a major issue. I think we have to take into consideration, particularly when you are using it empirically. If you're giving a guided therapy, that's a different matter. Antifungals, some of the newer antifungals, the basic resistance has been because of not efficacy, for instance, isavuconazole, but basically because of the cost. So I think even the Western pharmaceutical companies will have to bring down the price because the market is bigger. But we must realize that antimicrobial resistance is high. So what needs to be done empirically, that also needs to be kept into mind. Also, a couple of days of extra stay in the ICU is going to add to your cost. So if we are hitting something which is appropriate, I think do that, absorbing the cost, because that will circumvent the cost of the thing. So one has to keep that also in mind.
Truly agree. So basically, we need to understand our organism profile and the cost involved. So then we can do justice which one to choose, even though we have lots of agents in the bucket kind of this one. Suppose when you adopt any sort of newer agent in your unit, so do you adopt any different policy in terms of de-escalation? You speak to the formulary, and like you do something in terms of diagnostic modalities different, or you straight away, okay, this came into the market and we'll try it out? What is your policy kind of?
See, when there is a newer agent, most of which are more expensive than the existing agents, we have a restricted prescription. That means every resident cannot prescribe those drugs. Only the authorized people will be able to do that. Obviously, they have to fill in the justification form why they're using that drug. As long as they're justifying it, it's okay. And we must take into consideration the diagnostic stewardship is as important as therapeutic stewardship, antimicrobial stewardship. Because if you're using high-end, newer agents, I think it must be supplemented by molecular testing. So if you have the facilities, you must use it, because again, don't take into consideration the cost of only the testing method, but also take into consideration you will be able to de-escalate. So we must do that.
So definitely, so we need to think like in terms of increasing our capacity to diagnose. So lots of data is there, multiplex PCR, lots of technologies which we got in terms of the biomarkers and the PCR technology and all. To move on to Dr. Kapil Zirpe, so we know that in India, in Asian countries, we have a burning issue of gram-negative organisms. But when it comes to gram-positive organisms, like, so we have a INSAR data which shows there is an increase in prevalence in the recent years, even in gram-positive resistant organisms and all. So what is your experience on using newer agents when it comes to gram-positive, particularly MRSA, MSSA organism? So we got a couple of agents. Can you comment on that?
Yeah, first thing, there is no gram positive in ICU. There's hardly in a hospital acquired infection you get the gram positive. Gram positive in the community. But if you get a gram positive in a hospital or hospital acquired infection, MRSA is more than 50% resistance. So that's the problem with the MRSA. And then we need the agents which are time tested. Though vancomycin is still the gold standard. Like the newer, I will talk about the daptomycin, I can talk about the levonorofloxacin, I can talk about the dalbavancin, I can talk about the ceprolin. So these are the four, this thing. I have experience with the levonorofloxacin because it was launched and I think in a COVID or pre-COVID era, it's a Indian molecule. It was the first Indian molecule manufactured and in a market. But unfortunately, it lost its effect because of might be the over publicity or misuse, because it has a gram positive as well as the gram negative coverage, and probably they lost in their indications. So nowadays we are not using, and there are the lots of other issues I will discuss in the next part of the levonorofloxacin. Dalbavancin is available in India. It's a good gram positive sidal drug. One of the major advantage of this drug is a long-acting drug. So you can do the lot of drug profiling, and another advantage of it is it works in the implant biofilm where the vancomycin has a doubtful role. So if you ask me, I have the only one patient experience, but it is not enough to talk about much about this molecule. But the third molecule, ceftaroline, the 5th generation cephalosporin, I will talk a lot, because it comes as a community-acquired bacterial pneumonia. This is one of the major indications. If you see the all IDSA guidelines, ceftaroline is the drug of choice. And I have recently came across the back-to-back 2-3 cases where the H influenza complicated with the MRSA, and we have tried the ceftriaxone and it works very well. So you need to be on a toes, and that's what the when influenza patient comes with the bacterial sepsis and the multi-organ failure, you need to do the both panels, bacterial as well as the viral panels, to pick up those secondary infections. Don't be always that Acinetobacter or Klebsiella or MRSAs will not be there in H influenza prone cases. They are much more common in this class of the patient. And the daptomycin, yes, daptomycin is proven. Daptomycin is for the bacterial endocarditis, is a good drug. But I will not use in bacterial pneumonias. That's what we stand at present regarding the gram-positive in ICU and the community acquired.
Yes, definitely. Even though we have agents to cover gram-positive, the problem is limitation in terms of thrombocytopenia, in terms of predicting their PK/PD when it comes to glycopeptide, that is a vancomycin. We need a trough level, peak concentration, increase in their MIC, what we call it as an MIC creep. So that's why we got couple of agents which came for MRSA, though India mainly we have a gram-negative and all. Again, to come back to gram-negative organism, to Dr. Pradeep, so we have some sort of BLBLIs. Again, in the last 2 years, one agent which came into market is cefepime enmetazobactam and cefepime zidabactam, which is going to get launched maybe in couple of months. So suppose these two agents, if available, where you want to fix them in your clinical practice?
Yes, I think both are interesting molecules. Like cefepime enmetazobactam came pretty recently, and zidibactam is being developed by Indian company. So I think what we need to understand is any new antibiotic that comes in gram-negative, obviously there is so much of resistance, and we are at the forefront of resistance. We need to see whether there is a overrepresentation of certain BLBLIs in our usage. So if you look at the usage, obviously there is a overburdened usage in piperacillin, tazobactam, generally amongst the clinicians. So there is a role for these newer ones, especially cefepime zidobactam, because there was a good study that came in JAMA where they compared with piperacillin, and it was shown to have any new antibiotic, MICs will be low because of having not been used. And this particular zidibactam, which is there along with cefepime, it seems to have a longer half-life and some zwitterion sort of an activity. Its penetration into periplasmic membrane is found to be more effective. And the clinical study that came in JAMA showed non-inferiority, although it did not show superiority. So having said that, this has a role in OXA48 also initially. So I think this has a positioning mainly in complicated UTI at this point of time, or hospital-acquired pneumonia, and VAP and bacteremia as a carbapenem sparing, and some effect on CREs also, especially OXA48 is what the evidence is at this point. So we need to gather more of a clinical sort of a experience with this cefepime enmetazobactam. And zidibactam, I think they are doing a trial, so we wish to see what the outcome of this, and possibly that will also have a similar positioning as compared to cefepime and enmetazobactam. So, but we had to be wary when we're using cephalosporins. Always our concern is about the inoculum effect and MIC creep that tends to happen with the usage, especially in ESBL. Because as of now, we can position it for this, but we need to be wary of the inoculum effect. Although the claim is with cefepime, the inoculum effect is low.
Yes, correctly. So these two agents definitely placed above the most commonly abused antibiotic, that is piperacillin tazobactam, and near to a carbapenem sparer kind of this one. Particularly data is in complicated UTI, but bacteremia, VAP, HAP and all, we need to get more data. Move on to Dr. Manish. So we have two more agents in the last couple of years back. One is plazomycin, one is arbicacin. So what do you want to comment on these two agents? Can we place in our clinical utility which patients?
So, like both of the molecules have been, positioned as new aminoglycosides, which has been marketed as a single daily convenient dosing and having lesser nephrotoxic and other side effects relative to the older aminoglycosides. If I go for arbicacin, not much experience. We've got a lot of almost all the data is from Japan and Korea side, which has not yet been validated, and it has been positioned as for both MRSA and Pseudomonas, the molecules. But yes, recently plasmamycin I've been able to use in 3 cases, and again it is again positioned as something. I would say what they say, the only study is that it's non-inferior to meropenem in cases of complicated UTI, but the strict usage is for complicated UTI, which is recurrent and has been provenly resistant to other medications like we use, like meropenem and let's say ceftriaxone, avibactam and all. One pyelonephritis and two complicated UTIs results were good, 2 smaller number were there, but general, I think, word of caution would be that, as Dr. Yatin also said, that we use them in very, very restricted form where we have culture proven sensitivity. All 3 of these were such cases only, but because we don't want to lose them out like we already have lost, let's say, ceftriaxone, avibactam, and obviously in the past, meropenem and all. But I think we still need time with these
Yes,
drugs.
definitely. When we got these so-called next generation aminoglycosides, thought process was in terms of coverage, toxicity, and mainly the comparison in terms of resistance origin, because there is a like enzyme called aminoglycoside modifying enzyme. So they claimed, they proved on paper, these 2 agents, they are resistant to the resistance which is created from this aminoglycoside.
They are able to overcome the AME resistance, and it doesn't affect them, and they act
So,
on the 30.
yeah, that is one advantage. With that background, they came into market, but so not so much of use other than the complicated urinary tract infection. Move on to Dr. Pankaj. So
Harish, can I just add for plasmamycin? I think the main argument is the PB3 inserts in Indian E. coli. That is what the studies, CMC Vellore study showed. Because all E. coli in India, 96% have PB3 inserts, and they are resistant to ceftazidime avibactam. That is where the positioning of plasmamycin is being contemplated.
Those organisms like KPC, AXA48, so this is able to cover with that of the plasmamycin kind of. So Dr. Pankaj, like when we got ceftazidime avibactam, 2 more agents we were expecting actually. Got cleared FDA long back, but not entered into Indian market. So one is meropenem vebarobactam, imipenem relibactam. So are you looking forward, like are we having some space for these 2 agents, or what is your take on these 2 molecules?
Actually, again, because these 2 agents, they are more active on the KPCs, which is not that common in India. And moreover, there is concern regarding meropenem vebarobactam is on effectivity on NDM, which is more common here in this part of world. So probably once they are launched, and cost effectiveness is one part, which is might be governing the uses in Indian context. So probably we might be having them at par, probably ceftazidime avibactam or like that kind of thing. So more studies are required for their effectiveness in Indian context, because we are more having more prevalence of NDM bacteria here in India. So that is one point.
Yeah, that is true. So we are not so excited for meropenem vebarobactam or imipenem relibactam because we have a problem with metallobetalactamases. So even though we got these 2 agents, they are not going to cover acinetobacter and they are not going to cover metallobetalactamases. Right. So I don't think we have a space for them. Again to Dr. Pankaj only. So to touch on the newer antifungal. So again, it has been introduced during the COVID, isavuconazole. So what is your clinical experience on isavuconazole?
Isavuconazole is a very good drug, and it does not require TDM, and toxicity effects are also very less. So it has replaced so many things like in aspergillus and of course in mucor also. And the effectiveness is good, dose monitoring is not required, interactions are very less, and economically it is okay, not bad. So definitely it's a good drug, and which is taking up most of the toxic antifungals.
Definitely, yes. This is a new generation, next generation azole. So when we have a voriconazole, the problem was toxicity, QT prolongation, drug interaction, so CYP enzyme interaction and all. Isavuconazole available as both oral and IV. So it is one of the very good option for a maintenance therapy for mucor. If you induce the therapy with amphotericin B, so it serves the purpose as a oral therapy, but it is available as a prodrug. So now it is cost effective also. There are lots of players in the market. So again, move back to Dr. Kapil. So, like you are mentioning like 2-3 agents, like can you comment on commonly available 2 agents? One is levonorepinephrine and dalbavancin. So, what is the take, whether they are going to sustain for prolonged time in terms of the gram-positive coverage in Indian scenario?
See, if you see a levonorepinephrine, I was involved in every trial in what happens in India before the launch and after launch. Yeah, I have the huge experience with the levonorepinephrine. It is an excellent drug. The problem is the moment you cross the border, that means you are extending your indication. It is excellent for the diabetic foot. It is excellent for the skin and soft tissue. This thing. The moment you try to use in a septic shock or sepsis or bacterial endocarditis, yeah, and that's what they did. I always had a lot of discussion with those company guys. Ki, why you are promoting this drug? It is excellent drug. It is one of the advantage of the levonorepinephrine. It has a gram positive cover. It has some gram negative cover. So empirically, you can place very nicely levonorepinephrine. Second thing, it has 100% bioavailability with the oral forms. So you can continue for the prolonged period. And there is a less toxicity was there and resistance was available. But I don't know the current situation, but over the period, they started using left and right and probably lost their place where we can do. But that drug was a good drug. I still maintain my statement that drug is still, if you use in a particular indication, it is a wonder drug with the less cost, Indian this thing, and good viability. So you can switch over the oral confidently. Okay, nothing will be your offering less to the patient. And regarding the
Dalbavancin.
I don't have much experience. I said I use in a one patient, but again the cost. So we have to see the cost again the dosing. Advantage is a long acting drug. So once in 3 days, once in week you can use, but cost is 38,000 or 32,000. So we have to just, if you are exhausted with the all your drugs, or it is particularly you are dealing with the biofilm in the implant situation, then this drug is good. So these are the two drugs with the two situation, but I am still ready to bet on a levonorepinephrine, provided they stick up to their original indications where it was launched.
Yeah, by convention, see, our approach is we want to give antibiotic every day in a sicker patient. We are not convinced with dalbavancin when it comes to give one dosage, and that's enough. Very difficult, even though we have some proven data on paper. Cost now it is reduced. It's around 10,000, 11,000. It is available with different company. Dr. Pradeep, one question is we learned about many things, newer BLBLI, newer antibiotics and all. Do you feel other than antibiotics, is there anything going to come in the near future in terms of treating or an adjuvant therapy for infected patient?
Yeah, I think that's a good question for future. So I think there's a lot of buzz that's happening on bacteriophages, if that's the dimension that we are looking at. So just for the audience, bacteriophage is targeting any modified virus or a bacteria against a specific bacteria, which are mainly resistant in nature. So there are trials. If you look globally, there are trials, mainly successful trials and approved indication is for Pseudomonas in cystic fibrosis as an inhalation, and it has got an approval. But when it comes to other systemic therapies, there are trials on E. coli and Staphylococcus aureus. So that is one group, bacteriophage. So it is emerging and it is evolving. Maybe in next 3.5 to 5 years, we may have these inhalers for Pseudomonas in cystic fibrosis, although the burden of cystic fibrosis in India is less. But what our interest and excitement lies in E. coli and maybe Staphylococcus. There's another dimension called lysins. So this is another new components that are evolving. But we still have, we need more evidence and more science and more sort of a regulatory authorities that they need to circumvent before we get it into our clinical practice. But bacteriophages are something to look out for. And there are these lysins against Staphylococcus and bacteriophage against E. coli. There are ongoing trials for that. You can look up into it. So these may have certain roles in the future.
So definitely we have to look forward for many other therapies. Last question of the panel to Dr. Manish. So one molecule which are eagerly waiting, that is the cefiderocol. So what is your thought on that? Is it going to fill the lacuna what exists in terms of the newer therapies which we have in India?
Yes, certainly. I had been able to use it in a few cases because it is only available through a special requisition. And fortunately in Delhi we have people who can afford and the right connects. So been using it for past couple of years. Definitely because of its unique action, it's a sider-4. It bypasses the PBB mechanisms, the PB3 lateral resistance, and goes mimics the iron and inhibits cell wall synthesis, which makes it quite unique in the form. Again, now the problem, as sir said, for levothyroxine, for other drugs like ceftriaxone, avibactam, is the overuse. Okay, only if we are able to, restrict its usage till the apex drug, because it has worked well in many of our patients. It has salvaged many of my patients in the past couple of years. So the positioning has to be right. Definitely will fill the lacuna out there. I think the only reason why it is still working with us is because it's so difficult to get hold of it and so costly. I am not definitely won't say that those who cannot afford it should not get it, but it should have the proper restriction in place to use it. But for the ESBLs and the MDRs and all, it can be a vital drug, definitely.
Thank you all the panelists. Cefiderocol is one molecule even I am waiting, because it had a coverage for Acinetobacter, it had a coverage for all sort of metallo-beta-lactamases and other non-lactose fermenters also. With this, we'll conclude here. Any questions? Any comments? Yeah. Thank you all.
Regarding, I think one anti-molecule that is Elores, ceftriaxone, UTA. Any?
See, basically, Eloris has been marketed as an antimicrobial resistant breaker. So, because it's having a metal chelating agent kind of this one. So, theoretically, they proposed many proposals. Even it has been proven in vitro in terms of resistance avoiding, because it is going to chelate the zinc. Thereby, it will avoid the origin of resistance to metallo-beta-lactamases and all. It helps in penetrating the biofilm. Okay. And it is having a coverage inside the anaerobic acidotic environment and all. With that background, so in India they tried to club the EDTA with meropenem, all sort of combination, but there is no global rationality for that molecule. Even though we used Eloris not as a primary in a sicker patient, as an add-on only for avoiding that resistance. Most of the data is in vitro. In vivo, very less data kind of this.
Just to add to your question, I think another concern is it has sulbactam at a 500 mg, in the vial, and that is a very low dose. So one has to be concerned, because if you are using sulbactam targeting Acinetobacter, the suggested dosage is very high, 3 grams, 6th hourly, 8th hourly. So you are underdosing some sort of a component against a antibiotic may lead to resistance creep. So I think that is a concern with usage of such combinations.
And major concern is, if you want to prevent the further resistance in our community or in our ICUs, stop irrational combinations. That is one of the antibiotic stewardship. Stop the irrational. Just meet your drug store in charge and the management and the CEOs and categorically stop the irrational combinations. And there is a list of the irrational combinations on the website is available. You can go through that. And please stop that, because the doses are inadequate. Like he rightly said, sulbactam for Acinetobacter is 3 grams something 8 hourly. We need to reach the 12 to 16 gram. And what we are giving 500, what will happen? Resistance will happen. Nothing, no magic will happen with that particular Acinetobacter. So all these irrational combination, first, the one request I will do to the entire audience, go back and stop the irrational combinations from your drug formulary.
Thank you. We'll close the session here. The further discussion we can do during the leisure hours. Thank you.
Thank you, sir. I request our panelists, please give memento to our moderator, Dr. Harish. To move next session, I request our chairpersons, Dr. Ajay Govardhan sir, Dr. Girish Ramole sir, Dr. Manoj Rai sir, Dr. Rajesh Singhal, Dr. Firoz Memon. Please join the dais. I repeat, Dr. Ajay Govardhan sir, Dr. Girish Ramole sir, Dr. Manoj Rai sir, Dr. Rajesh Singhal and Dr. Firoz Memon. Join the dais as the chairperson. Please. Over to chairpersons.
For the next session on toxindromes in ICU neuromodalities, I request Dr. Pradeep Rangappa to share some light on that. Sir is a senior consultant at Manipal Hospitals, Bangalore, and he has led numerous workshops, conferences, collaborative platforms, both nationally and internationally. Sir was past Vice President ICCM and is also Secretary ICCM Bangalore chapter.
Okay, yes, so, good afternoon, friends. So,
I
thanks,
request
Vish.
Dr. O.P. Sundarani, sir, please join the dais as a chairperson. Over to you, sir.
Yeah, good afternoon, everyone. So, outset, wish to thank Vishal and Team Raipur for having me here. So, just to talk about this very huge topic, in fact, we can have workshop for 2 days on this particular topic. It's a bit of challenge. So I'll try to give you an overview as to how one could approach these toxic drones in ICU. So when you look into the whole categorization of toxic drones, we can look at the drugs that cause sedation, obtundation, and stroke, and certain toxins that causes agitation, and toxins that causes seizures. This is mainly from the neurological perspective, and the toxins that causes movement disorder and akathisia and encephalopathy. So this is, when we talk about toxidromes, we need to categorize in some format to try and recognize the toxin and look about management. Or we could look at the drugs that acts on the brain, on the spinal cord, or the ones which penetrate blood-brain barrier and cause problem, or at the neuromuscular junction. So there is some sort of a categorization that needs to happen when we look at type of toxins that we have in question. So when you look at toxidrome classification, so you can look at anticholinergics. So these are the examples which predominantly cause delirium in a patient, or tricyclic antidepressants, and antipsychotics, which are haloperidol and thioridine, or antiemetics. So they all come under anticholinergic when you look at toxidrome classification. Then there are cholinergic, which we see commonly in India, which is OP compounds, which we deal with more commonly, malathion and phenthyon, or nerve gas, which not necessarily we see it very much here. And the third component is opioids, mainly heroin, morphine, codeine. So there is an increasing surge in the usage of these in our Indian population as well, and opioid-like, which is clonidine and clonazepam. So these are the sort of classification you can look at, which acts on neurological. And there are sympathomimetics like adrenergics, like cocaine, amphetamines, and phencyclidine, which again cause a lot of neuropsychiatric sort of a disturbance. Then you have other compounds which we were using before, like theophylline, which come under xanthine category. And then there are the antidepressants like noradrenaline reuptake inhibition, like long-acting sort of an antidepressants. Then you have the fourth category, which are sedatives and hypnotics like alcohol, barbiturates, benzodiazepines, and miscellaneous. So this is the way we could categorize to try and group them in different baskets when we are treating toxidromes. So the common manifestations of CNS toxicity of any of those drugs, what you saw, can be agitation, can lead to delirium, can be stupor, and can lead to some sort of a coma. And for looking at the drugs that commonly causes seizures, you have a mnemonic, Otis Campbell. So you can look at opioids. T stands for theophylline, I stands for INH, S stands for salicylates, and C is cocaine, cyanide, and carbon monoxide. A, amphetamines, anticholinergics, metaldehyde, and P stands for pinems, because some of the carbapenems, as you know, imipenem, they can lead to seizures, and even levofloxacin, which we use commonly in our practice, can lead to seizures, and barbiturates. So this is just a mnemonic for you to remember and group the type of drugs that can cause seizures, and E stands for ethanol, and L stands for lead and lithium. So this is a mnemonic for you to recall as to what are the different toxins which can manifest with these sort of a manifestations. And generally, when a toxin is causing seizure, there is usually an imbalance between glutamate and GABA, which leads to GTCS. And then you have this tricyclic antidepressants, which predominantly act on the sodium channel, and cyanide acts on the brain by reducing the oxygen consumption and delivery. And there are theophylline and caffeine, which acts on the adrenergic receptor. So these are some of the mechanisms of the drugs which lead to seizures in patients. And encephalopathy, you have paracetamol, which leads to liver failure by causing accumulation of this particular enzyme. And then you have this cocaine, which causes leukoencephalopathy and increase in the brain lactate, which all leads to encephalopathy. And in Wernicke's encephalopathy, predominantly happens due to thiamine deficiency in patients with alcohol intoxication. So these are the sort of a grouping that you could think of. And when you look at the movement disorder, so you can have movement disorder pretty much with most of the drugs that we tend to use in ICU, which can lead to dystonia or akathisia. And these are the common drugs, tricyclic antidepressants, monoamine oxidase inhibitor or SSRIs, which can lead to this sort of a movement disorders. And cocaine addicts or opioids sometimes can lead to strokes, and amphetamine, because there is increased usage in urban cities like Bangalore or any urban cities, there's a lot of amphetamine usage. So all this can lead to strokes. So you have to look at this as a possibility when you deal with this. And of course, with IV drug abuse, you can have CNS infections. And the differential diagnosis for any of these sort of a poisonings, when they come, you have this mnemonic AEIOU, which you can keep in mind, and any of these can lead to any of these problems. So that is about the neurological toxidrome classification. So I'll jump into treatment a little later. So when you look into the ECG, there are toxicologic bradycardias with nystagmus, which typically happens in lithium toxicity. And the drug abusers like phencyclidine toxicity can lead to vertical nystagmus. There's only one drug which leads to vertical nystagmus, and that is phencyclidine. And bradycardia with nystagmus is lithium toxicity. And most of the blocks that can happen with any of the drugs that may be overdosed, like beta blockers, calcium channel blockers, or digoxin, can lead to any type of heart block. It can be first degree, second degree, or complete heart block. So if you have a patient with heart blocks, so at least try to see if there is an overdosing, and we are increasingly seeing overdosing with calcium channel blockers and beta blockers in our cities. So then there is toxicologic bradycardias, which can happen with QT prolongation with opioid, and you can have toxicologic bradycardia commonly in our country with the OP poisoning. So, and many a times you don't necessarily get the history because they do come with obtundation and bradycardia, so you may have to consider. And you can have toxicologic bradycardia due to tricyclic antidepressants and class 1A antiarrhythmics like quinidine, procainamide. So these are the common drugs which lead to toxicologic bradycardia. What about Brugada syndrome? We see occasionally where you have this camel hump sign in the ECG, and tricyclic antidepressants and class 1AC antiarrhythmics like quinidine, procainamide, encanide, or flecainide. All of these can cause toxicologic bradycardia. So there are distinct group of drugs that causes toxicologic tachycardia. So these are antidepressants. Any of the neuropsychiatric drugs like all this venlafaxine, bupropion, all this can cause wide QRS. And you would very often see TCA overdose in our practice. So be wary, always look into ECG. So ECG gives you a clue. Always look for R wave in V1. So it gives you a sort of it hints you or signals you towards possible toxicologic bradycardia. So R in V1, or you see R in ABR, you have to suspect there could be something. And class 1AC antiarrhythmics like quinidine, procainamide, encanide, all this can cause wide QRS and toxicologic tachycardia. And even antihistamines, we do get overdosing with antihistamines. They can cause wide QRS tachycardia. So then there are causes for narrow QRS tachycardias. So typically sympathomimetic agents and anticholinergics like antidepressants, antipsychotics, antihistamines, all of this cause toxicologic tachycardia and cocaine. So these are some of the classification or categorization of toxins which manifest with ECG manifestations. So for all the audience here, if you have to use ECG as a tool to identify toxicology, so you have to look at ECG and see whether this is a nice algorithms, whether there is an ectopy or no ectopy. If there is a high ectopy, if there is an ectopy, then it indicates there is 64% risk of acute cardiovascular events in these patients. If there is no ectopy, you have to look at whether there is sinus rhythm or no sinus rhythm. If there is sinus rhythm, look for whether it is normal QTC, then it is low risk. If it and 3.8%, they are at a risk of cardiovascular intoxicity. Then look at whether there is a long QTC. If they have long QTC, they are at a moderate risk or 26% of acute cardiovascular events. And if it is high QTC, more than 500, then they are at a high risk. So this is a ECG approach to try and see if patients are at a risk for toxicological sort of effects on the ECG. So this is a simple algorithms looking at QTC and ectopy as a means. So now we look at what is the newer sort of a developments that are happening in therapeutic modalities. Mainly when you look in 2024 and 25 evidence, it's more on extracorporeal therapies as a means to treat these toxicologies. So the one that is making noise, at least as a life-saving, is VA ECMO, because this any of the ECG sort of a toxins that you saw or which causes gross hemodynamic instability not getting corrected with conventional medical therapy, where there is cardiotoxic drugs, like we have done ECMOs for calcium channel blockers and beta blockers. So it is a life savior. So these are some of the indications. Any cardiotoxic drugs, gross hemodynamic instability, where perfusion is not getting better despite your best sort of a resuscitative measures, then we have mechanical support. So VA ECMO. So we have used in calcium channel blockers and beta blocker overdose. And what about the role of hemodialysis or CRRT? So they are useful in toxin removal, especially in small water-soluble toxins, especially like sodium valproate, caffeine, and other overdose. Hemodialysis, you have to look up into the literature whether the toxin that is taken is dialysable, and that is something that can be utilized as a modality. And hemoperfusion, for all the audience here, especially in India, we have a problem with paraquat. And paraquat is a killer. A sip of paraquat can kill a patient. So you need to be aware at least, is there a role for hemoperfusion, charcoal hemoperfusion in paraquat poisoning? So we have used in paraquat poisoning, charcoal hemoperfusion, or theophylline overdose, we have used charcoal, or barbiturate also you can consider. So, and we have these other newer filters, which are toxin removal filters that are available. And consider this, I'll show you the evidence in next 9 to 10 minutes about the role of these in hemoperfusion. And plasmapheresis. So plasmapheresis, we are having a lot of biologicals being used and immunotoxins. So plasmapheresis may be effective in certain removals, especially immunotoxins. So these are some of the newer sort of developments that are happening in poisons, which are unique to our country. So paraquat, I think most of the Indians are aware, one sip can kill, and we do see, I'm sure even in Raipur you would be seeing, because paraquat is available widely as a herbicidal drug in India. And people do come to us with this consumption. And what is the treatment? So this is a very unique poison where, you obviously take care of airway, breathing and circulation, but we can't give more oxygen to these patients with paraquat. Activated charcoal has some role if it is administered very early on, 1 to 2 grams per kg. But the problem is you can't give too much oxygen here because they have so much of oxygen-free radicals, and oxygen itself becomes diabolical in these patients, causing more lung injury and more aggressive fibrosis. So we can't give oxygen in these patients. You can put Ryle's tube, but you have to be very careful because it causes a lot of esophageal ulcerations and oral ulcerations. Sucralfate can be given. I'm not going into the clinical features, so there is a video of mine you can go and watch. So ventilation, you can give oxygen just about to maintain their normoxemia, but generally they become very hypoxemic because of a rapidly progressive fibrosis that happens in the lung. So they may need all this mechanical ventilation. If they get ventilated, you have to use arsenate, but maintain saturation just about enough, 88 to 90, not more than that, because they have rapidly worsening lung function, and they do have a stormy course with rapid iteration. When hemodialysis and hemofiltration, does it have a role in paraquat? Because anyway, these patients, whatever you do, the mortality is going to be very high. They go into multi-organ dysfunction with renal dysfunction, and they may need. So hemoperfusion, less than 4 hours, is shown to be beneficial. But I have to confess, we have used in our patients have not survived. So this is one study which I could get a reference, where they have used hemoperfusion for 7 sessions in 6 to 8 hours in less than 4 hours, and they could get the paraquat levels down and improve the outcomes of these patients. And there is a lot of role of immunosuppressants in paraquat poisoning. So the role of methylprednisolone, dexamethasone, and cyclophosphamide have been used to reduce the lung inflammation and the fibrosis, basically to reduce the inflammatory process, and they go into rapid lung fibrosis. And this is one study that we could get where they have used IV cyclophosphamide, 1 grams per day into 2 days, plus methylprednisolone for 3 days versus oral dexa, and they compared with the window to dexa compared to the placebo. And this is the largest study that you can find with the usage of immunosuppressants in paraquat poisoning. They had 300 patients. 147 were given this cyclophosphamide and methylprednisolone, 152 were placebo. If you look hospital mortality, there was no significant reduction. Although there has been a claim that this will help, but there was no improvement in hospital mortality. Even 3 months mortality, there was no difference. And they've used a lot of antioxidants like N-acetylcysteine at this particular dosage. And they have used vitamin C at 300 mg twice a day, desferoxamine to chelate iron to reduce free oxygen radicals and hydroxy radicals. And they've used salicylic acid, which is claimed to scavenge hydroxy radicals. All these are anecdotal case reports and case series. Right now, this poison remains very lethal. We don't have, so early hemoperfusion is the only way. But otherwise, there's not magical drug that can save lives in these patients. So they've used a lot of anti-apoptotic agents and anti-inflammatory agents. So they've used edaravone. So this is another molecule that has been used in paraquat poisoning. This particular study in 44 patients was shown to have protective effect on the kidney and the liver and delay the fibrosis. But there was, but these are all case series, so we can't make much whether this will help us save the patients. And there was no survival benefit. Even from this study, there was no survival benefit. What about ECMO? We have put our patients on ECMO, on paraquat poisoning, but unfortunately the results are very bad. So even with ECMO, they not necessarily will survive. And there are case reports of even patients going to the lung transplant. In fact, we had a patient on ECMO who wanted to go on a lung transplant, but when looked into literature, it is not at all encouraging, because even when the transplanted lung, they develop fibrosis with paraquat. So it is that lethal. So unfortunately, I don't have much answers whether we have any magical therapy, but you can use hemoperfusion. Early hemoperfusion maybe perhaps may help little bit in helping save your lives, and cost effectiveness of this ECMO and lung transplant is something that you need to really see. So that is one poison I wish to cover, because the mortality is very high, and despite all the newer advances that we have, that we failed to save these patients. So what about all these calcium channel blockers, beta? We are increasingly seeing, at least in our city, lot of antihypertensives being overdosed. So the whole question is, would you jump to ECMO because they'll be hemodynamically unstable, lactates will be high, or would you use all this sort of a therapy? The answer is, try to max on all these therapies, because this is very important in calcium channel blocker for audience. The type of insulin that you are meant to use, insulin with dextrose, is very high amount of insulin. I'll just show you. And glucagon levels, and many a times we have averted going to mechanical circulatory support with the effective usage of insulin with dextrose and glucagon. So just I'll show you the protocol that we have used. And so the summary is, you have to use calcium in these patients, calcium chloride at 10 to 20 ml for 10 to 20 minutes, 3 to 4 doses. And of course, you will start norepinephrine. Glucagon, you have to use at this dose 5 to 10 milligram for 1 to 2 minutes and 2 to 2 milligram per hour as infusion. And insulin, if you look at the dose, it's 10 units per kg per hour. So if it is a 60 kgs, you are using 600 units per hour with dextrose. And fat emulsion, there is a role which I'll talk about. So 1.5 ml per kg, 20% we use, and we use as an infusion at 0.25 to 0.5 ml per kg per minute for 30 minutes. And if all this fail, then you may have to go to ECMO. So the message I'm drawing is, you have to max out on these therapy, glucagon and insulin, because we have treated few calcium channel blockers where you max out on insulin at a high dose. Very often we sort of fear to go to such a high dose of insulin with dextrose, but we have to use it in calcium channel blockers to mitigate the effect, and try and avoid going towards mechanical, because once they go on ECMO, obviously there are cost implications to it. So the only message is, try to use, because all these are available, fat emulsions are available, and glucagon is available easily in India. So try to max out. Only once you max out, they are not getting better, then you move to ECMO in these patients. So that is the message for this. So now we are in India, we are having very interesting compounds. Recently, we had this particular patient coming to our ICU who looked blue, literally like a blue lady. And she's a 19-year-old lady. She's a biotechnology student, bioengineering student, who took this 10 ml compound. And this compound, there are websites, there are dark websites which these people are visiting, where there are compounds to help them to commit suicide. So which is very interesting for all of us, all doctors to be aware. There are dark websites which people are visiting to commit suicide in a safe way, and she consumes sodium nitrite, which is not easily available. It is available in the dark web as a comfort dust. It's called as comfort dust. So she came with a methemoglobinemia of 65.5% with lactate of 6.3. She was fully aware what this compound does. And she came with sodium nitrite poisoning. Basically, sodium nitrite converts ferrous to ferric salt, and this ferric salt cannot bind to oxygenation, oxyhemoglobin, and they become hypoxic. So they have reduced oxygen delivery and lactates go up. They have severe metabolic acidosis and hypotension. So it is easily available on the dark web. So this is something I wanted audience. And we did a plasma exchange, and this is how the plasma exchange. So plasma exchange has a role in this particular compound. So methhemoglobin normally should be less than 1 to 2%. And for her, as you see, it was 64%, methemoglobin 65.5%. She belongs to this. More than 70% is lethal. And the treatment is methylene blue. So it is 1 milligram per kg for 5 minutes, which is easily available in India. So we use methylene blue for her as an infusion, along with vitamin C and plasma exchange. So please be wary of these newer modalities that are available to treat these patients. And we offered her hyperbaric oxygen. We put her in a hyperbaric chamber for 2 atmospheric absolute for 90 minutes. And methemoglobinemia, after all this, plasma exchange, methylene blue and hyperbaric, it came down to 0.6% and she went home. So these are some of the newer poisons that are available. Just last couple of slides. Lipid emulsion therapy. I spoke about fat therapy in calcium channel blockers. So it has a unique role. This is a newer evolution. These are available in India. So usage is with it is effective against all calcium channel or beta blocker overdose because they push this compound into the lipid core and they have effectiveness in improving the myocardial contractility by preventing the conversion of free fatty acids to carbohydrate and myocardial contractility. The dosage is usually 1.5 ml per kg we give and as an infusion at 0.25 to 0.5 ml per kg, and you have to monitor triglycerides level, and efficacy has been shown in calcium channel blocker. So the future of toxicology, what we need to be aware is whether we have predictive models with the type of toxicity that patient we may be seeing in trying to ascertain their trajectory, and nanotechnology for better sort of a specific therapies, and precision medicine in trying, like how we did in sodium nitrite, and using telemedicine to guide other sort of a patient, other sort of healthcare communities dealing with toxicology. And we need to maintain registry. As a large registry, databases will help us in managing toxicologies better, and enhanced extracorporeal devices. We have extracorporeal devices, so better engineered extracorporeal devices and accelerated antidote development. So these are some of the future trends that we can put our mind on to see whether we can save more lives in this sort of a space. So request you all to submit your valuable work to our Journal of Acute Care. So all these lectures are there on my website. You can visit my website and rehear to these lectures. Thank you. Thank you one and all.
Thank you for nice presentation. Any question?
I would just like to add two things. Recently, I had a patient. Basically, he was just spraying the paraquat in the field, and wind was blowing the wrong way, and he inhaled, and it was enough to kill him. He did not know, but all the features were there. Finally, we got them to get the box. They were saying Safachat. Actually, it was Safaya, the brand names. Second thing is toxicodrome. I would like to add, something. Sometimes two different drugs, including antifungal antibiotics, individually they may not be depressing the CNS, but give the combination it is. I like to tell my experience with isavuconazole. Individually, never an issue. Meropenem, never an issue. But every time I use it with either a ceftazidime or cefepime, invariably by second dose, CNS gets depressed. Sometimes patient lands on the ventilation. Initially, it's not mentioned anywhere, like in the literature, they have interaction like this. It took me some time to realize this is what was happening. Around 10 cases, then I realized, okay, this combination is always giving a problem. First experience, like patient suddenly became like psychotic behavior, and few hours later resolved. The next days when I gave same thing happened, then I realized, okay, it is coinciding with every time I'm giving ceftazidime dose.
Yeah.
So
I think that's a valid comment, but if you look into the literature of the movement disorders I mentioned, akathisia, they say literally any drug that we use in ICU has a role in causing involuntary movements. And delirium also. We underestimate our delirium because we believe there are a lot of different variables which cause delirium, but there are a lot of drugs that we use also have a bearing on delirium component. and ECG manifestations. We see in ICU very often patient going into tachyarrhythmias or bradyarrhythmias. So we need to relook into the drugs that we may be using, because many of them may be vulnerable to developing arrhythmias. Very often we see patients developing long QT. Seldom we monitor the trends in the QT interval, and this may be getting prolonged, and that may be leading to the sudden cardiac arrest following arrhythmias. So these are certain subtle things that we need to pay attention to, at least the QRS and QT intervals, and look at R wave in AVR, because AVR, R wave starts appearing or in V1. So it is an indication that there is a drug that is causing the effect. So there is a separate video of mine on ECGs in toxidromes. So please watch it. It's very interesting and fascinating how most of the drugs we tend to use have some bearing on ECGs.
Thank you, sir.
Thank you, sir, for the insightful lecture.
Thank you. Thank you.
Thank you.
Hello.
Yeah.
Thank you, sir. I request our chairperson, please felicitate.
I think
Quirino
had something to say.
Thank you for your very nice presentation. I totally agree. I would like just underline that we have this problem with Paraca for Chinese country, because as you know, in Europe and many other countries, is not allowed to sell this kind of herbicide because it's too dangerous. I remember, and you bring me when I was young, because I don't see any more death with this intoxication just in the beginning of my career. So thank you for this.
I think that's a very valid point Dr. Quirino has made. In India, we don't have regulatory control over such drugs, which he's mentioning, that he saw them in childhood and right now they're not available. Many of the chemicals that we use in our agricultural industry are banned in Europe, because I do my farming, because I am fascinated with my farming I do. Most of the chemicals that we use in our farming are banned in Europe, which we use in India. So this is a big area. I think as a doctor community, we should put our mind into it and try to get the governance to stop using certain banned chemicals. I think, and paraquat is one of them.
Thank you, sir. I request our chairperson, please felicitate our speaker with a big round of applause. And I request our chairperson, please collect their mementos from the memento podium. Now we move to the next session. I invite to chair the session Dr. John Massey, Dr. Suresh Chandravanshi, Dr. Ramesh Sahu, Dr. K.R. Sinha, and Dr. R.S. Chabra, sir. Please join the dais to chair the session.
The next session.
Dr. K.R. Chabra, sir, Dr. Ramesh Sahu, sir, Dr. K.R. Sinha ji, please join the dais to chair the session. Over to chairperson.
The next session on hyperglycemic syndromes in ICU shall be delivered by Dr. Narendra Rungta, sir. He is founder and chairman at Critical Care Foundation with more than 25 years of experience and has served as CCM at various capacities. Sir was also past president of Indian Society of Critical Care Medicine.
This is in pointer. Okay, thank you. Good afternoon, friends. Thank you, Vishal, for making me part of this conference. Ironically, I am standing between you and lunch. I am talking on diabetes and inducing starvation for all of you. So, DKA and HHS, hyperglycemic syndromes, which you see, and there is a sharp significant difference between both of them, but we see DKA a little bit more commoner than HHS. Case number 1, DKA, 21-year-old female, known case of diabetes 1, presenting in ER with vomiting, loose motions, incoherence, anuria or oliguria, heavy breathing, looks very sick for last 2 hours. tachycardia, tachypnea, looks acidotic, hypotensive, SpO2 is fine on room air, but she is quite dehydrated. Blood sugar is 380. ABG is acidotic. There is high anion gap. Lactates are high. Sodium is okay. Potassium is 5.8 on the higher side. Magnesium is okay. X-ray chest shows the right side consolidation. And when we do point of care ultrasound, ejection fraction is okay, fine. 42%. IVC is highly collapsible. This is typical DKA that we see in our practice. Now, how will HHS present in contrast to DKA? A 42-year-old male, known case of diabetes 2, presents in ER at 4 a.m. with seizures 1 hour, unconsciousness 3 hours. He was getting treatment for UTI and fever for last 1 week. Has tachycardia, hypotension, respiration, SpO2, looks fine. But what is more remarkable is neurological manifestations. We have seen seizures, he is unconscious, deeply comatose, has GTCS. GCS is between 9 and 10. pH is fine, bicarbonates are okay, there is no acidosis, lactates are okay. Sodium, potassium is on the lower side. Ketones in urine are not detected, which were quite obvious in DKA. IVC again here is collapsible. So these are two spectrums of hyperglycemic syndromes that we observe in practice. I am talking mostly clinical. So what is hyperglycemic syndrome? This is state of sustained imbalance between insulin and counter-regulatory hormones, of which glucagon is the most important one. And as the stress will progress, other counter-regulatory hormones like cortisol, catecholamines, growth hormone, they will also come into play. And this type of, DKA is likely to be more common in diabetes 1, whereas HHS will be more common in diabetes 2. Shock anion gap acidosis are most remarkable in diabetes 1, where we see DKA, whereas neurological manifestations dominate. Why and what happens pathophysiologically, I'll try to discuss. So this is, the classical difference between DKA and HSS. DKA can be mild, moderate, severe. And what will define what is mild decay, what is moderate decay and severe decay is it's a very gray area. And largely, pH may not be the hallmark of severity of DKA, but it's the hypotension, obturatension in DKA when it is severe, patient is deeply comatose, probably these patients are more sick. As we go on, we will try to discuss. And normally what happens? What is the normal metabolism in a non-diabetic patient? When glucose enters the pancreatic cells, there is production of adequate insulin. And when adequate insulin is produced, it leads to decreased hepatic glucose production and increased glucose uptake by muscles and adipose tissues. Therefore, glucose is maintained in controlled high euglycemic situations. When and there is simultaneous inhibition of glucagon production from alpha cells of pancreas. Decline in hepatic glucose production also takes place because of inhibition of glucose production. Now look at this diagram. Normally this is, the above diagram, above part of the diagram is in normal individuals. When there is insulin, glucagon is controlled production. When insulin decreases, there is increased glucagon production. That is what happening in cases of hyperglycemic syndromes because of absolute or relative deficiency of insulin. So when there is acute stress, when there is infection, or these patients are subjected to stress and they have pre-existing situation of absolute or relative deficiency of uh, insulin, it results, which may result from precipitating events or their progressive metabolic derangements that these patients undergo during the process of development of infection or other stress situation. This stress response results in increased production of glucagon and other catecholamines and other mediating hormones. Simultaneously, there is increased release of other elements also, which may be cytokines, TN alpha, and lot of interleukins, which are of more of academic interest or we do not know about their clinical importance as of now. Now, why every patient does not develop HHS, or why few patients only develop HHS, and why most of the patients would develop DKA in diabetes type 1? That they have enough insulin to prevent significant ketone production, but not enough to control hyperglycemia. So those patients who develop HHS, they are patients of diabetes type 2. So they have relative deficiency of insulin. Once they have relative deficiency of insulin, they have control over, ketone production, which occurs with severe deficiency of insulin, but with relative deficiency of insulin, they can prevent or control ketone production. Hyperosmolarity in HHS also seems to be playing a role in preventing ketosis. If there is high osmolarity, which happens in HHS, that also probably seems to be having a bearing on development of ketosis. Decay is more common, as I said earlier, in type 1. Now, why does incoherence or mental depression occurs in DKA or HHS? Mental obtuse tension may occur in patients with DKA also because of hypoperfusion, cell dehydration, intracellular hypernatremia, severe acidosis, or other factors. Deep coma in DKA points with patients with plasma osmolarity of more than 320. We should always look for other causes of severe coma, because severe coma is an unlikely complication or representation in DKA. It is very common and it is the primary presentation in HHS. Coma in HSS occurs because of increased plasma osmolarity, which I'll try to explain in subsequent slide. HHS patients may have focal neurological signs like hemiparesis, hemianopsia, and seizures. Now, plasma osmolarity, you all know in routine we calculate by sodium into 2. That's the standard formulation we follow. However, glucose also forms a part of this calculation. Normally, glucose is not significant because the ultimate calculated value of glucose contributing to osmolarity is very small. It comes to about 8, 9, less than 10. However, if there is hyperglycemia, glucose level more than 300 or say in HHS around 1000, then this value become very significant and will lead to significant addition to hyperosmolarity or osmolarity of plasma. Therefore, in such situation, this becomes the single most important factor in HHS, and blood sugar are usually more than 800. Osmolarity, therefore, may be more than 350, which is usual. And if osmolarity is more than 320 in patients with DKA, then we should look for other factors in these patients. Now, this is the normal patients. These, what you see in the center are the brain cells. And now they are, well circumscribed, healthy looking cells. This is what happens normally. However, when you have decreased osmolarity, now there is a situation of decreased osmolarity. What is decreased osmolarity? the circulating plasma is diluted. Therefore, water will flow from extracellular fluid to the intracellular space, and as a result, the cells will swell and will burst out at this stage. This will lead to apoptosis. Now, let us say there is a situation where there is increased glucose and contributing very significantly to osmolarity. Now, in this situation, the extracellular fluid becomes quite viscous. Osmolarity is very high. Then water will flow out of these brain cells into the extracellular. As a result, cells will shrink and again decay. This is the one of the commonest mechanism by which these patients suffer from deep coma or seizures or many other neurological complications in cases of HHS. So now we will come to acidosis in DKA, which has several sources which can induce acidosis. Shock-induced renal hypoperfusion leads to reduced bicarbonate production. That we all know, if there is a reduced renal perfusion, this will lead to compromise in bicarbonate production. Now, the second process is development of ketonemia, which leads to neutralization of already reduced compromised bicarbonates, which further compromises bicarbonate levels and produces acidosis. Third, and probably for a transient time till we correct that, lactic acid production, which further neutralizes bicarbonates and is also responsible for creating high anion gap acidosis, which is of great diagnostic value in cases of DKA. Now, DKA and ketoacidosis, why this develops and it does not develop in HHS? Because there is severe deficiency of or absolute deficiency of insulin, and this leads to lipolysis. The fats are broken into and it's metabolites, and there is an increased level of free fatty acids which are ultimately metabolized into ketones. Ketones are three. Number one, they are first to be produced with acetoacetic acid, and then it is later dehydrogenated into beta hydroxybutyric acid, and ultimately it is converted into acetone, which appears in urine. Now, out of these three, acetone is the true ketone, but it is non-acidic. However, and acetoacetic acid is the most important of all these three. Urine ketones test positive for only acetone and not for acetoacid or beta hydroxybutyric acid. So, now what produces lactic acidosis in DKA? Now you see, this is the cell and this is the mitochondria. When there is very high plasma glucose, the mitochondria of each cell is unable to metabolize all the glucose. Therefore, this glucose is thrown into alternative cycle, and in presence of dehydrogenate, it is converted into alternative cycle and lactate. Therefore, you will see when you control hyperglycemia with only fluid, lactic acidosis is very, very fast to respond. And these patients become, they show a massive, significant improvement in pH very, very fast. Now, there is a condition called normoglycemic DKA. Normoglycemic DKA, in which serum glucose is normal or near normal, has been described particularly in patients who have poor oral intake and been taking treatment with insulin just prior to arrival in the emergency department. This may also happen in pregnancy and in patients who are consuming sodium glucose co-transporter or SGLT2 inhibitors. This is quite corroborated and proven. Therefore, even if blood sugar is normal and patient shows DKA, you don't be surprised. and treat them patients like those you treat for DKA. Now, I'll come to management of DKA and HSS. So the various headings: fluid resuscitation number 1, management of electrolyte imbalance number 2, correction of acidosis number 3, insulin therapy comes at number 4. This is one of the most important thing I wish to emphasize for all of you. We should not rush to give insulin to these patients at arrival. Otherwise, we may invite catastrophe or disaster because of various things I will talk to you in coming slides. There are specific interventions which are related to HHS. There is importance of ketone monitoring. There will be specific pediatric consideration because diabetes type 1 may present an usual first presentation, diagnostic presentation of DKA in children is infections, and they present for the first time with DKA. Switching to long-acting insulin after the patient has been recovering and putting them on oral diet, and some precautions that we take during management and monitoring. Now, fluid resuscitation is the most important intervention in DKA. Whether it is a patient of DKA or HHS, both types are severely dehydrated, and this severe dehydration leads to increase in osmolarity and in a shock state. So fluid stress, the targets are MAP, mean arterial blood pressure more than 65, achieving a urine output of 2 ml per kg per hour, fluid type normal saline, fluid quantity 30 ml per kg first 2 hours. Subsequently, we may switch on to 10 ml per kg per hour. Now, these patients, because of peculiar pathophysiological situations in which they are caught in because of insulin deficiency and other metabolic derangements, there is a possibility that these patients will go into abdominal distension and abdominal compartmental syndrome because of high fluid therapy. Therefore, it may be wise after initial resuscitation to switch over to N/2 saline. And as soon as blood sugar touches 250, we should switch over to a solution, normal saline or N/2 saline containing 5% glucose to prevent occurrence of hypoglycemia, which is not uncommon in these patients while we introduce insulin for all of them. Correction of shock and acidosis are achieved fast in DKA with fluid therapy. Lactic acidosis also resolves very fast. This is not a sign of poor prognosis in DKA, as we assume lactic acidosis is a very serious problem in most of the patients, whether it's a case of poisoning or a sepsis or other causes which leads to lactic acidosis. This is one condition where lactic acidosis is severe, anion gap is very common, yet lactic acidosis is not of any prognostic value because this is a coincidental event that happens because of metabolic problem. Osmolarity correction is challenging and tricky in HHS. Treatment of the precipitating cause should also be initiated early. Otherwise, we will land into problem. Now, management of electrolyte disturbances in DKA. Potassium loss is a major problem. I showed you in the first slide that potassium of that patient was 5.5. That is higher than normal. Yet, in such patients, you may have a situation where potassium deficiency may have as much of as high as 99%. That means patient is left with less than 1% potassium of total potassium that the patient was having before development of this particular problem. Why? Loss of potassium, preceding polyuria, vomiting, reduced intake, proceeding the patient had been taking insulin therapy before coming or getting this disease, use of bicarbonates to correct acidosis, which we very commonly do in practice. Therefore, potassium supplementation should be started as soon as patients start passing urine. We should not wait for insulin therapy before correction, before we start insulin therapy, we should initiate potassium. A low pH with potassium of more than 5.5, less than 0.5 is direct indication of starting potassium therapy in all these patients. Potassium supplement may be needed for more than 2 weeks and replenish the previously, the severe deficiency that these patients usually have. Now, there is severe magnesium deficiency also in these patients because potassium and magnesium move together. Some patients may land with GBS type picture, and many a times we have heard that these patients had been subjected to immunoglobulin therapy because their diagnosis was made as GBS because of particular type of quadriplegia that they exhibited. Magnesium supplementation is needed for several days until a level of 4 milligram is reached. I must tell you here, we can continue and introduce potassium and magnesium therapy only on two conditions. Patient must be passing urine and must be ventilating. Otherwise, both of these elements may produce problems. So, 100 to 120 milliequivalent of potassium should be given per day. Long-term potassium introduction administration should be planned. IV replacement is needed. It will not work if we want to do it orally. Target potassium is more than 4. Magnesium replacement is done with 50% as we do, and it has to be done for several days because each time we give magnesium, lot of it will be lost with urine. Now, phosphate is another electrolyte which we do not attach importance to. This is also estimated that in all DKA patients run into shortage. Therefore, and these patients, because of standalone phosphate deficiency, may become muscularly weak and may show paralytic situations like those in GBS, in addition to potassium and magnesium deficiency. Therefore, phosphate administration and supplementation is also of great importance in DKA patient. Now, sodium is measured in low in DKA. This is, pseudo hyponatremia because measured sodium is reduced by 1.6 milliequivalent per 100 milligram rise in blood sugar, and where blood sugar has risen by 700, 800 milligrams, you can assume that sodium estimation has come down by almost 10 to 15 milliequivalent per liter. Therefore, we should interpret the sodium levels in serum with some caution. And normal sodium, therefore, in DKA reflects severe dehydration. Only severe dehydration patient will show normal hyponatremia. Otherwise, these patients also show problems of chloride as we give them normal saline, high quantity of saline containing sodium chloride. These patients ultimately will run into hyperchloremic situation, and despite their urine coming free of ketones, the pH may still show acidosis, and that usually is because of hyperchloremic acidosis. In such situations, we should switch over to N/2 saline. However, hyperchloremic acidosis is not dangerous, and most of these patients are expected to recover spontaneously without any clinical problems. Now, correction of acidosis is not required because with correction of dehydration, with correction of shock, urine output, both bicarbonates will improve, lactic acids will reduce, and within matter of hours, we will find that the pH of the patient has come to near normal or even normal. No patients of pH 7 or more should get sodium bicarbonate solution, which is disastrous because sodium bicarbonate will directly bring down the levels of circulating potassium. Already the body is deficient of potassium, and it works over time to maintain circulating potassium levels. Therefore, potassium levels appear normal looking in plasma. If you give sodium bicarbonate to these patients to correct acidosis, therefore potassium will be pushed into cells or muscles and the patient will run into severe potassium deficiency and may lead to cardiac problems, including cardiac arrest. Insulin therapy should be started only after fluid resuscitation and potassium stabilization. And there should be no hurry, heavens are not going to fall. If you delay, if the patient remains little hyperglycemic even after 4 hours, 6 hours. Therefore, insulin administration should be done only patient has been powering urine and there is correction of some acidosis and there is usual loading dose and then the maintenance dose. How to monitor insulin therapy? Our target should be to reduce blood sugar by 50 milligram percent per hour. We should not augment the reduction in blood glucose level for the reasons that we have already demonstrated to you about the cell dehydration of the brain. A specific intervention in HHS, correction of osmolarity is the principal objective. Normal saline again is the fluid of choice. At least 25% or more correction of osmolarity will be achieved only by fluid resuscitation. Then insulin is introduced to correct glucose slowly, seldom faster than 50 milligram per hour to prevent central myelinosis. And this is how central myelinosis will appear on a MR scan. So the chances of these patients going into central pontine myelinosis by overzealous, because of overzealous correction of hyperglycemia, because we are scared of very high glucose level in decay. So ketone monitoring, ketones are only of academic interest. Once ketones are cleared from urine, we don't need to monitor ketones anymore. They do not have any significant prognostic value as far as monitoring of DKA patients is concerned. Sometimes what you will observe, after initial clearance of urine from acetone, you on day 2, day 3, after first clearance, you will find that acetones reappear in urine. That doesn't mean that the patient is getting acidotic again or complicated again. This is because of residual acetoacetic acid and hydroxybutyric acid getting converted into acetone and now being passed into urine. So we can ignore these and we do not need to augment insulin doses to correct that. Some special mention in children. There is, instead of regular insulin, Linspro or aspartate insulins are recommended because they act very, very fast and they do not form hexamers as other insulins do. Dietary management of these children is also little more challenging. And children, because of their low thresholds, osmolarity issues are also greater challenges. Therefore, we should be very careful about correcting their osmolarity and hyperglycemia. We should be little more patient and little slow in these patients. As soon as the patient recovers, we should put them on long-acting insulin. Oral diet should be introduced and vigorous monitoring may be given up at this stage. Some important points: hypoglycemia must be prevented at all times. Correction always of any of the parameters should be slow. We should be patient in management of these DKA patients or HHS patients. Potassium correction should start very early and takes a long time to correct. Magnesium and phosphate supplementation is also needed, and that also parallelly as we do potassium correction. Potassium up to 5.5 is not a contraindication to early potassium therapy. Thank you very much, ladies and gentlemen, for your patient listening.
Thank you, sir.
Yeah, nice presentation, sir. And it was the latest update. I have one question. There are some patients with diabetic retinopathy, and that is related to the brain, lentiform nucleus, in which the caudate nucleus and the globus pallidus are involved. So there are many patients in casualty who come with hyperglycemia. How to select from among those patients, how you will select for MRI? These can be diagnosed only in MRI. So what are the criteria to select for MRI from these patients?
That's a great question, though, but I would leave those cases for my neurological colleague to decide.
Anybody can answer.
Then
Anybody can answer.
I will because that's beyond intensivist area. So selection of such patients, I would leave out to neurologists. Because I do not have personally exposure to such situations during last 35 years that I have seen about, or most of the time, if there were any such cases, I must have missed.
Yeah, when this portion of the brain is involved, there must be some clinical signs and symptoms. So by those signs and symptoms, we can select the patient.
I'm not aware, so I'm honestly conceding that I must have missed, or I do not know about such situations. I have not come about description of such patients in literature.
And in cases of hypoglycemia also, there are brain changes. So what brain changes are there? So that from there also we can select the patient for MRI.
Yes, hypoglycemia, I have always felt that hypoglycemia is more important than hyperglycemia. We can live with hyperglycemia for months. We cannot live with hypoglycemia for more than hours. So there are pan-neurological changes because of hypoglycemia. No single part of brain is spared because of hypoglycemia. And some of the changes which are left in brain even after correction of hypoglycemia, they are of permanent nature. These patients may become, they may lose their IQs, they may lose their memories, they may become epileptics, or some of them have shown serious changes in the hypothalamus and pituitary also. Particularly if this has been a pediatric patient, we have seen a severe growth retardation in these patients. So hypoglycemia is a very dangerous complication and must be prevented. And there is no part of the brain, no cell of the brain which can be singled out that which can be spared if the patient becomes hypoglycemic or if there is a sustained. So never ever allow. I'm okay with 250 milligram blood sugar, but I'm highly suspicious with blood sugar less than 100 milligram. To me, euglycemia in ICU is between 150 to 180.
Thank you. Thank you, sir. Any questions from the floor?
Hello.
From the audience?
Hello, sir. Very comprehensive coverage of the topic. Thank you. I have one thought that you have mentioned that hyperchloremic acidosis normally resolves on its own. Hyperchloremic acidosis normally resolves with fluid and all. But still we are feared to start NS as an initial fluid. We sometimes give balanced salt solution for initial fluid resuscitation.
You see, there is a lot of talk about balanced fluids.
Yes, sir.
I am not a great fan of balanced fluids.
Okay.
I have never used balanced fluids for a long time.
Okay.
I have never observed, this is a controversy and we can argue these for a long time.
Okay.
So we don't need anything. If we are patient enough, if we are able to point out that this acidosis is because of hyperchloremia, even if we don't do anything, all these patients are going to recover. Only thing is, simultaneously, during resuscitation of DKA patients, there is small but definite risk of abdominal compartmental syndrome. That must be avoided. And that runs parallel with hyperchloremia.
And also for insulin, you have mentioned first bolus and then maintenance infusion. But sometimes we directly start infusion without giving bolus. So it is mandatory to give bolus and then start.
No. Again, I am very relaxed about insulin therapy.
Okay.
You have not blundered if you have not given bolus.
Okay, sir. Okay.
So that's okay.
Thank you, sir.
A great talk, sir. I'll just clarify his point regarding this acidosis. I am a nephrologist. So all these organic acids, including all these decay acids which sir mentioned, they're all converted in the liver to bicarbonate once you treat them with fluids and insulin. That is the reason why they don't need any bicarb correction and acidosis automatically recovers. In fact, it is dangerous if you give them bicarb. That's the answer to your question. Thank you.
Thank you, sir.
Thank you.
I request our chairperson, please felicitate our speaker with a memento. And I request our chairperson, please collect their mementos from the memento podium. We will continue our next topic without any lunch break. I request all the delegates, please come into the hall for interesting sessions on acute liver failure, which will be delivered by Dr. Akash Shukla, sir. To chair the session,
to chair this session, I would like to invite Dr. Sandeep Pandey, sir, Head of the Department Gastroenterology, Ramkrishna Care, Dr. Manoj Lahoti, Suyash Hospital, Raipur, Dr. Devender Singh from Apollo Hospital, Bilaspur, Dr. Manish Lunia, Senior Consultant Gastroenterologist from Raipur, and Dr. Vaishali Dubey, Senior Consultant Gastroenterologist, Vidya Hospital, Raipur.
Dr. Lalit, may I ask some of you to go outside and announce that the sessions are on,
Yeah.
so that more and more people should be in the hall.
Sure. I think by the time you introduce the topic and the speakers, I will do this.
Good afternoon, everyone. It's my privilege to introduce today's next speaker, Dr. Akash Shukla. Dr. Akash Shukla truly needs no introduction to this August gathering. Dr. Akash Shukla is presently head of the Department of Gastroenterology, KEM Hospital, and he is Director, Hepatology Division, HN Reliance Foundation Hospital, Mumbai. He has several remarkable contributions in the field of hepatology, especially acute and chronic liver failure, alcohol use disorder, non-alcoholic fatty liver disease, Budd-Chiari syndrome. And he is one of the most respected hepatologists in India and abroad. Let us listen to the very common clinical topic which we encounter daily, that is acute liver failure. Let's listen to Dr. Akash Shukla's perspective on this complex subject.
Good afternoon, everybody, and thank you for those kind words of introduction, and thank you, the organizing committee, for having me here. It's always a pleasure to be here amongst my roots. Let's start with the case. This is a 24-year-old lady who is otherwise healthy. She gets some prodromal features, low-grade fever, and then jaundice for 5 days and encephalopathy for 2 days. She is admitted elsewhere for these symptoms. There is no past history of liver disease. And then she develops altered sensorium, and for that she is referred. So when she is seen in the ER, she is hemodynamically, BP is 126/50, pulse rate is 118. There are bilateral basal course crepitations. She is drowsy, reacting to painful stimuli, not following commands. Pupils are equal. Cardiovascular system is fine. Fever is there, 101.5, and per abdomen is soft. When we investigate this patient, ABG shows normal PO2 and CO2, but bicarbonates are 5, lactates are 8, and the chest X-ray shows a right lower lobe collapse. The first hour of the ER, what we need to do is resuscitate this patient. But fluids, we have to be very careful. This patient has already got bilateral course crepitations. We have to decide what are the investigations we are going to send. Then we come to the choice in a patient who is altered, whether we need to restrain this patient, sedate, or intubate. In a patient who has got grade 3 and above, the best thing to do is sedate and intubate. So restraining increases intracranial hypertension, and therefore it is best avoided in patients with acute liver failure. Then we have to decide the imaging in this patient. So here, whether you do a brain imaging, abdominal imaging, or chest imaging, most of us would do pan imaging, but I think what is required really in this patient is a chest imaging and not brain or abdomen. We know what the brain is imaging will not be sensitive enough to pick up any raised ICP. It's a very short history, and abdominal imaging is not going to show much other than a shrunken liver in very advanced cases. But you can do ultrasound of the abdomen, but what is key here is to see if there's any chest infection. But what you require in the first hour is anti-brain edema measures. These are the investigations. Platelets are 80,000, WBC count is fine, creatinine is 2, amylase lipase are normal, bilirubin is 10, transaminases are more than 1,000, albumin is 2.3, and ammonia is 320. So on the first day after the initial stabilization, the EBG shows lactates to be down to 4 from 8. Ammonia levels after adequate hydration have come down to 200. We do a transcranial Doppler and optic nerve sheath diameter, which are both normal. Urine output is 0.5 to 1 ml. So the key question here was whether we should start this patient on CRRT, because there are features of raised intracranial pressure and ammonia levels which are still more than 150. So this patient was at this stage sedated, ventilated, and initiated on CRRT, and then required a low dose of NORAD. Ammonia was monitored and kept between 85 to 100. The usual target on CRRT is to keep the ammonia levels below 120. The lactates we would want below 5, so they were targeted to be between 2 to 4. And the patient was covered with antibiotics, meropenem, teicoplanin, and micafungin because of the chest consolidation. Otherwise, usually a BL-BLI combination is sufficient. Patient was given NAC infusion and 3% saline to keep the sodium between 140 to 145. The core temperature was maintained between 35 to 36. CO2 was maintained in the normal range, and patient was started on low-dose trickle feeds. Patient was monitored closely, especially the ammonia levels and sugar levels, and daily transcranial Doppler and ONSD. The etiology-specific workup was sent, which showed everything negative except for IgM anticore antibody. Because the onset was with fever, therefore, we had sent the entire fever panel as well in these patients. Day 5, the INR starts downtrending. The INR is now 2.4. No products were transfused. The CRRT dose was reduced, and the sedation was continued. Day 6, day 7, when the sensorium improved, the CRRT was discontinued, the urine output was adequate, the ammonia remained less than 100 after stopping CRRT. So for us, the rule of thumb is if the arterial ammonia is below 150 on 2 occasions, on stopping CRRT, we can discontinue the CRRT completely. And then the patient was weaned off the ventilator. So this was a patient who was a hyperacute liver failure. IgM HEV was positive, so Hep E related. Jaundice to NCAF was 4 days. Peak INR was 3.4. She had mild cerebral edema, and she had a AKI grade 2. So which brings us to a high chance of spontaneous recovery. So let's see, what do we do when you actually face a patient with acute liver failure? The first and the foremost is airway, and this cannot be emphasized more and more. Most patients of ALF who die, they die because of pneumonia, because of aspiration. The moment their chest is infected, they will develop brain edema and coning, and that is what kills them. Whether it happens on the same day or subsequently is a different matter. So the most important thing is protection of the airway. The moment the patient is not able to control the secretions in the throat, this patient should be intubated. Whether it is grade 2 encephalopathy, and definitely in grade 3 and 4 encephalopathy. Circulation is the next important thing. The moment you put these patients on ventilator, remember their blood pressures will drop. They will have SIRS, and it is very difficult to differentiate between SIRS and sepsis. And therefore, you would require continuous monitoring either invasively using PICO or similar catheters, or you can do IVC monitoring or 2D echo-guided monitoring, whatever is the local expertise which is available. You don't want to over-infuse them because that will increase the ICP. You don't want to dehydrate them because that will push the lactates up. So you have to keep them absolutely euvolumic in a very tightly regulated manner, and that is the best way to save these patients. Be very liberal with sedation, but the sedatives which should be used should be propofol as the preferred choice and fentanyl if the second one is required. Do not use benzodiazepines because in a patient with liver failure, if you use benzodiazepines, they can circulate for weeks together. So even if you have given for 24 hours or 48 hours, even a short-acting benzodiazepine can circulate for a very long time. So even when you stop the sedation, the patient will not wake up for many days, and that will increase the risk of infection. And then you have to monitor these patients with transcranial Doppler, which is the ideal one, or lesser compromise is optic nerve sheath diameter, and where facilities available, reverse jugular oxygen pressure should be used. Pupils is a very terminal thing, so do not rely on the pupillary signs. If the pupils have dilated, that means you have already missed the boat. We maintain these patients at normal temperature, do not cause hypothermia. So the concept has changed. Hypothermia is no longer considered a good choice. It actually increases the risk of bleeding, and therefore it is best avoided. Monitor electrolytes and correct them. Do not overinfuse and initiate CRRT early. What are the indications of CRRT in an ALF? If you have two readings above 150 of ammonia or a single reading of above 200, despite adequate hydration, then these are the indications to start CRRT. Now, CRRT, again, is a very umbrella term. You have to understand the nuances of CRRT to do it effectively. You have to decide how much is the effluent rate. You have to decide how much is the ultrafiltrate that you're going to extract. And that is decided by the hemodynamics, the clinical condition, the acid-base balance, the ammonia levels, the lactate levels, what is the status of the microcirculation. And based upon that, and that is why you cannot leave it to your nephrologist. The CRRT decision has to be taken by the liver unit. What is the dose, how you're going to use, what is going to be your exchange fluid, what is the rate of the exchange fluid that you're going to give. This cannot be decided by the nephrologist because they won't have the understanding of the metabolism in this patient of liver failure. It has to be decided by the liver unit. Nutrition, there is no harm in keeping the patient nil by mouth for a few days, but if they are able to tolerate, then you would want to give them a normal protein and normal calorie diet. Do not give prophylactic FFPs or platelets. The bleeding risk is low despite high INR, but if the patient has sepsis or the patient has developed severe renal injury, then these patients would require correction of the coagulopathy, especially for the procedures. We must start these patients on broad-spectrum antibiotics, and if the ICU stays more than 7 days, then typically you would add empirical antifungals as well. Can we do anything specific for these patients? Can we give N-acetylcysteine? The answer is yes. N-acetylcysteine is a good drug which is now used and recommended for all acute liver failures. But if a patient is septic, please avoid giving N-acetylcysteine. This patient where we gave N-acetylcysteine was actually a mistake. That data was not available that time when we managed this patient. But today, if I have a patient who has got an infection, I would not use N-acetylcysteine because it suppresses the neutrophil burst and therefore it actually causes more bacterial infections. Steroids should be given for patients who have got autoimmune hepatitis. So if the patient has grade 3 or grade 4 encephalopathy, then steroids should not be given to these patients. These patients should be sent straight away for liver transplant. So acute liver failure because of autoimmune hepatitis with grade 3 or above encephalopathy is not a candidate for steroids. If you give steroids to this patient, you will be able to salvage 10% of the patients, but you will kill the other 90% because of infections, and they will not reach the transplant table. CRRT today has become the mainstay of therapy, and it should be started early, especially if there is a suspicion of raised intracranial pressure or ammonia, as we discussed. What about PLEX? And I'll be discussing this in a bit of detail in my subsequent slides. But one place where PLEX is to be used aggressively and early is in patients with retinol poisoning. So yellow phosphorus poisoning, it should be initiated early and to be done aggressively, and that has been now demonstrated to improve survival rates. So if you look at N-acetylcysteine, the dose that has to be given is 150 mg per kg over 1 hour, followed by 50 mg per kg over 4 hours, and 100 mg per kg over 16 hours, and then 100 mg per kg for the next 5 days, not 7 days. But the easier regimen to remember is 150 mg per kg per 24 hours for the first 5 days. And if you see the meta-analysis, it shows that it is associated with improved survival, but not in those patients who have an infection. There it is associated with worse outcomes. This is the only study which has shown that CRRT is associated with improved survival and reduces the ammonia levels. And subsequently, we have one study from ILBS now, which has recently published, which has shown the benefit. What kills the patient is cerebral edema, and which is most commonly precipitated by infection. So what we do for these patients is hypertonic saline to keep the sodium between 140 to 145. Previously, we used to recommend 145 to 155. But recent studies have shown that if you keep between 145 to 155, you get cerebral microhemorrhages. And even if the patient recovers, they have long-term neurological deficit. Therefore, you avoid hypernatremia. Hemodiafiltration, as we discussed, keep them at normal temperature and avoid hypocapnia. Hypocapnia, again, which was previously considered as a standard of care, is now best avoided for the same reasons, because it is associated with cerebral microhemorrhages. Coming to PLEX, because this is a very important topic. There are 3 studies which have shown that plasma exchange is actually useful. The first was a prospective study, randomized controlled trial, European, which showed survival benefit. Then the second one was a full volume PLEX retrospective study from Stahl. And the third is half volume PLEX prospective case series from CMC Vellore. And when you look at the prescription, typically the Western prescription is a high volume, 8 to 10 liters of plasma exchange, expected to remove 90% of the PAMPs and the DAMPs. While if you do look at the Indian and the Stahl's data, normal volume 1 to 1.5 times, and low volume is half the plasma volume, which is around 2 liters. So no head-to-head comparison between each of these, but one thing is for sure, your replacement fluid cannot be anything other than fresh frozen plasma. It cannot be albumin, it cannot be anything else. So please do not compromise on this. The moment you use albumin as a replacement fluid, even if partial replacement with albumin, you will develop severe coagulopathy and your patients will bleed to death. So do not experiment with this. Now, the question between centrifugal and membrane-based is again very difficult. Centrifugal is one which we prefer when the patient actually has hemodynamic instability, while membrane-based is in patients who are hemodynamically stable. But today, actually, my usage of plasma exchange for acute liver failure is less than 10%. It is a very rare patient where I find that the interleukin levels are extraordinarily high, more than 10 times upper limit of normal, and the patient doesn't have infection. Those are probably the only candidates for plasma exchange today in my practice, and that too, if these levels remain high despite initiation of CRRT. So plasma exchange should not be offered as a first-line therapy for acute liver failure. And why do I say so? It is based on this real-life study, which is a multi-center UK-based study for 7 centers across 8 years, where they demonstrated that there is no benefit of plasma exchange in overall survival in patients with acute liver failure. So the previous multi-center trial had shown benefit, but in real life, there was no benefit which was found because of plasma exchange. So reserved for very rare patients, because remember, plasma exchange can cause TRALI, it causes lung issues, and makes many of the patients non-transplantable. The second problem is you can get severe hemodynamic instability during plasma exchange in these patients who are on CRRT. And the third problem is risk of infections. You will introduce infections with repeated sessions of plasma exchange. And if your patient has not improved after the first session of plasma exchange, he is not going to improve after the second or the third. So do not keep on trying plasma exchanges. Plasma exchanges, in my experience, has killed more patients in India than survived. Then, of course, we have to decide upon transplantation. Patients who have high lactates are actually the most likely candidates for transplant. Patients who have got persistently high ammonia levels, they are the ideal candidates for transplant. But it's very difficult to predict. The longer the jaundice to encephalopathy period, the more chances are for transplant. So if a jaundice to encephalopathy period is more than 4 weeks, then this patient is not going to survive without transplant. So these patients should be taken up for transplant as soon as possible. There are several criteria which have been tried. One is your classical King's College, which everybody is aware of. Then you have the LFED, which is from the All India Institute. And now you have also got the MELD score, which is important. But what we follow is actually the UK organ distribution super urgent criteria, which characterizes into different parts, which is a modification of the King's College criteria. And based upon this, today we can classify whether a patient is going to require transplant or not accurately in almost 90% of the cases. So why I'm saying so, I'll come to it later. We should also know which patients should not be transplanted. If the patient has already coned, if there is a confirmed invasive fungal infection, if the patient is on more than 2 inotropes, and if the patient doesn't have a good social support, especially suicidal cases where we know that we have not been able to treat the underlying pathology, psychopathology, these patients should not be offered transplantation. What has been our experience of ALF at Sir H.N. Reliance Foundation Hospital? Since February 2022, we have had 45 patients of acute liver failure. Of these, 28 patients were considered for medical management alone. Of these, 100% survived with just medical management. Not one of them were offered transplant at a later date. 17 patients were considered for liver transplant and were listed for liver transplant. Of these, only 3 got the livers. All these 3 survived. While waiting for the transplant, only one of the 17 patients actually died. 2 patients discharged against medical advice because they could not meet the financial constraints. And very interestingly, of those 17 patients whom we thought required liver transplant, 2/3, 11 out of 17, survived without a transplant. And that is why we decided to move out of King's College and LFED criteria to the new UK criteria. Because when we looked at the new UK criteria, our survival rates were comparable to what they were doing in the UK. And this partly came because we have as our mentor, Professor Julia Wenden, who monitors very closely and works very closely with us in managing our critically ill patients. Why we have been able to make this successful? Because we have a separate liver ICU, only for patients with transplant and acute liver failure. Other patients go to other ICU. In our acute liver failure ICU, only liver transplant trained nurses are there. The nursing ratio is 1:1, and if CRRT is started, then you have 2 nurses for 1 patient. And even the residents, the JCs on duty, are the ones who are doing only liver ICU. They don't do general ICU duties. And the hepatology unit, the liver critical care unit, and the surgical team is one combined unit. They are not 3 different entities working separately. So we have combined rounds, combined decisions for every single patient. And that is why we have been able to make such a good impact in our patients. And decision for CRRT and PLEX is taken by the liver unit and not by the nephrologists. Thank you very much, and I'll be happy to take any questions.
Thanks, Akash. Well, the message is crystal clear. lot of things you have actually spoken. We sometimes we are put in dilemma whether to do Plex or CRRT. Well, CRRT has actually changed the game now, and the medical management scene is much better now as compared to previous years. But Plex, I think it was brought in as a desperate measure, to do something for the patient. And is there any particular etiology in whom Plex still works better? Because in our practice, we've seen that Ratol induced associated ALF seem to do a little better than other etiology patients. What's your experience on that?
Absolutely. I completely agree with you. And that's what I mentioned in my talk also, that one place where I would start Plex early is for Retol poisoning, yellow phosphorus poisoning. These are the patients where it has made a huge difference. So if you start it early, at the beginning of the liver failure, don't wait for the full-blown liver failure. But at the beginning of the liver failure, if you start, these patients actually do much better. Many of them will not even develop the full-blown encephalopathy, despite having very high INRs.
Excellent survival statistics for ALF patients. It is very hard to see. Very few institutes are able to make it. So in this case series or a number of the patient you had over the last 2-3 years, so what were the common etiology and which are the patient which could not make?
So as you saw, of the 45 patients, I think we had only one death and 2 patients left against medical advice. So 42 survivors. The most common etiology in the first 2 years was actually hepatitis E, but last 1 year has been hepatitis A. So there has been a definite shift between the etiologies. The second commonest etiology is ATT induced. Now, what has been our experience is patients who develop ALF because of anti-tubercular therapy, they are very less likely to survive spontaneously. So in fact, the 3 patients who were transplanted, all of them were ATT delay. Now, being on ATT is not a problem. One of these patients was actually MDR-TB on MDR-TB therapy. So do not worry if they are MDR-TB. We have done one transplant in the second week of ATT. So there is no need to wait for 4 weeks. There is no need to wait for the TB to respond. You can transplant them even in the first week of anti-tubercular therapy. So we should not be afraid. So I think that is a clear message which we should give. The patient who died, unfortunately, was again drug-induced liver injury. It was because of anti-epileptic drugs, and that patient could not make it because they didn't have a living donor prospect, and the donor was not available on time.
Hi, Akash. Sir. It was a brilliant presentation. Regarding neck, what I have observed, that neck should be given within 48 to 72 hours, especially for paracetamol. For non-paracetamol ALF, which we see in India, we don't see paracetamol-induced ALF. For viral etiology, should we give NAC to these patients? And NAC, I have observed in my hospital that NAC causes anaphylactic reaction. It causes hypotension, it causes multi-organ failure, and it should always be given in ICU setting. And second question is that it's a time-sensitive disease. So should we refer all the patients who have grade 2 encephalopathy and higher to liver dedicated unit where the transplant facility is available?
Fantastic points. I completely agree with you. So the first point, that N-acetylcysteine is a double-edged sword, I completely agree. It can cause anaphylaxis. So it has to be given under very close supervision in the ICU. Do not initiate it in nursing homes. Second point, all patients who have paracetamol definitely need N-acetylcysteine. For the non-paracetamol, in patients with viral hepatitis as well as for drug-induced liver injury, there is a role for N-acetylcysteine, provided, as you very rightly said, it is initiated early. Once the patient has developed advanced liver failure, then giving N-acetylcysteine doesn't help much other than just bringing up the sodium, because it has got a high sodium content. So it just helps bring up the sodium, and that is why it is helpful. But you can give 3% saline and do the same thing. So once patient has already got advanced liver failure, I don't think there's much role of N-acetylcysteine. In fact, you may actually cause harm. And with regards to the second point, all patients should be transferred to dedicated liver units once they have fulfilled the criteria of liver failure, acute liver failure. So if they are in encephalopathy and the INR is more than 1.5, they should be transferred. Remember, when you refer them, they may require transplant, they may not require transplant. But they should be at centers which can do the transplant if it is required. And there's a very good data to even show that even the medical management outcomes are better in transplant centers as compared to non-transplant centers. So you should be in dedicated liver units only and not at other places.
I think we need to close the session for the time constraints. May I request the chairpersons to close the session?
We hereby close the session. Thanks, Akash, for a brilliant oration. Thank you.
Thank you so much.
May I request the chairpersons to give a token of appreciation to Dr. Akash Shukla. Akash is basically from Raipur and now heading the Department of Gastroenterology at KEM, which is my alumni as well, and heading the Department of Hepatology at Sir Reliance, and doing great transplant work at both the centers. Thank you, Akash. May I request the chairpersons to collect their mementos from the memento podium. For the next session, we have a world authority on interventional endoscopy, Dr. Mohan Ramchandani, who is the Director of Endoscopy at Asian Institute of Gastroenterology at Hyderabad. The chairpersons for the session are Dr. Kuldeep Solanki, Senior Gastroenterologist from Raipur, Dr. Jeevan Lal, Senior Gastroenterologist from Bhilai, Dr. Ravi Shukla, another Senior Physician and Gastroenterologist from Bhilai, Dr. Amit Joshi, Gastroenterologist at Suyash Hospital, Raipur. May I request Dr. Gaurav Tripathi also to join this session as a chair. Over to chairpersons.
Thank you, Lahit. And it's a pleasure to reintroduce Mohan. He is, as already been stated, Director of Therapeutic Endoscopy and International Authority. And he publishes around 50 plus papers every year. He is a pioneer of POEM in India, and third space is the area of interest. Recently, he's taken over the fight against GI cancers, and we are happy to welcome you at Raipur, and you may please start.
Thank you, Kuldeep. Thank you so much for the kind words. And at the outset, I thank Lalit and their team, Dr. Sandeep, for giving me this wonderful opportunity. So GI bleed is a common problem, and all of us in clinical practice see them. Some of them are so severe that they need to be admitted in ICU. And this is the case which recently I saw. 65-year-old male, he had hematochezia. He was bleeding like anything for last 3 days. There was no hematomesis. He required 12 transfusion in 3 days outside hospital. Apart from that, there was nothing like abdominal pain and no cause of GI bleed obvious, neither chronic liver disease, NSAID or anything, anticoagulants, no past surgery. When he come to us, what was there? He was in shock. His BP was low, he was tachycardic, and then the skin was pale. There was no stigmata of chronic liver disease. No mild splenomegaly was splenomegaly also not there. The rectal examination showed dark blood. Otherwise, he was okay. So we shifted him to ICU. And in ICU, whenever a patient of GI bleed comes, I think I follow the ABC sit fix rule. What is that? We must first of all see whether he requires intubation because he is massively bleeding. What is his blood pressure? Whether he is on anticoagulation, which can be reversed, otherwise he may die. What is the source of bleed? Whether it's variceal, non-variceal. We'll investigate further what therapy we can start. sometimes we may start octreotide for varicella or terlipressin, or sometimes proton pump inhibitors. Then we think about whether to we should do endoscopy for this or not. Intensive care monitoring is one, and then I start talking to my cardiologist, nephrologist, and intensivist what we can do. So this is how we see this patient. He came to us in ICU. We started resuscitation. With general, as soon as patient come to us with GI bleed, we must triage them. Like this patient who has severe hematochezia, shock, we must know what is the first thing which we do after all the resuscitation will be done. But what I see is, I see the shock index. Shock index means the patient's systolic blood pressure versus heart rate. If heart rate is more than blood pressure, like this patient has heart rate of 110 and BP of 90, that means heart rate was more than systolic pressure. So his shock index was more than 1. So whenever there is a shock index of more than 1, this goes to a different investigation modalities, because if the shock index is high, that means patient is bleeding heavily, and we should investigate in such a way that not only the investigation gives us a clue, but also treat that. So say for example, this patient has hematochezia, I will do immediately a CT angio because his shock index is high. You cannot do endoscopy, you cannot, because he is hemodynamically unstable. Colonoscopy will be futile because the colon will be full of blood, nothing will be seen. So this is how we do. In this case, shock index was more, so I'll come back to the case. But suppose shock index is okay, that means he is not that bad, hemodynamically stable. We still don't rush for endoscopy. We calculate the risk score, and for lower GI bleed, in this case, we do a Auckland score, which is very simple to calculate, like age, gender, previous lower GI bleed, digital rectal examination finding, and so on. And if the Auckland score is less than 8, I send this patient out of ICU because he will not require much of intervention. But if it is more, I will keep him and continue to ICU. Similarly, for upper GI bleeding, we must do a Blatchford score. This is also very simple to do. This is nothing but when to send this patient home. If my Blatchford score is 0, he will not even require to be admitted. But if it is more, then we may admit in ICU or in ward, depending upon the severity. But this negative predictive value is very high, and they can be sent home. The second thing which I do after triage, okay, this patient is shock index is high, he requires further treatments. We do start transfusion. Transfusion, as you know, is a ICU. We now well known that we must do a restricted strategy rather than a liberal strategy. The patient received 12 units of blood without any monitoring, so we must have a restrictive strategy, transfuse only if the hemoglobin falls below 7 rather than targeting it to below 8 or 10 or 9. We also use TEG, which transforms transfusion from protocol-based to physiology-based, and we know when to give fresh frozen plasma, when to give cryo, because in cases which comes to us like chronic liver disease, we see from ICU, we say, oh, INR is 3, and he cannot be sent for endoscopy. In cirrhotics, there is a rebalance of hemostasis. Of course, there is a high INR, but also there is deficiency in protein C. So there is a rebalance. There is a rebalance, and the hemostasis is in a very fragile condition. Anything like renal dysfunction, infection, or alcohol can make this disbalance, but INR being high in a cirrhotic will not be a contraindication for endoscopy. We must do TAG, and in this case where INR is very high, platelets are low, but TAG is absolutely normal. So INR is not a good test to tell us about the true status, because it's a very, very narrow approach, the approach should be based on tag, and then we should decide. In this case, like this patient has a normal tag, and he was okay to do any therapeutic procedure also, even biopsies. We see a lot of patients who have high INR but normal tag. So this is very important to resuscitate patient like this, restricted, transfuse with that with the some protocol in mind. Now, this patient who came to us with hematochezia, we must also know where he is bleeding from. Is the hematochezia being always colon? No. So there, the bleeding mostly is in upper GI, and the upper GI sources are now also changing. If you see the previous series is where ulcers make the majority of cases, with the advent of PPI, this is becoming lower, and there is a neck-to-neck competition between variceal and peptic ulcer bleed. Similarly, the lower GI bleed is also commonly seen in India, but mostly attributed to IBD. Now, in this case, which we are dealing with, had no hematemesis. He has only severe hematochezia. But we must know where he is bleeding from, whether it's upper GI or lower GI. So put a Ryle's tube. If Ryle's tube is showing blood, it is mostly upper GI source. But if it is negative, in 16% of the time, even with the upper GI source, Ryle's tube aspirate may be negative. So don't rely too much on Ryle's tube aspirate, but most important is the history, which if hematemesis is present, mostly the lesion is proximal to ligament of Treats. If melena is there, still mostly it is upper GI source, barring some lesions in the proximal colon. In this case, which we had, who had required 12 transfusion, presented to us hematochezia, means, and also the shock. But once this combination happen, hematochezia with shock, there can be upper GI source, because the bleed is so brisk from upper GI that it travels rapidly from the stomach or from the duodenum to the colon. But whenever you feel hematochezia as upper GI, there should be hemodynamic instability, because these are brisk bleed. As happened in our case, patient had shock, he had hematochezia. So I'm thinking about upper GI source in this case, and that's why I'm planning to do endoscopy, but at 2 a.m. in the ICU, you will think whether we should do endoscopy or not immediately. Immediately means in 1 hour, or we should wait. Or are there any medications which can help us? So the advantage of immediate upper GI is that we can get an immediate diagnosis, we can triage the patient, we can start therapy, but the problems are availability, risk involved, and the cost. So what we can do is, we can, even if patient has a bleed, we can start the patient on PPI, that is IV 80 milligram stat, 8 milligram per hour. That causes not reduction in mortality, but ulcers with clean base. That means those patients will have a better healing of ulcer, not requiring endotherapy. So at least we can, ICU, we can start them on IV PPI. So by now we have done hemodynamic optimization. We have corrected coagulopathy based on TAG. We have inserted the NG tube. We have started the proton pump inhibitors. IV erythromycin is not available in India, but we can start some prokinetic if we are contemplating to do endoscopy first. Antibiotics are must if we are considering the variceal bleed or the patient is in shock, and the vasopressor may be started. So now we are still thinking whether endoscopy should be done immediately or not. So we should do endoscopy thinking that those patients who are in high risk, like those patients who are high age, shock, comorbid illness, these patients have higher chance of getting something on endoscopy, but the problem is when to do. If patient come to me at ICU at 2 a.m., should I do the endoscopy within 1 hour, 2 hours? The answer was given by this very nice trial by James Lau in NEJM. They showed that if you do urgent endoscopy within 6 hours, neither you can reduce the mortality, neither you can reduce the further intervention, hospital stay also remains same. So there is no point in doing very quick endoscopy. Just wait, resuscitate, start the treatment. The colonoscopy also, if you do very quick colonoscopy, it's of no benefit. Within 12, even 24 hours endoscopy, colonoscopy has not been shown to be very effective. There is no reduction in mortality or endoscopic intervention. Even if patient come to you with hematochezia, hemodynamic instability, if responding slightly to resuscitation, wait for some time. What about intubation? Whether you will intubate the patient once you are in the ICU or not. So the intubation has been shown, if you intubate everybody, then it can increase the aspiration pneumonia, increase the mortality, it can harm the patient more than benefit. So the selective approach should be intubate only those who are severely altered mental status, massive hematemesis with ongoing bleed, severe hypoxemia, or severe hemodynamic instability. Otherwise, we do not want the patient to be intubated before endoscopy. What about bringing the endoscopy in ICU? If you bring the endoscopist in ICU with the patient being on ventilator, it is very helpful because you can have a diagnostic success. You can 64% may be treated by there only, and the hemostasis achieved is also high, but the procedure-related complications are okay. So in this study, it showed that clearly that we must consider bedside endoscopy in ICU who are mechanically ventilated, who have acute upper GI bleed, and who have contraindication to transport like severe hemodynamic instability. So we can bring them. Now it is 8 a.m., everybody is in the hospital. What to be done? We have not done in this patient. We have just waited for some time. Patient is hemodynamically not that bad. Now, should we do endoscopy or not? So in endoscopy, we may find many other problems, but in ICU setting, I will say that stress-related mucosal disease is a major problem. This happens because in the critical illness, there is shock or hypotension leading to splenic and mucosal hypoperfusion, leading to decreased mucosal blood flow. And as you know, the mucosa is a very important, mucus is very important protective mechanism from the GI erosions, and subsequently with many other factors working together apart from acid, there can be acute stress ulcers. And whenever the patient is on mechanical ventilation without enteral nutrition, or patient has coagulopathy or more than two of the following like shock, sepsis, acute kidney injury, these are very high risk for stress-induced ulcer, and these should be put on prophylaxis. And the prophylaxis should be IV PPI or H2 blocker, both are equally effective, maybe PPI more, but if you do too much, then there will be more complications like Clostridium infections or aspiration pneumonias, so we have to balance. So only give prophylaxis to high risk or very high risk, not to low risk or moderate risk, because there is other problems also. As an endoscopist, we go in and see whether there are ulcers. The ulcer can be actively bleeding, or there can be a visible vessel or clot. I'll not go into these details, but there are many armamentariums available to tackle these bleeding. As an endoscopist, we have clips, we have thermal coagulations, and these can be managed very, very easily as an endoscopist. And the most important thing which I found out in ICU setting, when the expert endoscopist may not be available, there is some hemostatic powders which are coming out. Many companies are there. They are adsorbent. They absorb the fluid part of blood, make the clotting factor more concentrated. So it requires just an endoscope to be put in and spray everything. So that can buy us some time till the more further expertise is available. So hemospray is one which we use in ICU setting. For variceal bleeding, we have other options like banding, which we do very commonly. In the most important, the gastric varices are treated by, most commonly now, by IR, where interventional radiologists do BRTO, but in acute setting, we are able to inject glue and coil under EUS guided, and this is a big varices in the stomach, and you can see the needle is being passed and coil and glue being injected to achieve the hemostasis. That is equally important because if the blood is filled in the stomach, you can still do this therapy. So these are some of the ways we are able to do these therapies. In ICU, what I find is if the first banding or glue doesn't work, we have Sangstecan Blackie tube, but gradually it is going out of disrepute because there is aspiration, asphyxia. We have now the stents, which do not require fluoroscopy, and these ELA stents can be placed bedside. You can see in this patient, we are putting on the bedside. The patient is actively bleeding from the post-EVL ulcer. This can be a bridge to the tips or transplant, but we can save the life for first few days till the definitive therapy is available. And you can see in view of even massive bleeding, you can control the bleed, and the whole blood is filled in the stomach, and you can without fluoro, you can pass this on bedside and achieve the bleeding. So this is how the bleed is controlled. Acute bleed control in almost 100%, but mortality does not reduce. Uday 60%, 60-day mortality is around 75%. So these are the modalities which will control the acute bleed, but not. So in the end, I will say that whenever you see a patient with bleeding patient in ICU, consider stress ulcer prophylaxis. Think about timing of endoscopy. Hemostatic techniques are for endoscopists. Variceal bleed, I have shown you. Bedside endoscopy, you can think about when the patient is hemodynamically unstable, ventilator, you call your endoscopist in the ICU. Selective intubation is the key. You should not selectively intubate everybody because that can harm the patient. Coming back to our patient who was very sick, hematochezia, CT was done, angio was normal, patient was resuscitated in ICU, restriction transfusion strategy was adopted. Next day, upper GI colonoscopy was normal and the patient was bleeding. So CT angio normal, upper GI normal, colonoscopy normal. What to do next? We went with the longer endoscope. You can see there is an endoscope which is a long, this is an enteroscope. So it went slightly beyond the D2, D3, and we could see a lot of blood. And you can see there is a big clot. So this is an artery which is bleeding, but because of the clot, the CT angio was normal, and the upper GI and colon was normal because this patient, we could not reach there. So these are the armamentarium which can help us to catch these very, very difficult patient to manage. But with the proper coordination between intensivist, gastroenterologist, and interventional radiologist, and of course the surgeon, we can achieve this in a proper way. Thank you very much for your patience here.
It was an excellent overview, Dr. Mohan. What is the position of SB tube in managing the variceal bleed?
Actually, a few days back, I was searching for SB tube and we could not find in our department. Somebody put in the fridge, in the freezer, but no more. I think it's very difficult to procure also because of the problem involved. One, aspiration, and ultimately you have to remove it next day. So with the advent of those stents, which can achieve the same goal with no aspiration, with the proper feeding being continued, a Sangstecan tube you cannot feed the patient. So there were a lot of problems with Sangstecan tube, although it was very helpful for buying some time, but I think stent has taken over its role, and probably Sangstecan tube is almost now vanished, but may be available if in the cost effect, because if there's a cost involved in the stent, it can still be used, but majority of the centers are not using now.
Any query or comments from the audience?
What? Yes, sucralfate has not been recommended by the society as a prophylaxis. That is no more recommended. People use it, but it is of no benefit for the mucosal disease which happens in ICU. Only PPI are recommended, H2 blockers are recommended, and only with high risk, because there are criteria for high risk and we should only use them.
Because potential was to reduce the excessive bacterial growth proximally in the intestine.
Yeah, but it should be effective for bleeding also, prevention of bleeding. So the bleeding rate have not been shown to be better with sucralfate. So that's why it is not recommended.
Thank you.
Thank you, sir, for a very good lecture. I want to ask why we should not done capsule endoscopy in this case before enteroscopy, because the source was not clear.
Yeah, so capsule endoscopy is good for diagnosis, but it doesn't have any hand. So you do a capsule, prepare the patient, do the capsule, wait for 7-8 hours to pass, and then somebody will read. By the time 24 to 48 hours will pass, and you will lose up time. So whenever you see a patient with so-called obscure GI bleed, when you have done endoscopy, colonoscopy, both are normal, patient is hemodynamically unstable, you must do an intervention which has got therapeutic capabilities. So the enteroscope becomes the treatment or diagnosis of choice in this case when we are fighting for the time. You know, we don't want to waste our time in diagnosing first. And capsule endoscopy is also not without any problem. If you see blood, it is drowned, you will only see the blood, you will not see anything. Or there can be a gist which can be quickly passed for the capsule, and capsule will be falsely negative. So capsule is also not, but yes, if patient is hemodynamically stable, there is obscure occult GI bleed, not overt. Overt with hemodynamic instability, enteroscopy is the first choice. Or CT angio is the first choice. Or angiography is the first choice. But obscure occult bleed, I agree with you that in such cases who present to us with anemia and FOBT is positive, in such case, capsule should be done to have a roadmap and subsequently go by the enteroscope.
Thank you.
So, my question is, should platelets be corrected before?
No, as I said, platelets in setting of, so that there are criteria for therapeutic endoscopy. If platelets are more than 50,000, you should not transfuse anything. If they are below 50, you can, but you must do TEG. Also in chronic liver disease, you must not depend on platelet counts, must not depend on INR. You must do thromboelastography to see what is the problem and treat them accordingly.
Dr. Mohan, what is your preferred modality for endotherapy, particularly in a patient with a deranged coagulation profile or a previous use of dual antiplatelets?
No, that's a very important question. Actually, we have seen that if you use mechanical blockers like clips, OTSCs, they are better treated. While if you do thermal ablations or by injection, they may cause more bleeding. So there is no hard data on this, but our experience, we feel that if the patient is on antiplatelet, better to use mechanical therapies rather than thermal therapies. Because the raw area which you create with thermal therapies will keep on oozing with the anticoagulation or antiplatelet actions.
Mohan, with logistics becoming more favorable, do you see in near future the endoscope being passed on, upper GI endoscope specifically, passed on from gastroenterologist to the critical care personnel, as lot of instruments they have already been dealing with?
I think any modality should not be restricted to one particular person. It should be for patient. And if our intensivists are well trained to triage these patients properly,
Especially
they definitely
with collagen spray.
Of course, yes. That I told you that if somebody is in ICU late in the night and they have the access to endoscope, they can definitely do the endoscope. And if they are not very well trained in therapeutic endoscopy, at least there are modalities which can, like as I said, spray the powder, give the tamponade, and wait for the morning.
Yeah, Mohan, it was an excellent presentation.
Thank you, sir.
Regarding when the patient comes with massive GI bleed and patient is in shock, upper GI endoscopy is normal, colonoscopy is full of blood, we either go with enteroscopy or with interventional radiologist help. So in deciding enteroscopy, how do you decide whether to go antegrade enteroscopy or retrograde?
So if patient is in shock, I always take a help of CT. So if there is a CT angio, if CT angio is negative, then most of the time we based on the either history or data. If the patient majority of the bleed happens 80% in upper GI area, so we must go with the oral route first, because even if you want to go by anal route in actively bleeding patients, you have to go from the dirty area to clean area. While in enteroscopy, if you are doing orally, you are going from a clean area where you are not finding anything, and suddenly you find blood, and that is the area of active bleeding. If you go retrograde, you are going through blood, you will not be able to reach, and then it is difficult for us to go from a bloody area to normal area. So always start with antegrade enteroscopy in such situations.
For the final
Masterly,
comment.
yeah, masterly one.
Thank you.
But for a resource limited setting, where all these enteroscopes are not available, there are so many places people would be bleeding.
Yes.
There are many ICUs which are built in peripheral towns and cities also.
Yes.
So is there any role of intraoperative enteroscopy where they might be having upper GI endoscope and colonoscope but may not be having enteroscopes?
Yeah.
So in those particular settings which are resource limited, and still I believe that there is a role of intraoperative endoscopy to cover those uncovered areas, those unseen parts, so that patient can be taken care of. That is one thing.
Yes.
And here I would allude to what Kuldeep said, that probably in next few months or years time we will have point of care endoscopy in addition to point of care ultrasound.
Completely agree with both of your points, sir. Yes.
With that, we are happy to close this session.
Thank you. Thank you so much.
Thank you, sir. I request our chairpersons, please felicitate our speaker with mementos. And I request our chairperson, please collect their mementos from memento podium. And I request again Dr. Ajit Sadani, please felicitate our chairpersons with memento at memento podium. Dr. Ajit Sadani, please. Now we move to next session. I invite to chair the session Dr. Mukesh Sharma, Dr. Rajkumar Baranwal, Dr. Karan Saraf, and Dr. Vachhani. Please on the dais to chair the session.
Next session on contrast-induced nephropathy shall be delivered by Dr. D.M. Bhaumik, sir. Sir is Professor Nephrology at AIIMS, and he has more than 218 publications to his name.
I request Dr. Suneet Chaudhary, please also join the dais as a chairperson. Dr. Suneet Chaudhary.
Change a second.
सर वो पैनलिस्ट में ना
So, welcome, sir. So today's topic, contrast-induced nephropathy, myth or reality. So we have lot of cases across the specialty, and we fear any patient in AKI to do contrast CT. So, sir, welcome you for the talk.
Thank you, chairpersons. It's really an honor and privilege to be here for this conference, and I thank my dear friend Dr. Sanjeev Kale, with whom I've been associated last, I think, almost 35 years now. We worked together initially in 1990s. So I thank him very much for inviting me. I thank Dr. Vishal as well, and a very well organized and very well populated gathering. So I'll be speaking this afternoon on contrast-induced nephropathy and whether it is a myth or it is a reality. So the first case of this thing was in 1954 when the myeloma patient who developed acute renal failure. At that time it was called acute renal failure. We have now changed the terminology after contrast. And that's how the term contrast-induced nephropathy came into being. In the last 20 years, we have changed our terminology of ARF to AKI. So the term now used is contrast-induced acute kidney injury. And in my presentation here, I'll be talking about contrast CI-AKI. And the pathology is intense renal vasoconstriction, osmotic diuresis, and a direct tubular injury. I'm not going into more details regarding the pathophysiology, but this is the known pathophysiology. So how is it diagnosed? Most of the studies are with this very conventional characterization of creatinine increase of more than 0.5 mg per deciliter or 25% rise in serum creatinine from the baseline, which is assessed 48 hours after contrast administration. In a minority of cases, the peak may increase even later until 5 days. We have our acute kidney injury network and the KDIGO, which is the international body, which defines AKI, and there it is 0.3. So in fact, in their commentary, they've written that we don't understand why for CI-AKI there should be a different definition, but that's how it is. So I mean, both these definitions have been used in various studies. This mainly for CI-AKI, and this is our standard definition of 0.3. So what is the incidence? If you see the earlier studies, that time itself it was shown that in a patient with normal renal functions, even in diabetes, it is just about 1 to 2%. And but however, it is the third most important cause of new AKI in hospitalized patients, where it is almost 11%. And incidence in high-risk cases jumps up to almost 25%. So this is in 2008. What about critically ill patients? So in this study, in 75 ICU patients, where they used a low osmolar agent, it was almost 18%. So the traditional risk factors for CI-AKI, this is what is taught, is a patient-related, so advanced age, more than 60, diabetes, existing CKD, heart failure, nephrotoxic drugs, hypertension, sepsis. But as you will notice that, all these things anyway cause AKI in the ICU setting in any case. So, I mean, that's the problem, and that's what I'll discuss subsequently. And the contrast agent related, it is osmolality of the contrast agent, which is most important. High contrast agent is when the osmolality is up to 2000, which we don't use anymore. Nowhere we use it anymore. So all the earlier studies were actually based on this contrast. The low osmolar or the non-ionic contrast is 600 to 800 milliosmoles per kilo. And isoosmolar is isoosmolar to blood. So that is 300. So one is osmolality. Second is the volume, and various ratios are there. So this is one such thing where if the volume is to the creatinine clearance is more than 3.7 or 4, then you're more likely, or repeat contrast administration within a week or 10 days. So why we call it? Why could it be a myth? Because as I said, the earlier studies are all based on high osmolar agents, and many subsequent studies showed that actually in those patients in whom contrast was used or it was done even without contrast, it was very similar. And the clinical significance is not so much in the current era. And many cases are actually contrast-associated AKI, which I showed in the ICU setting. They may be having nephrotoxic drugs, sepsis, hypovolemia, etc., etc. And in 2004, Chertow, he's a very famous nephrologist who's done a lot of work, a lot of clinical trials. He passed away recently. So Chertow, in his paper, a large paper, he showed that there were low rates of coronary angiography, CAG is coronary angiography, or stent in the elderly patients with CKD. So which he thought was very unfair, that these patients were being, denied the proper therapy. And this unnecessary avoidance or delay of essential imaging leads actually to worse outcomes, which he termed as renalism. So this is the term which he coined and which has stuck on. And several publications have been there in renalism thereafter, including one very recently in 2025. So renalism is the issue that this is a myth, and one should not talk about contrast-induced nephropathy at all. So now coming to current era. So this is one study, retrospective study, where they did CCT in 160 patients, various indications, using low osmolar, and standard around 100 ml IV, and hydration was given. Serum creatinine was done after 42 to 96 hours. Various variables were documented, and CI-AKI was 8.8%. And the only effectual risk factor in this study was the initial serum creatinine level. So, I mean, it's not something which you can wish away, because there is an incidence of around 8-10%. Now, what about CI-AKI in CKD patients? So, in this study of 405 adult CKD patients, you see most of them were CKD 3. The other CKD stages was 40, 50 each, and the mean age 62. In fact, all the studies now are in this elderly. So, I mean, it's the elderly group on which we are focusing, and all of them had received IV saline, pre-post procedure, and the CI-AKI was 11.1%. And diabetes was a very significant risk factor. And also, if you give it arterial, then the risk is higher. So arterial means coronary angiography, as opposed to the other CCTs. Age, sex, and CKD stage in this study did not influence. And so they concluded that CI-AKI is a common complication in CKD patients. And they recommended, this recommendation is very important, and on which I'll again repeat at the end, is that pre-procedural risk assessment and appropriate prophylactic measures are essential to minimize CI-AKI, rather than just calling it a myth. So it is not a myth, but then one has to take the proper precautions. I told you that the other agent which is used is the isoosmolar agent. So what about if you use the isoosmolar agent? So this ioxaglate is the standard low osmolar, and iodoxinol, which is available in the country, is the isoosmolar agent. It's more costly, of course. So in this IDPC trial, they had 2,000 odd patients, which constituted 14% of the whole group, which is 16,000 patients. Okay, so who had one of these high risk factors: age more than 70, diabetes, non-dialytic CKD, heart failure, cardiogenic shock, or ACS. And when they studied this versus this in this group of patients with a contrast volume of around 90, you see CIN was 15%. So that is quite a bit, isn't it? And death or dialysis occurred in about 3.4% patients. So they concluded in high-risk patients, incidence of CIN is high even now, even with a low volume. And there's no difference, at least in this study, between low and isoosmolar contrast agent. Moving on now, we have better markers for renal, diagnosing renal insufficiency now, and cystatin C is one such compound. And it is basically produced by all nucleated cells, which is freely filtered by the glomerulus, as opposed to creatinine, which is produced from creatine phosphate in the muscles, and it's also freely filtered. But it is less cystatin C is less affected by age, sex, race, and muscle mass, but it is more expensive and less widely available. But the advantage is that the levels increase earlier, and it can predict AKI earlier than creatinine with a higher sensitivity and specificity. So this may be a better marker for picking up CI-AKI. And in this systematic review, in 7 prospective studies, they found that in 6 studies, it was a better marker. And the cutoff value was 1.03 milligrams. Please note here for all students as well that the value is almost the same as creatinine, except that the denominator instead of deciliter is liter. So creatinine we measure in milligram per deciliter, the cystatin C is in milligram per liter. And they took cutoff value, because it's not standardized. The thing is, cystatin C cutoff values for renal insufficiency is not that well standardized, but roughly you can remember this as the value. So earlier diagnosis than creatinine is a more sensitive indicator of renal dysfunction. Now, because CIN was a problem earlier, you see way back in 2004, this Mehran risk score was developed based on these risk factors of hypotension, intraarterial balloon pump, heart failure, elderly, anemia, etc., and renal dysfunction, and the scoring system was done. And as you can see from this scoring system, that anything more than 11 was quite bad, which risk of CI-AKI is 26%, with even a risk of dialysis there, and more than 16 was very bad. So they concluded that this risk score can be used for clinical and investigational purposes. Sorry. In the US, they also have a sample questionnaire which is used by the radiologists when sometimes creatinine is not available. So you have this whole list of things which the patient is given to fill before the procedure. Moving on now to more advanced things, we have now other predictive markers. So there's a lot of study now on various inflammatory indices because finally it's probably an immune response. So in this retrospective study of 281 patients with acute ischemic stroke who underwent some endovascular treatment was thrombectomy, and they studied CIAKI. They found CIAKI in 19% cases, and this was the problem again. And they studied 4 inflammatory markers, not remember all of them, but all of the 4 were found to be very useful in predicting CIAKI. And the best was the systemic immune inflammation index based on plated into neutrophils upon lymphocyte count. The calculation of all these 4 are very simple, actually. They're very simple. So, I mean, one could use them for predicting CIAKI. This is a very recent study. The other marker, which is also very simple, is glucose to lymphocyte ratio. So, in a single center retrospective study in 592 patients, where primary stenting was done, they again studied this glucose lymphocyte ratio and they kept a cutoff value of 4.16. Because what happens in stress is there's stress hyperglycemia and there's inflammation with relative lymphopenia. So, you look at the score again. And they found that those who had high GLR, they had a much higher CIAKI. This is another interesting way of diagnosing CIAKI from a recent paper where an 85-year-old female with acute myocardial infarction with a borderline creatinine who was given quite a large amount of iodinated contrast. The creatinine increased next day and then she became anuric. And then when you do NCCT, mind this is an NCCT 4 days after contrast, you can see the kidney still lit up because the contrast was being retained. So this could be another way of diagnosing CIAKI. Moving on now to prevention strategies. So how do we prevent it? So the disease does exist around 10-15% in the high-risk group. So how do we prevent them? We definitely stop metformin in all patients, stop RAS inhibitors, stop NSAIDs. This is controversial. I mean, there are a lot of papers for, against, and many papers have said that those who are on SGLT2 inhibitors, overall AKI is less. I personally feel that, anyway we stop SGLT2 inhibitors, we have a sick day rule. If anyone has vomiting, diarrhea, any illness, we just stop it. So I think it's a good idea to stop in these prospective patients as well. We continue statins, that's useful. I'll come to NAC subsequently. You hydrate all of them with sodium chloride or bicarbonate. Again, this is controversial. Use low osmolar or isoosmolar contrast media and use the minimal volume of contrast agent in the high-risk group. This is from our textbook, the 11th edition, and as you can see here, no benefit or harm is seen with all these initial loop diuretics, mannitol, dopamine, phenoldiazepam, maybe even hemodialysis. Unclear statins, but we do use statins, and beneficial is isotonic fluids and low osmolar agents. Now, what about NAC? So in this meta-analysis, what they found was that if you give NAC, oral NAC, along with low osmolar contrast media, that's the LOCM, then it was definitely beneficial. So this was in the Annals of Medicine 2016 meta-analysis where they found that giving oral NAC, not IV, oral, with low osmolar contrast agent was helpful in preventing CIAKI. Of course, giving along with IV saline, which is given in any case. Then came the PRESERVE trial, a very important trial in NEJM 18, so it's already 7 years. It was a 2x2 factorial design trial of 5,000 patients who underwent coronary angiography, and they had high risk for renal complication as defined by EGFR of 15 to 45 or a diabetic 45 to 60. they received 2 factorial, no? So 2 into 2. So, I mean, it was either bicarb or normal saline or NAC or placebo. And it was actually stopped after interim analysis because no benefit was found of either bicarb or an acetylcysteine. So the preserved trial concluded that it is no good. Both are no good. The other thing is that what about CO2 angiography, which is now being done in many places. So in 272 diabetic foot patients who had to undergo some endovascular procedure for infrainguinal chronic peripheral arterial disease, 64 patients received CO2 angiography, 208 patients control. You see there's a contrast volume of 24 ml even in the CO2 angiography because you need it initially to localize the lesion. So, but they received much less contrast than the control group who received 89. Technical success was fine, and the CAKI was much lesser in the patients who underwent CO2 angiography. So, this definitely reduces the contrast dose and AKI. Nicorandil is the other drug which has now been studied to prevent AKI, and in this systematic review and meta-analysis, they found in 11 RCTs with about 3,000 patients in whom they gave Nicorandil, they found that it was quite useful. And this is the forest plot. The other interesting thing which has now come up is the remote ischemic preconditioning, and this was the BRIC randomized controlled trial. And they took the high-risk patients with a Mehran score of more than 11. This is very recent, 25. More than 11, and who were undergoing CAG for ACS, contrast volume less than 100. The Mehran score had this cutoff of 100, no? Less than 100, 1 point more than 100, whatever. So they took everyone as less than 100. And they randomized 1:1 RIPC versus sham. I'll come to the procedure in my next slide. And the primary outcome was the development of AKI. And secondary outcomes are studied with this NephroCheck. NephroCheck is now available even in our country as a point of care in the ICUs for diagnosing AKI, and as well as this cyclic GMP levels. And it also studied the major cardiovascular and cerebrovascular events, which is the MACCE. And this is how it is done. This random ischemic preconditioning. There are 3 cycles of 5 minutes of upper arm ischemia, the blood pressure cuff is inflated to 200. So, I mean, 5 such cycles. And the sham also had inflation, but only up to 100 mm. So, and then they did the angiography. And the results were very helpful. This is a study from AFMC Pune where they found that if you just give oxygen 2 liters per minute, that helped. And this standard procedure now in all the army hospitals. This is what I found out. To summarize, contrast-induced AKI in normal individuals is less than 2%, but in high risk, it is 10 to 15%. You can predict it by various scores and inflammatory scores. You can prevent it by standard isotonic saline or isoosmolar agent. And now the CO2 angiography and the remote ischemia preconditioning. Nicorandil and oxygenation need further studies. So we have to go from renalism to realism. See, renalism is that you are avoiding doing a procedure or delaying it because of the fear of CIAKI. So although there is a risk which is real, one shouldn't avoid it. Rather, counsel the patient appropriately, take consent of possible AKI, progression of CKD or hemodialysis, and take the appropriate preventive measures. So one must do the procedure, never deny the procedure, but do it with precautions. I spoke about the iodinated radio contrast, but also the other contrast agents which are used. One is the GAD, which is now used very commonly. And the worry there is the nephrogenic systemic fibrosis. If it occurs once, it cannot be treated, and the patient is doomed lifelong. So that's why we're very frightened. But we have the safer macrocyclic ionic. Please note here it is the ionic agents which are safer. It was non-ionic in the radio contrast. And up to 25 EGFR, no problem. Fluorescein angiography is the other thing in the eye department which is used, and often we get references. That's why I showed this slide. And if you give this dye in renal failure patients, they look all yellow and ectric, but there's nothing to worry. It all goes away. It doesn't cause any problem. And that is the teaching. We had a detailed study with cystatin C and NGAL, which showed actually some renal dysfunction in some patients, almost 30%. So I'll stop here and leave you with this quotation by Marcus Aurelius, who was a Roman emperor. He was the last of the great good Roman emperors. So it is my views and it is open to discussion. Thank you very much.
Thank you, sir, for your excellent presentation on contrast-induced nephropathy and reality and myth. Now the matter is open for discussion. If anybody has any query, please come forward.
Very nice. You had covered almost everything. See, I'm a cardiologist. So basically now we are talking when we do intervention, we are doing it in acute coronary syndrome, acute MI and primary angioplasty, where you cannot avoid taking a patient because it's a life saving. So where we have to think about cardialism, not renalism. So it's saving life of a patient because even if the kidney is involved, the patient can be saved and the kidneys can be taken care afterwards. So we are nowadays talking about zero contrast angiography and angioplasty. So what we do is we are doing IVUS and we are doing OCT, where hardly any dye is used. So this is the solution from the cardiologist side to avoid a contrast-induced nephropathy. Thank you.
Thank you.
Hello. So, very nice overview on contrast-induced nephropathy. Just a thought again, the site of procedure, does it matter? Radial versus femoral approach, does it matters?
Yes, arterial is worse than venous. Yes,
radial is preferred over femoral there. So.
I am not sure about that. I have not seen. Maybe he can answer. Yes.
Radial is preferred because of the complications of bleeding. Bleeding is more common in femoral. Okay. The amount of contrast which we use, basically it's a learning curve. So initially when you are doing radial, more amount of contrast you will require. Mm-hmm. Technically it's more easy for a newer person to get from the femoral, but nowadays more and more people are radialist. Yes. So the best thing is avoid CINS, hydration. Absolutely. That is the only answer.
Absolutely.
Whether you do renal, whether you do radial or femoral, it doesn't matter.
Thank you, Dr. Vomik. It's sir here. This side, sir.
Chairperson.
Oh, okay.
Yeah. So it's definitely a real clinical situation, not a myth, unless until it's properly diagnosed and we see the response to the therapy. So at what point of time you decide your diagnosis is not contrast and you have to go for other etiology and renal biopsy?
Obviously, as I said, all these patients may be having other factors like sepsis, drugs, hypotension, hypovolemia. So actually, it's a diagnosis of exclusion. In fact, our textbook will say the first thing is that you have to exclude all other conditions before labeling the CIN. That is one. Biopsy, normally we do not do so early. Normally, biopsy is done after 7 to 14 days. If the urine is showing active sediments and there is a doubt that there would be a treatable lesion, which is the cause of AKI. So biopsy is usually done at 14 days. Very early biopsy done only at 7 days. I don't think I've ever done a biopsy for contrast-induced nephropathy. If you're thinking of active glomerular disease, then you would do it. Otherwise, you will not do a biopsy.
No,
wait and
if
watch.
there is no response to the therapy, what you are
Yeah, so after
for?
14 days, yes. After 14 days, yes. For prognostication, yes. After 14 to 20 days, yes, definitely.
Sir.
Yes. Can I speak on the mic?
Some of the patients, what I notice after angiography, angioplasty, around 3 months later, they will come in very bad shape and starting requiring dialysis. And some of them actually when I was working in Maharashtra, what I started doing after 1.2, anybody higher 1.2 creatinine, we should do a USG. Many of them had latent MRD actually, medical renal diseases. We used to counsel them separately that you have higher risk actually.
They need follow-up, absolutely, absolutely. So the high-risk cases need follow-up. That's a very important point, and we miss out on that group. They need regular follow-up. In fact, in one of the studies they found that at 3 months, this MACE and like cardiac and the renal events were higher. So follow-up is extremely important. Yes.
And this nicorandil, if we have to give, is it given before the contrast, or like nicorandil prevention?
Nicorandil, they give IV as well as oral. That's why the paper.
But is it before the contrast or after the contrast?
Before.
Before, 4 hours before. Okay, thank you.
They gave before. Sir, sir, it was an excellent talk. Sir, just one question. Sir, what is your experience of contrast-induced AKI in post-kidney transplant patient, if at all it is indicated?
Yes, that's a very good question. Again, we don't deny or really delay. Recently, we don't deny it. And of course, in such cases, they'll always be admitted. See, a post-transplant patient who has problems and needs contrast would be admitted. So they'll, of course, have all the proper precautions taken. And yes, sometimes we do find some deterioration. Of course, in post-transplant, there's other issues coming of rejection and tag toxicity, so it becomes quite a complicated ball game. But then, yes, it's a very important issue there as well.
Thank you, sir.
I didn't cover that. Yes.
Thank you, sir.
Besides hydration, sir, is there definite role of NAC, sir?
Yeah, so NAC, as I said, this preserve trial showed that it is no good. Our latest, actually, KDIGO guideline is 2012, which predates preserve. So that still says that NAC can be given. Now, NAC is, I think, quite safe. And I personally, in high-risk cases, still use NAC. For low-dose NAC, that is 600 BD for 3 days, 2 days pre, and then on the day and 1 day after, so 3 or 4 days. So yes, I do use NAC in many cases, although the preserve trial said that it is not good.
So now we can conclude the session. Thank you, Dr. Vomik, for your insightful
Thank you, sir.
session.
Thank you. I request our chairperson, please felicitate our speaker with the memento. And I request our chairperson, please collect their mementos from the memento podium. I request Dr. Sonika, please felicitate our chairpersons with the mementos at the memento podium. Now move to the next session. I would like to invite the chairpersons, Dr. Nikhil Motiramani, Dr. Sulabh Chandrakar, Dr. Satish Suryavanshi, Dr. Javed Ali Khan sir, Dr. Javed Parvez, and of course Dr. Sumanta Padi sir, if he's here.
Our next session is on arrhythmias in ICU. I request Dr. Somen Devidatta to guide us upon that. He is a cardiologist and electrophysiologist at Apollo Hospitals, Jubilee Hills, Hyderabad. He has more than 12 years of experience to his name, along with multiple research and publications.
Good afternoon, friends. Finally, the real emergency has come. I mean, the people, organizer has kept the cardiac emergency in the last but one session. I think this is the most important emergency we are facing every day and night, and it does not give you time even for 30 seconds. So these are the cardiac emergencies are the most important emergencies. And out of that, the cardiac arrhythmias in the ICU is the most morbid thing which can happen. So we have got a good panel. We have got a Dr. Javed Parvez, who is the electrophysiologist. He'll be talking, he'll be telling something more. Javed, just.
So I will not talk much. I'll just say brief words about introduction of Dr. Somen. Somen sir is an accomplished electrophysiologist. He leads a electrophysiology team at Apollo Hospitals, Hyderabad. He has almost 10 plus years of experience. And if I'm not wrong, sir has done his fellowship in electrophysiology from NHS Singapore. So stage is all yours, sir. Please guide us through this important topic.
Over to you, sir.
Thank you. Thank you, respected chairpersons. Thank you, Javed. Really humbled with the introduction. I must thank Dr. Vishal for having me here. In fact, I was mentioning Javed. I'm absolutely flabbergasted with the pedigree of the speakers, the content. It's been just blown away with the kind of information that we've been exposed to since morning. And it's absolutely my privilege to be a part of this podium. So that said, I'll jump straight to the topic that has been entrusted to me, which is arrhythmias in ICU. I would probably club it with emergency as well, because I think that's the place where we see most cardiac arrhythmias, and that's where the residents and doctors are challenged. Now, instead of making it a didactic, I'll try to compile this talk in a series of cases. Most of the cases, in fact, all the cases that I've seen in the last couple of years with our team, and see whether I can kind of feel free to interact. If not physically necessary, please have a mental calculation as to what I'm trying to, project in front of you and what would be your approach. So let's jump straight. Now, this is a 65-year-old gentleman who has recurrent episodes of faints, has been admitted to the cardiac ICU or even an emergency with loss of consciousness episodes, which are absolutely true. He just faints out of the blue, he drops, and he comes to the hospital, and this is the ECG. We have found nothing. As expected, multiple EEGs and brain imaging, which is a standard, which is a norm in such patients, has been done without giving any additional clue as to what is the problem here. So just take a few seconds to see what's in it, because I'm showing the ECG because that's where the clue is. So notice here, there's a right bundle branch block, and then there is a left axis. So this is clearly an abnormal ECG, and with this history, this ECG is almost conclusive of paroxysmal AV block, and this patient is almost likely to be diagnostic of AV block, and you would not be wrong to consider the diagnosis. So, but unfortunately, this gentleman kept falling, kept having loss of consciousness. We couldn't pick it up, and eventually he got tired of losing consciousness, and then he decided to give a more direct clue. So what is there in this ECG? Again, this if you notice in the first half of the ECG, you have 1:1 conduction with a longer PR interval if you notice closely. Same axis, same right bundle branch, but the second half, clearly there is obvious complete heart block. Notice the very slow escape, which is diagnostic of an infrahyphen AV block, where the escape is very slow and unpredictable oftentimes, which leads to this sudden loss of consciousness. If your rate drops from, say, 70, 80 to suddenly plummeting 25, you're going to lose consciousness. So now it's a no-brainer. That's where we had to apply ourselves when he came with those episodes, unexplained loss of consciousness with abnormal bundle branch appearance in the ECG. But then he went into persistent AV block. It's easy to pick it up here, isn't it? It's an AV block, and he needed a pacemaker. It was done all right, but the challenge was to pick it up when the clues were less. Now, another case, a similarly aged gentleman, same history, 5-6 episodes of falls. In fact, this gentleman had a neck of femur fracture. He was admitted to the ortho ward. He underwent the surgery, and then tragically the AV block was picked up. So if you notice closely, there are two ECGs. On the top is another ECG with right bundle branch block, and at the bottom the ECG, same gentleman, another time left bundle branch block. Now you have dual block, left bundle as well as right bundle branch block at different points in time with this history of loss of consciousness. Again, a sine qua non of AV block. It is diagnostic. You do not need an AV block documentation to consider a pacemaker. And this again was an AV block. Third scenario, similarly aged patient. The history is slightly different now. He has a fixed threshold, sudden fatigue or sudden breathlessness. He says, I don't lose consciousness, I walk, and then suddenly I start feeling serious breathlessness. I just can't walk. I feel fatigued. Now, most of us, which is not necessarily wrong, would consider this as an indication of angina equivalent or coronary artery disease or a valve disease and investigate. Nothing wrong with that, but all those things were done multiple times, didn't yield anything. What was actually happening was this. He was having a repeated Mobates type 2 AV block. What happens is in such patients, when they are at ambient rate 60, 70, they conduct all right. The moment they have conduction disease, which is severe, that is exposed when your rates reach 90 or 100 or thereabouts. That's when the AV block happens. The conduction system, refractory system period is very long, and they go into so-called 2:1 conduction block or conduction. So your demand is 100, you are reaching 90, 100, and suddenly your heart rate falls to 50 because that's where your ventricular rate is at. And that's where you feel extreme fatigue, extreme exhaustion, and that's where his symptoms were. Although he did not have a complete AV block, which is why he probably didn't have a syncope. So these are the things that you need to pick up. Nowadays, we are wiser. We have these wonderful tools where we can record for days and weeks together, where these discrete events which play hide and seek with you can be easily diagnosed. But these are important to pick up. We can pick up these things based on the ECG. If you have a bundle branch block, a longer PR, and structurally normal heart, but the conduction looks sluggish, you need to, anticipate such events. You can prevent many fractures and loss of lives. Now, I mentioned about this earlier. If you do not have a documented event, this is the ECG. Sometimes it can be hard. I do admit. What do we do? Like I said, most of the times to the point of, with due respect, abuse, neurological investigations are abused in such scenarios, multiple brain imagings, multiple EEGs, loss of consciousness or syncope where it is very clear is very, very seldom a neurological event. Neurological events generally have focal deficits. When you have a pure loss of consciousness and the patient gets up with no deficit, it is most likely a cardiac event, a cardiac arrhythmia or a bradycardia. And there, neurological events, neurological investigations do not yield much. So your electrophysiology study is a very simple procedure where you can just measure your conduction system health by measuring an HV interval, which would do the trick for you. And this is an intracardiac trace where we, if you notice, you have A and his signal going together and there is a complete AV block. Okay. Now, this is another scenario. Again, we'll talk about bradycardia. There's a 70-year-old gentleman who had similar falls with repeated head injuries. And every time you see, he's with atrial fibrillation, sometimes fast, sometimes controlled, but his injuries are blamed on fast conduction. And he's treated that, or sometimes over-treated with rate slowing agents or conduction slowing agents, which is a common practice. But what was happening was this. This is causing him. So typically when you have sinus node disease, your bradycardia is not very evident when you have atrial fibrillation, because atrial fibrillation has nothing to do with sinus node. Your sinus node is diseased. The moment atrial fibrillation terminates, the sinus node just does not wake up from its slumber, and that's why you have a prolonged pause. That's why we see something called sinus node recovery time, where we pace the heart fast, try to stimulate or simulate a tachycardia, and then suddenly stop pacing. In you and me, the sinus node will be normal and it'll pick up from where it had stopped. It'll start immediately. But in somebody who has a sick sinus, is going to take an eternity for that sinus node to start picking again. And that's what you see here. The moment tachycardia terminates, you have a long pause. And this is often complicated by the rate slowing agents. We use flecainide, we use diltiazem, calcium blockers, beta blockers. They often complicate the scenario by making it worse. Now we'll switch gears. This is again an active 50-year-old gentleman who suddenly out of nowhere just dropped while he was walking. He fractured his jaw. He was brought to the ER with CPR. By the time he reached ER with the CPR, he had spontaneous rhythm back, but there was no relevant past history. This was the first event. And after stabilizing the next day, this was the ECG. He already had sinus rhythm. Please critically note the ECG. What do you see in this ECG? You obviously have sinus node. Sinus rhythm with normal AV conduction. But notice I've just blown up the inferior leads. There are Q waves and there are splintering in the Q waves, which suggests that there is an underlying inferior wall MI which has evolved. It has happened in the past. And indeed, there was a mild LV dysfunction and regional wall in the inferior air territory was completely akinetic. And in this scenario, most likely this patient had, with that kind of history, had a sudden ventricular tachycardia. But we don't have a documentation because he had passed out outside the hospital. So we took him to the lab. Again, we do an EP study, which is typically the direct investigation for that. And without any sweat, this first ventricular pacing protocol, you induce this monomorphic sustained pathologic ventricular tachycardia, which never happens in normal human beings. Notice that there is a right bundle branch block and there is a superior axis, which suggests that the focus was from the inferior part of the heart, which is the scarred area or the infarcted area. So this is clearly a scar VT in a gentleman who had sustained an inferior wall MI, probably silent or missed in the past, and was having recurrent episodes, or probably the first episode of ventricular tachycardia. Naturally, he needed an ICD, he was implanted, and the last 3 years he had 2 appropriate discharges, both of it were threatening events and potentially life-saving shocks from the ICD. Now, more commonly, in fact, as I say that, I'm dealing with 2 such patients in the ICU. Back in the ICU, you have these very, very incessant, irritating, pulseless, unstable VTs. Most of them are, with critical ischemia. Sometimes you can even have scar-induced VTs like this. Notice they start with one PVC. These PVC has been always there. These are these Purkinje fiber VTs. And they trigger off a set off a VT which is very fast. Notice the plunge in the arterial pressure. In no time, their arterial pressure is just 0. So, and you need to shock them. You shock them for 2 seconds, they're okay. And again, they come back with the same VT again. It keeps happening. You deliver, before you know, you have delivered 20, 30 shocks. The patient's heart is globally suppressed and they go into acidosis and so on. So this is most of the time because of a critical ischemia which is hidden, or even if you had a heart attack or a healed MI, you can have a scar-related VT that way. But most of the time, scar-related VTs are the VTs, like I said, slightly slower and more organized. These are with critical ischemia. So what do you do? Usually they do not respond to antiarrhythmic agents. So most of the times IV amiodarone is started immediately. You have mexiletin, lignocaine. Choice of the antiarrhythmic again depends on the underlying etiology. You need something else, and deep sedation and mechanical ventilation often bails you out of that situation, and at least for the time being, the storm stops. You can get him out of the storm. Not to say the storm won't come back, but at least in deep sedation, about 80 to 90% of your patients, the VTs calm down. Then you can go on addressing the underlying cause. If it is an ischemia, you have to revascularize the patient. Most of the times you need a rescue PCI because they are very high risk for CABGs. If you have a scar VT, if there's no underlying ischemia, the arteries are flowing, then we need to do a catheter ablation and modify the substrate. If not, you make them lighter and they'll be back into the storm. You cannot extubate such patients. Some centers, and also it's documented, it's been documented to show that bilateral cervical sympathectomy also helps in controlling such storms, but that would be an add-on if these things don't work. So this is how we do a substrate modification. You can see the LED territory, the septum. The red area is the scar of the low voltage area. We map and modify the scar and try and get him out of the VTs. Yeah. So this is an interesting ECG. This is a 21-year-old guy. Saw in Western India a few days back. He had, few years back, he had many episodes of blackouts. He just used to pass out, get up, pass out, get up, and it just kept happening. What do you notice? So if you see in the right side, it's easier to see it's an atrial fibrillation which is going on, but on the left side, it's a bizarre broad complex. That's a pre-excitation. You have an accessory pathway with a very short refractory period. It's a dangerous accessory pathway. And all the atrial fibrillation is going down the accessory pathway. This can happen more commonly if you have blocked the AV node with beta blockers or calcium channel blockers. The accessory pathway is actually encouraged to conduct more. And the same guy, in another episode, notice the heart rate is bizarre. It's almost 300 right on the top. The heart rate is close to 300. And these patients, he was lucky to survive because this can easily degenerate. Notice you have the AF with pre-excitation and it goes to VF and you can lose them. So these things do happen. Another tragic case, we lost this guy actually. He was a 35-year-old boy. He had, again, similar episodes. He used to just pass out. Most of the episodes were early in the morning. I think most of you would recognize this ECG. Strikingly, he had lost 2 of his brothers in the same fashion. They used to pass out too. He was asked to get a treadmill test done. Treadmill test was negative for ischemia, and they was given clean sheet that you do not have a structural heart disease. But this is nothing to do with a structural disease. This is Brugada syndrome. And this is a channelopathy. Most of the times it's a loss of sodium channelopathy, but there are other channelopathies which can cause this. And if you have history of syncope with the family history of sudden tragic deaths and a spontaneous ECG Brugada change like this is the highest possible risk in Brugada syndrome. And as I heard from his family later that we lost this guy also, they need an ICD and antiarrhythmics on ICD if they receive shocks for VFs. So I'll skip this slide. Yeah, sometimes you may not have discrete Brugada changes. You may have a strong family history, but you do not have a spontaneous type 1 ECG. You can challenge them with certain drugs, but I would not encourage that in peripheral areas where we don't deal with that routinely. We need, because they can easily go into a storm, VF storm. But these are a few things to bring out the Brugada changes. Another very interesting case, this lady is now about mid-20s. She, right from her infancy, after the age of 1 year, she used to go into seizures. She had seizures. She was eventually diagnosed of epilepsy and was started on, I think, carbamazepine and a couple of drugs for epilepsy. The seizures never improved. They continued. I don't know, she survived all that. And then later in her almost, I think when she was 18-year-old, we saw her. She was like, as usual, in a neurological ICU with a telemetry going on. And there we saw this. So funnily, the ECG would, prolong, QT would prolong, and she would go into a torsade run. So it actually was a long QT syndrome. It was diagnosed with genetic testing. And if you notice here, the baseline ECG, the QT is extremely long. It's almost encroaching to the next P wave, and it's almost 600 and 650s. And tragically, to make things worse, she was diagnosed empirically or clinically as epilepsy and started on carbamazepine, which is a sodium channel blocker and can make the whole QT. If anything, it doesn't make it better, it can make it worse. So she was stopped off that medicine, and then she eventually was implanted with a dual chamber ICD. You need to implant dual ICDs here, because if you pace the atrium, you increase the atrial rate, you can drive and reduce the QT. A bradycardia is a risk factor and worsens the QT. Once you have them on the slightly on a higher heart rate, you would have the QT functionally shorter. Ventricular pacing is not advisable, because then they will have ventricular pacing induced adverse effects on the heart. Eventually, she underwent bilateral sympathectomy also, because she got quite a few shocks from the ICD, and now she's healthy. She does get a sporadic shock now and then after sympathectomy, but she's a lot better. She's not had a fit episode ever since that time. And now, I think, should I stop here? A couple of cases I had. So I'll just stop with this case. This is a 56-year-old lady. I'd seen this lady a couple of weeks back. She underwent a mitral valve replacement for severe rheumatic mitral regurgitation 2 weeks back, about 2 months back. And after the discharge of that surgery, she had 3 episodes of loss of consciousness at home. When she came back, we saw her with this. Again, you notice here, similar to the previous case, you have runs of torsades, except this is now acquired. This is acquired. This is not a congenital QT syndrome. It is acquired QT prolongation. Why did that happen? Now, she was not on any anti-arrhythmic treatment. She was not on amiodarone, not on sotalol, not on diuretics to cause dyselectrolemia, which could trigger that. So it was a little baffling. So the reason for that was, before MR, she was in persistent atrial fibrillation. Almost permanent atrial fibrillation with persistently high heart rates, 100, 110. Now, after MVR, inadvertently, the surgeon created an AV block, which always happens. Most of the time, it can happen with MVR or AVR. And thereafter, she went into AF with CHB. Now, with CHB, she went into junctional escape. With junctional escape, remember, her heart rate was 100, 120 all the time, and now she's at 50, 60. Even though 50, 60 is not that bradycardic, it sounds like an innocuous heart rate, but for a female, the drop from 100 to 50 can cause sudden functional prolongation of QT, which is what you notice here. The QT is so long, and then you have this after depolarization, which can trigger. Here, these 2 PVCs, they don't trigger the VTs, but here the third one does trigger a torsade. And this is a classic torsade with an EAD, early after depolarization, on the T wave, and that trigger. And that's why she had these repetitive runs of torsades and loss of consciousness. So what did we do? We implanted a single chamber pacemaker. I did a his bundle pacing, a left bundle pacing on her, and increased her heart rate to 90 by pacing the ventricle. And there you can see the QT slowly settling down from 650, now it is 550. And then slowly with each passing week or fortnight, you bring down the rate by 10, 10. So from 90 to 80 to 70, 60, and then leave it there. And that's how you manage this. This is acquired long QT. I'll stop with that. thanks a ton for the opportunity. It really means a lot. Thank you.
Sure, Satish.
Very nice talk. Most of the things have been covered. My question to you as an electrophysiologist, like first of all, like you had shown cases, but from history, most of the time we are able to diagnose whether it's a cardiac syncope or a neurological syncope. And like I'm surprised, like recurrent MRI, CT, and EEG, why it was done, but it's okay. Second thing, my question is like patient gets a scar VT.
Yeah.
You put a AICD in a patient, but in spite of that, the patient is getting a recurrent shocks and all.
Yeah.
So, in how many percentage of patients you do electrophysiology and radiofrequency ablation? If it's a scar VT, and what is the success rate in that?
Yeah, great question. In fact, I'm faced with that question now all the time, sir. If the patient has an ICD and is getting appropriate discharges, and see, once a while a discharge is expected. That's the reason why the patient has an ICD, to take care of the sporadic event. But if it comes as a storm and you're receiving 50, 60 shocks, in fact, we have heard of crazy stories where your ICD was implanted, 2 months later the ICD's battery is done delivering 200 shocks. That does more harm than that's. Spare a thought for the individual who has got the shocks and what it does to the heart. It's just tremendous impact on the heart function. So in those situations, you have to, we have to reduce, we have to bail them out of the storm. Typically, the two things that are, as an acute storm in the ICU, as I said, we need to get them under general anesthesia as deep as possible, as quickly as possible. That gives you the best possible chance to, at least at that point in time, hold the storm. And then before you extubate them, underlying, so if it's a scar VT, then we need to do a catheter ablation and modify the scar. That is the best bet because you're directly dealing with the substrate. Some centers put bilateral sympathectomy a notch ahead and put it, but that's, I think, interchangeable. But I personally think that you need to do a scar modification. Just getting the sympathetic tone down, you still have the substrate and you may still have ventricular tachycardia. We could try that with beta blockers and go with a very high dose, get a resting heart rate of 60. If that doesn't work, bilateral sympathectomy may not as a standalone work. It does work as an adjunct, but we need to definitely consider a catheter ablation. Although the outcomes are not great. The mortality is almost 50%. Again, there are a host of factors and scores that because they're already very sick patients, they have heart failure, low output syndrome, AKI, and so on. But you still need to do what you need to do. If you leave them like that, they'll die. You just have to do a catheter ablation, I think.
Javed? Sir, great
Yes,
talk
Javed.
as usual.
Yeah,
Because we
thank you.
hardly get to interact with our critical care colleagues. So there is a thing regarding the electrical therapy for arrhythmias,
Yeah.
cardioversion and defibrillation. Majority of the times I've seen there are a lot of reservations in the critical care team or the other colleagues. So a few tips and tricks or regarding the safety of electrical therapy, if you could give.
Absolutely. I completely agree with your sentiments. That's something that I also struggle with our colleagues and Apollo and other areas that I go to. For some reason, electrical cardioversion is considered they have a very high threshold to consider that. It is considered unsafe. In fact, respectfully, I could not disagree more. You could not have a safer, if you've done your homework all right, patient is on anticoagulation, rate fibrillation, you've ruled out, thrombus. For ventricular tachycardia, the selection often makes itself. Your patient is unstable, you don't have a choice. But many times we hold back this cardioversion and just accept a rate control, which is, a shame because you can get such a better quality of life by maintaining sinus rhythm, getting sinus rhythm back by a well thought out cardioversion. Absolutely, fully agree with you. A cardioversion is extremely safe. In fact, counterintuitively, antiarrhythmics are not as safe. Many times you don't understand what all these trials that initially had these equivalent results with rate control rhythm, they had the problems because pro-arrhythmias. That's even true today. Flecainide, amiodarone, sotalol, amiodarone is considered. It is safe. It is safer compared to other cardio agents. But I think electrical cardioversion is safer. Done well, it always works. At least it works better than antiarrhythmics.
One final question,
Yes, sir.
In case of the VT storm or incessant kind of VT, which is not responding to the conventional treatment, how frequently you recommend the sympathectomy and What is the effectivity of doing this procedure in ICU setting?
Sir, I mean, in those circumstances, you won't have the time, or you won't have the choice. Most often times, the patients will be sick. The moment if you have a patient in storm and you have them under GA, what you will notice, the moment you try and attempt extubation or even attempt them making them lighter, you will see the storm coming back. That often happens. If your storm has settled with sedation, expect it to come back when you lighten the patient, because the substrate is pretty much there. So you have to do something, otherwise the patient won't get extubated. That's where the decision makes itself. Now, what you do there is either a sympathectomy or catheter ablation. I would, global recommendations suggest catheter ablation, and sympathectomy is a credible supplant. It's probably not an alternative, but some centers go for it first. I would not do that. I would consider a catheter ablation, but the subset is such that you don't have a choice. As somebody who has 5-6 shocks, you given an antiarrhythmic infusion and they have stabilized over 2 to 3 days in the ICU, I would hold it back. Catheter ablation is a challenging procedure, is a procedure fraught with risk as well. But if you worked your patient out, is okay without any VTs, you would probably consider an ICT implantation, or send them home with, if they're already on an ICT, send them home with antiarrhythmics, because they're safe at the end of it. But if you have a flurry of shocks, go ahead and do with the catheter ablation.
Okay, so we are closing the session, friend. One important last words, that friend, the cardiac emergencies are the real emergencies. They did not give you a lot of time. Sometimes it's a matter of 30 seconds, 50 seconds or so. The only important thing is how to identify the cardiac emergencies and diagnose them properly and treat them properly. A lot of new modality of treatment is available, like Dr. Soman has already told you, that RF ablation, EP study, etc., ICD, dual combo devices available, so they can be treated in case they are diagnosed and treated on time. Thank you very much.
Thank you so much.
Thank you, sir. I request our chairpersons, please felicitate our speaker with big round of applause. I request our chairpersons, please collect their mementos from the memento desk. And
The next session is a panel on management of heart failure in CKD. And I invite Dr. Tapas Kumar Sahu to moderate the session. He is Associate Director and Head Critical Care at Medanta Hospital, Ranchi. He is Additional Courses Secretary at Indian Society of Critical Care Medicine. He is the General Secretary of Nephrocritical Care Society. He is also an Asia Pacific representative at ESICM.
the panelists, Dr. D.M. Bhaumik sir, Dr. Javed Ali Khan sir, Dr. Smith Srivastava sir, Dr. Pravas Chaudhary, Dr. Suneet Chaudhary, and Dr. Varun Agrawal. Please join the dais as a panelist for the session. Over to you, sir.
इसमें ये लगाया मैंने.
I request Dr. Sonika, please felicitate our chairpersons with the mementos.
So, good evening, everyone. At the outset, thank you, Dr. Vishal and the enthusiastic Criticon Raipur team. Happy to be here in Raipur within last 2 months. 1.5 months back, we have conducted a very successful nephrocritical care workshop here. And again, back with a nephrocritical care, rather I would say final match. Maybe this is the last major session. After this, we will be having 2 hour sessions. So this is a session where we will be discussing again the heart, the kidney, and the patient is in ICU. So very difficult, I would say, perspective. And we have a very, I would say, very knowledgeable panel here who will be shedding light on this very important topic. We have all witnessed this type of patients who have kidney ailment, again having heart failure, and the patient is critically sick. So, yeah. So this is a crosstalk between heart, kidney, and critical care. I would be making this as a very clinical oriented, so that we will be not feeling little bit of theoretical. And I would also ask my panelists, very experts, to also set their experience and expertise to make the management part very straightforward and easy for our trainees and also our practitioners. Now, disclaimers from my side. At Nephrocritical Care Society, I am intricately associated with some of the brainstorming sessions in the nephrocritical care part, and this is again one part which I like the most. Now, just to start with heart failure in CKD. It's not about the ejection fraction, it's not about the creatinine, it's not about the CKD stage which the patient is in and the vitals, SpO2, blood pressure. Rather, how we are integrating the two major organs are right now somehow compromised, and we have to manage the patient successfully so that the patient will not deteriorate further. Rather, the patient will improve and have a good quality of life. Yeah, so just why it is not working. Okay, sorry. So what is happening here? First, before that, I want that we should not be shocked. Whatever happening to our patient, we should be at the at least end have managed the patient very well. Now, before going into the proper the flow of the questions or the clinical vignette, now let's understand the pathophysiology. What is happening to the patient? Now let's understand there are two things here: heart failure. This other part is kidney failure, and there is a vicious cycle happening. Now let's focus our part on this heart failure. There occurs volume, pressure overload. Very easy to understand. Now there is impaired renal blood flow as the heart is not able to contract well. Reduced renal blood flow, activation of the RAS system. RAS system is renin-angiotensin-aldosterone system, and as a result, what is happening? There is progressive fluid overload or retention happening in the patient, and as a result there is continuous renal ischemic injury happening. This is the first you can see on the left side of your screen. Now as a result, the kidney will also respond because the kidney is also compromised here. So the kidney failure is also right now affecting the heart reciprocally by some of the left ventricular remodeling and fibrosis, uremia. Patient is having on and off anemia because of, we all know there would be definitely erythropoietin, the production would be affected. Sympathetic activation, and as a result the same thing, volume and pressure overload. So this is the vicious cycle which is happening in our patient. With this background, what we are going to have? In this panel, there are 4 panelists here. We will explore 2 real clinical vignettes. These patients are very real, and I would like everybody would correlate with these patients. Each panelist will get 2 questions. We will depend upon the time we have, and at the end, each question will have a take-home message for the audience in 2 take-home messages that I thought about, so that we can at least understand the problem and the suggested answers or solutions. Now, without further ado, I would be starting with the first clinical vignette. The clinical vignette number 1, and I have named it as hyperpotassium roadblock. A 68-year-old gentleman with ischemic heart failure with reduced ejection fraction. Ejection fraction is 25% only. CKD stage 3B A3. Now what is this A3? I would be explaining if somebody is not aware of this. Patient is also a known case of type 2 diabetes. There are recurrent admissions happened over last couple of months for the pulmonary congestion. So this is the real case, 68-year-old male, and with the background history of kidney and heart failure. Now he is in your ICU or ER. Now CKD stage 3B and A3, what do you understand by this? This is a moderate to severe decline in the kidney function, and also there is severely increased albumin loss. So A is albumin. Okay. Now patient has been advised not to use or take RAS inhibitors due to prior hyperkalemia. Patient's potassium was actually high 5.4, 5.5 range, and borderline blood pressure. Blood pressure was 100/60. So this is the background. Now the first question I would be asking to the first panelist, how to optimize the heart failure therapy in this patient. Now this patient is in real problem and the clinician is actually challenged when the kidney says no. Okay. So Dr. Javed,
Sir.
I
Hello.
would,
Hello.
I would be starting with a question with you.
Yep.
How yeah.
I understood your question.
Yeah.
Two important things.
Yes.
One is heart, another one is kidney, and both are damaged. The kidney function is already on the downside, and the heart is already on the lower side of this one. And we have to save both the organs.
Yes.
So we have to follow the guideline, what the guidelines say. A for ACE inhibitor, ARB or ARNI, B for beta blocker, and third one is MRA, which should be given. But in this particular case, SGLT2 inhibitor, the fourth pillar. We should remember those four pillars should be used and should be utilized properly. In this particular case, what you are discussing, the patient is having low ejection fraction, the kidney function is on the lower side. Same time, potassium is on the higher side, which is a matter of concern. And the ACE inhibitor or ARB or ARNI was denied before because of the hyperkalemia event. So in this situation, the first line of treatment I would prefer is to give the SGLT2 inhibitor along with the diuretic to decongest the patient. And thirdly, control the potassium by various methods like K-bind sachet or some other therapy to reduce the potassium. And after that, once the potassium is already under control, the ARNI I will prefer is the second line of treatment after the SGLT2 inhibitor, which has got the first, beta blocker is second, and third one is diuretic, and fourth one, in case the potassium is normal, then I think the ARNI has to be given to these patients for the longer time benefit of the patient. That is what the correct practice and recommendation.
Dr. Bhaumik, if you
Thank
want
you,
to
Dr.
add.
Javed. I think you have brought out very relevantly the way you would approach the patient. The problem, as he has said in the title itself, is the potassium roadblock. And unfortunately, what drug currently we have is what is the K-bind or the potassium K-oxalate salt that you have. You can use it for 3 to 4 days, but beyond that, one cannot use it on a regular basis because it can cause colonic necrosis. So that is the main problem, and so we cannot use it on a long term. But luckily now we have the newer potassium binders which are available worldwide. That is the patiromer and the zirconium cyclosilicate. And I'm told in the next 2-3 months it will be available in our country as well. So once that is available, we can start using ARNIs as well, which will be very
Absolutely,
useful.
because
So
the heart protection is the most important, because you have to protect the heart, and the kidney you can compromise to some extent.
Yes.
So that is what the major role, and the heart has to be given the priority.
Right. So we're in dire need of this newer potassium binders, and they can be used long term. Studies have shown for even up to 2 years, the trials has shown no problems and very useful.
Yeah, excellently narrated by the two panels here, and we have this GDMT. GDMT stands for this is guideline directed medical therapy, and in this, thank you. Yeah. So we have first the RAS inhibition, second beta blocker, third one is mineral corticoid receptor antagonist, fourth one is the SGLT2 inhibitor. These are the standard practice. So you have to start anyway in your patient. That would be definitely improving the survival. The symptoms would be better and the quality of life would be better in heart failure with reduced ejection fraction. Having said that, we have to also add, depending upon the case, the diuretics for the symptom control, ivabradine if your heart rate is more than 70 despite beta blocker. Vericiguat is a recently added FDA approved 2021, which increases the cyclic guanylate cyclase level. So that would be definitely improving the vascular smooth muscle dilatation. So that is responsible. That is also you can add on, and iron therapy. In chronic anemia cases, you have to definitely depend upon the IV ferric carboxymaltose. So this is something, and the message for the audience, start all 4 pillars early and together. maybe at low doses, depending upon the blood pressure and the potassium, rather than sequentially at the maximal doses. So this is the first sequencing GDMT approach. Now, I have already told, and sir has already told, SGLT2 is the game changer here. We need to remember that they barely lower the blood pressure. Don't worry about the blood pressure. They would improve congestion and are safe in CKD. So these are something myths we normally keep in our mind. So start with SGLT2 inhibitor first, then bring back the RAS inhibitors once the potassium allows.
Sir, I will add one
Yeah.
more point in this
Yes.
case. So, good thing is SGLT2 inhibitor has caluresis property also. So, it might help with potassium control in this
Yes.
in the patient. Plus, we can always use small dose of loop diuretics because in heart failure, the mechanism for hyperkalemia is decreased distal delivery of sodium. So if you are able to increase the distal delivery of sodium by adding a small dose of loop diuretics, you are very well able to control the potassium level. So good thing will be start with a SGLT2 inhibitor. If it potassium gets controlled, good. If not, add a small dose of loop diuretic, which will also help in controlling the potassium. And then you can think for the other therapies.
Yes, and evidence also as per the SCC and AHA heart failure guideline 2022 and 24, they have also recommended that early SGLT2 initiation and first sequence GDMT. Now the next question, Dr. Bhaumik is not here, so any of you can take this question. Potassium is right now 5.4. So what is your play to make the RAS inhibitor and MRA possible again? I think the answers have been already given, so I will be just skipping. Maybe the potassium binders come into the picture. And here the patiomor, the sir was telling, it is coming soon to the Indian market. So maybe that would be you are using preemptively so that the potassium can come back in next 48 hours and you can start all the life-saving GDMD drugs. And as per the evidence also, the Amber trial publication, the Diamond, they also say that patiomor enables spironolactone and RAS inhibitor continuation safely. So take home message, sometimes potassium binders and diuretics as suggested, they are the GDMT enablers. Now next question to Dr. Suneet. Now there is a confusion between ARNI versus the ACE inhibitors. So when do you make the switch? In the CKD patient where the blood pressure is borderline, you are not very confident that whether that would affect your blood pressure.
Thank you, Dr. Tapas, sir. Actually, patients who are having symptomatic heart failure with reduced ejection fraction, if they are already on AC inhibitors or ARBs, it is better to shift to ARNI group of drugs because it will further improve their cardiovascular morbidity and mortality and reduce risk for hospitalization. But we have to keep in mind that we should start it at a low dose and monitor blood pressure as well as kidney function and potassium level and gradually increase the dose. That will be a safer approach and will get the benefits of this group of drug and for further cardiovascular benefits.
Yeah, excellent. So the slide already, he has already shared his opinion, which is you have to start with low dose ARNI, gradually up titrate, do frequent labs, and this is almost safe to the eGFR of around 30. So don't be so much of afraid of starting ARNI. Now next question, any of you can take. Should we initiate SGLT2 inhibitor during decompensation or you wait till the discharge of the patient? Like the patient
So nowadays SGLT2 inhibitors are it started upfrontly. We don't wait patients to be discharged till the time of discharge. Most important thing is you have to always see patient blood pressure control. So he should not be in hypotension before starting SGLT2 inhibitor because that might further worsen your AKI and make things complicated. So if you think now patient has stabilized, blood pressure has stabilized, you can very well start it early, then delaying till the discharge.
My view is, friends, you should understand that SGLT2 inhibitor is already a game changer. It does not have many side effects except then some UTI, etc. in the female patient. So it's a very safe molecule. It should be started as early as possible. I personally don't think that it reduces the blood pressure to very significant level. So any amount of the blood pressure, even 100 millimeter of mercury systolic, it can be given very safely. There is a lot of debate regarding what should be the starting molecule, ARNI, SGLT2 inhibitor or something else. So what I personally think is that SGLT2 inhibitor, without any looking at the blood pressure, you can start right from the day one. This is one. In case the blood pressure is on the normal side, you can start simultaneously with the ARNI. So the ARNI, you have to look for either potassium or the blood pressure. But SGLT2 inhibitor can be started right from the day zero. It will give you the positive response as early as possible. What I personally think.
I think that summarizes everything for this clinical case. So last question to like anybody can take this. In mild AKI with congestion, do you favor loops, thiazide, acetazolamide or ultrafiltration with straightforward dialysis? Or what is your view?
So usually AKI with congestion, we first try to manage with loop diuretics because that is the best which works. But because thiazide diuretics does not work once your GFR goes less than 30. So it becomes very challenging to use. Though chlorthalidone can be used at even with low GFR of 20s and 30s, but loop diuretic works the best. And if it is not responding to then you can do sequential blockade. So you can add second diuretics, which can be your thiazides or acetazolamide, and then it will help. And if that does not work, then we have to go to more invasive kind of therapies like ultrafiltration, which is the savior in such cases.
Yeah.
Regarding the diuretic therapy in case of the heart failure with the kidney disease, what I personally think is that you should be very judicious. Because the diuretic, as we know, that it does not reduce the mortality. It is basically to reduce the fluid overload which is accumulated in the body. It should be very gentle. It should be very judicious. So the patient should be having the normal volume of the blood. That is what I personally. You should not be volume depleted.
Yeah, so stepwise, if we are running short of time, SGLT2 inhibitor first, RAS inhibitor is the next one. If you depend on the binder, better to use it binder based potassium control and stepwise decongestion. Don't aggressively start with the dialysis just to remove the water from the body. Now just we have 1 minute, so I'll be just summarizing the second bignet because we have 5 questions more and we don't have time. Second case, a 74-year-old woman, heart failure with preserved ejection fraction, with ejection fraction of 55%. It's not having any, we can just correlate with the first case. CKD stage 4, diabetes, anemia and persistent edema despite the patient is on high dose loop diuretic, already suggested by our panel. Ferritin report came to be 45 and the transferrin saturation is 15%. Now, here there is a balance between pressure, volume, iron and kidney all at once. Now the question is, what is the core therapy in the heart failure with preserved ejection fraction and CKD stage 4? If anybody...
Sir, various trials have been conducted and taking the ARNI, SGLT2 inhibitor, diuretic, etc. And only one molecule has been shown to reduce the mortality to some extent. That is SGLT2 inhibitor. That is only SGLT2 inhibitor. Even ARNI has not shown a very significant, remarkable drop in preserved ejection fraction. So only one molecule, which is SGLT2 inhibitor, especially the empagliflozin mainly, have shown a significant drop in the mortality, and diuretic has got the another role. Eplerenone, etc. have been tried, but I have no idea whether they have shown any mortality benefit or not.
So last question, you can just address the iron deficiency part. Sometimes we get confused. Like, does IV iron help the outcome?
Definitely, IV iron actually help in symptomatic improvement of heart failure patients. Iron deficiency should be corrected if possible, we use proactively IV iron preparation. That will correct the iron status, and it is beneficial for the heart as well as for the relief of the symptoms. So definitely it should be checked and corrected in time.
Yeah. So I know that the time is not with us. So just to summarize for the audience to know, this is the flow chart. You can remember, you can take the screenshot how you should be managing heart failure in patients with CKD. You start with the proper investigation for the cause, then commence with the beta blocker, ARNI and SG2 inhibitors. Monitor the renal function, potassium, then check the iron status, replace it if it is needed. Still symptomatic and the ejection fraction is not improving, then add the MRA, mineral corticoid receptor antagonist. Still symptomatic, then you have to consider different devices. So that is something from my side. It is a difficult topic to finish in 15 to 20 minutes, but one last, like if I would be summarizing, this is SGLT2 inhibitor. We hardly use in our clinical practice. Start using it. It is a wonderful drug as suggested by our panelist. Enable the RAS inhibitors early. Don't abandon it just thinking that the potassium will be high and blood pressure will be low. Fix the iron deficiency for better outcome and reserve the ultrafiltrate at the last. Don't start with the dialysis or the scuff to remove the water. Rather, we should be going with the medical directed therapy more aggressively. Thank you very much for your all attention. So future of the integrated care is together the cardiologist, the nephrologist, the intensivist and the clinicians who are taking care of the patients on OPD basis also. They should work together, understanding the pathophysiology and treating the patient wisely. Thank you very much. Thank you all the panelists.
Thank you, Dr.
Thank you, sir. I request our panelists, please felicitate our moderator with a memento. And I request our moderator to reciprocate the same to the panelist. And for the next session, I would like to invite chairpersons, Dr. Praful Agnihotri sir, Dr. Abhishek Singh, Dr. Yasin Khan, Dr. M.H. Usmani sir, and Dr. Sanjay Pandey. I repeat, Dr. Praful Agnihotri sir, Dr. Abhishek Singh, Dr. Yasin Khan, Dr. M.H. Usmani sir, and Dr. Sanjay Pandey.
The next session on role of albumin in modern intensive care unit shall be delivered by Dr. Ajay Padmanabhan. He is a critical care consultant at Apollo Hospitals with special interest in post-ICU clinic, after discharge ICU care, focusing on increasing outcome of ICU survivors. He has also participated in major critical care trials worldwide.
Thank you. Thank you to the organizers. So when I was given this topic by Dr. Vishal, I just walked down my ICU and found that albumin was hanging in almost every other patient. And when I spoke to my colleagues, I realized that the views regarding the use of this molecule is rather polarizing. And when I reviewed the literature and I understand why it is so. So we can begin with that in mind, and I will give my interpretation of the role of albumin in a modern critical care unit. And this will be based on some guidelines which were recently published as well. Excuse me, slide. Thank you. So let's look at the molecular characteristics of albumin, which make it such a fancied molecule. It's a multifaceted molecule, though. The most popular one is, of course, its role on oncotic pressure and volume expansion. But then there are other characteristics of albumin which also make it rather attractive. It's also a transport molecule transporting endogenous as well as exogenous substances. This includes substances such as free fatty acids, bilirubin, and as well as the drugs that we administer. And it also has a role in scavenging free radicals, antioxidant effects, and immunomodulation as well. It, of course, has been recently discovered to have a major role in supporting endothelial integrity and stabilization of glycocalyx, and also a role in buffering. It's a major extracellular buffer, and in considering that albumin is used in conditions where there's going to be metabolic acidosis, maybe it has a major role. So looking at the indications of albumin, and this is a head-spinning list of indications. This is very much a toned-down list that I've added, looking at the literature. It could include some general ICU, some cardiac and renal ICU indications, and of course the liver ICU indications, and some miscellaneous indications as well. What I'm going to do is I'm going to review some of them and see what is their role in a modern ICU. I'm going to give you the rationale, the evidence of their use, and whether they should be used or not. And each one I'm going to give with an analogy, with the traffic signal. If it's a red, I'm going to say don't use. If it's yellow, I'm going to say use with caution, and green, I would say it's probably a standard of care. So what about albumin as a resuscitation fluid? Of course, it's commonly used. So what makes it popular? Albumin is an ideal, what is an ideal fluid at all? What is an ideal fluid is one that causes a predictable and sustained increase in intravascular volume. It has a composition similar to an extracellular fluid, should not accumulate and should get excreted, and also should be cost effective. What about albumin? It has a good oncotic pressure, causes strong volume expansion, and the volume is more likely to fill the intravascular space. With a smaller volume, cause better hemodynamic effects than crystalloids. The effects are also prolonged considering its longer intravascular half-life. It has less extravasation and also helps maintain the endothelial glycocalyx. Does it come with harms? Yes, it can cause harms. It can cause edema, it can cause rare allergic reaction, it can worsen situation in when there is a capillary leak, and there is a theoretical risk of infection transmission as well. But the major harm often that we don't realize is the major cost associated with the molecule. So looking at this, let's review the evidence. And we start with a 20-year-old trial, the SAFE trial, very popular trial done in Australia, where albumin was compared, this is of course 4% albumin, was compared with normal saline and used as a resuscitation fluid in a heterogeneous group of patients. Without going into the details of what the SAFE trial did, it essentially proves that albumin is safe to use. However, it may not be superior to normal saline. Remember, normal saline itself is a molecule which is becoming less and less fancied. And in this group of patients who are probably moderately ill and did not require very large volumes of resuscitation, it is not superior to saline. Definitely, from the many post-hoc analysis that was done on this SAFE trial, it seems clear that it should not be used in traumatic brain injury where it seems to increase mortality. But another post-hoc analysis also says it may be useful and beneficial in a sepsis subgroup. But remember what it also said, that if the patient who received 1.4 liters of saline for resuscitation, the comparator albumin received 1 liter. Does it matter much? It depends on an individual. And did not result in any core patient-centric outcome benefits. This was followed by a series of systemic reviews and analysis. And to summarize that, it seems that albumin used as a resuscitation fluid results in better hemodynamics such as CVP, MAP, heart rate, cardiac index, better fluid balance, so maybe it could result in better outcomes, earlier stopping of vasopressors or inotropes, but difficult to prove core patient benefits such as survival or improvement in organ function. So let's see how to administer it if we are going to use it. If a patient is hypotensive with shock, with high lactate, you can consider albumin, but which albumin? Is it 5% or is it 25%? The suggestion seems to be that it should be 5%, considering it is iso-oncotic, and it's more likely to fill, because these are patients that are hypovolemic, it's more likely to fill the tank. So you administer them at a 250 or a 500 ml bolus and then reassess and keep watch on the cumulative balance. But what about 20% albumin? 20% albumin has been demonstrated to cause a better volume effect, probably 200 to 400% more than iso-oncotic albumin. But it could also cause large fluid shifts and volume changes. So a study was done, rather a feasibility study was done recently called as the SWIPE trial, where they used albumin for small volume resuscitation. There is basically this concept of small volume resuscitation means that you use smaller volumes for the same hemodynamic effect with a lesser positive balance. Seems like it's helpful. Is it feasible is what the SWIPE trial says, looked at. It seems that it is feasible, but whether it will lead to better outcomes is for future trials to decide. Until then, I think 5% albumin seems to be the safer molecule to use as a resuscitation fluid. Whether you need to check albumin regularly, if you look at the SAFE trial results, it seems that looking at albumin subgroups, the ones who had albumin less than 2.5 or more than 2.5, it didn't matter. The outcomes were all the same. So it probably is not mandatory to check albumin regularly when using albumin as a resuscitation fluid. So the take home is albumin seems to have favorable physiological properties, safer, better hemodynamic endpoints with lower net fluid balance, but no clear evidence to support use. And remember the heavy costs. And for now, prefer iso-oncotic. So for now, I'm going to say use with caution and definitely not to be used in TBI resuscitation. The next role of albumin, which has been extensively studied, is an albumin role in sepsis. Why is it so? The rationale is albumin, along with the volume expansion properties that it brings, it also brings a list of other secondary effects that we had already described, which makes it a valuable molecule to study in sepsis. If you look at it, immunomodulation, free radical scavenging, supporting the glycocalyx are all favorable features. Now, where do we use it? It can be used in 3 roles. It can be used in salvage and rescue, as we had already discussed. It could be used as a stabilization phase. That is when the fluid resuscitation is completed, and now you need to administer some other molecule which will result in better outcomes. One which can be given once the permeability of the capillaries has stabilized. This is what we are going to review. And then the other one is once the fluid has been given and there is a heavy positive balance, you do a de-resuscitation where you combine with Lasix, which we'll discuss later. So basically, this I'm going to depend on the Albios trial results where albumin was compared with no albumin. Remember though, this is not a resuscitation trial. Here they have used albumin as a drug rather than a fluid. Because all the patients recruited had already received fluid as per the EGDT that was in existence back then, and this did not demonstrate any mortality. However, it noted a couple of positive signs. There was a lower cumulative balance with the use of albumin, and a post-hoc analysis of the group of septic shocks showed that probably a lower 90-day balance, 90-day mortality with the use of albumin than compared to the crystalloid group. Looking at this with subsequent meta-analysis, seems like there may be some favorable benefits of using albumin in sepsis subgroup. But some of the recent trials, however, do not show this. Like this RAP study where RL was compared with albumin did not show albumin superiority. So should we use it? It could be used like a degree of resuscitation and as a degree of supplementation, more like a drug rather than a fluid. Because of favorable secondary outcomes, effects of albumin, data is still uncertain, but the direction of benefit seems to be there, and it should be used after initial resuscitation. The Surviving Sepsis campaign also says this. And how to use? We can use it as per the Albios protocol, where we measure albumin every day and try to target an albumin of around 3 grams per deciliter, and for that you administer around 200 to 300 ml of 20% albumin to keep the albumin at around 3. So for this, I'm going to say green, but also be very cautious because the albumin molecule is costly. So again, now the next indication commonly used is de-resuscitation and using it along with Lasix. Of course, the reason being that furosemide is predominantly albumin bound. If there is low circulatory volume, albumin will improve the circulatory volume, improve renal perfusion, and then now you get better delivery of furosemide at the tubular level, and this could break the resistance to diuresis and cause better de-resuscitation. So this is a common thing that is being used where we combine albumin and Lasix, and the net effect could be efficient de-resuscitation and better fluid balance. But is there evidence to support this use? Well, there are small RCTs and a few meta-analyses. One studying it in acute lung injury group where it showed a better negative fluid balance, better oxygenation, but no improvement in survival or other outcomes. Another meta-analysis also proving something similar. So the reason being this is a little skeptical is there is short-lasting outcomes are there. Effect is, however, not seen in patients who have normal albumin, and it's expensive. So what I would suggest is this can be tried where first you try Lasix for deresuscitation, and if you're not able to see an improvement, maybe add on with albumin. So for this, I'm going to advise caution. Moving on to the liver ICU indications. The most common thought is, of course, large volume paracentesis. The rationale being a large removal of more than 5 liters of ascites can cause hypovolemia and circulatory disturbance. And albumin, through its oncotic properties and its other secondary effects on the endothelium, may be useful and much more superior to crystalloids than crystalloids. So what is the evidence? There are multiple RCTs and meta-analysis which show that there is a reduced incidence of post-paracentesis circulatory dysfunction and renal impairment with the use of albumin, and some trend towards improved short-term mortality, short-term survival as well. Data on long-term is, however, uncertain. So albumin, of course, is recommended by multiple liver societies, European as well as American. So how when meant to use? So it needs to be used when the paracentesis volume is more than 5 liters. For every 1 liter, you administer around 6 to 8 grams of albumin. And this should be mainly in large volume, but however, in some situations, when there's a moderate volume paracentesis required, especially if the patient has poor renal function or pre-existing hypotension, maybe you can also consider using albumin in this situation. So here, I am suggesting that this is a standard of care. In spontaneous bacterial peritonitis, often again used. Here again, it's useful based on its hyperoncotic properties as well as its other secondary effects. The evidence of use, remember it always needs to be combined with antibiotics, and most of the trials also evaluate this. One major RCT back in 1999 showed that the use of albumin along with antibiotics resulted in a lower rates of renal failure and in-hospital mortality compared to antibiotics alone. And some meta-analysis also show improvements in mortality. So, however, don't use in all SBPs. Use in high-risk SBPs, that is those who have bilirubin more than 4 or higher creatinine. So this is what is being recommended by the European, American societies as well as the transfusion societies as well. So when to use 20% albumin. Recommended dose is 1.5 gram per kg of albumin at day 1 and 1 gram per kg of albumin, 20% albumin on day 3. Additional consideration, remember not to be used in low risk SBP. Remember the adverse effects as well. So here also I am going to say that this is a standard of care. Again, next is hepatorenal syndrome. This is a situation where we have systemic vasodilation but renal vasoconstriction leading a catastrophe. Again, albumin could be useful because it fills volume, it has anti-inflammatory properties, and because of this, albumin has been extensively studied. What is the evidence here? Again, remember here also, albumin has always been studied with another vasopressor, either midodrine or terlipressin or noradrenaline. So, when studied along with another vasopressor in multiple randomized control trials, there is a tendency towards better hepatorenal syndrome reversal and maybe even survival, especially when used along with terlipressin. So, it seems to be helpful. And it's also recommended by the European and American societies of liver diseases. So how to use? When you suspect FCRS, first administer 20% albumin fluid bolus. If the patient gets better by the volume effect itself, it means the patient is probably an AKI. If the patient doesn't get better, then probably it's an HRS. In that situation, add terlipressin and then continue at a dose of around 20 gram to 40 gram per kg from day 2 onwards up to around 2 weeks until improvement or up to 2 weeks. So remember, you're combining it along with terlipressin, a strong vasoconstrictor, it may cause trouble in patients with cardiac dysfunction. Here also I am going to say standard of care, but also little caution because albumin has never been studied alone. So the benefit of whether it is due to vasopressors or albumin alone is unclear. In other hepatic indications also it's been studied. Short-term albumin therapy has been studied in conditions such as infection other than SBP, hepatic encephalopathy, but the evidence here is actually counterproductive. It seems that it doesn't improve with outcomes and it also seems to worsen some outcomes such as pulmonary edema, and this is what the recent NEJM trial, Atal trial shows, where patients who had hypoalbuminemia with cirrhosis were administered albumin. It showed that there was increased risk of albumin. So here I'm saying no to the use of albumin. In cardiac surgical setting, here is another area where it has been commonly used. It's either used as a bypass priming fluid or post surgery in the ICU. There are two recent trials that have come evaluating this. One is the ALBIX trial and other is the ALBIX AKA trial. Very recent trials. One is in low risk and other is high risk. One was used as a priming fluid and other was used as a post ICU infusion. Both studied AKA as an outcome and did not show any improvement. In fact, they showed harm. In one study, the ALBIX study, there was increased bleeding, and another study, the ALBIX AKA study, which showed to prove that albumin reduces AKA, actually showed AKA incidence is higher. So the take home that I'm going to say is no to this use. What about albumin renal setting? Nephrologists have often prescribed albumin to prevent intradialytic hypotension. Recent small RCT showed that albumin use could be associated with fewer hypotension episodes and better fluid removal. And this is also demonstrated by subgroup analysis of the renal trial. So here, it's probably safe to use. Hypoalbuminemia is one of the conditions in ICU we frequently encounter. When something like this is seen, as intensivists, our immediate role is to try to fix it. But however, albumin could be low in the ICU because of multiple reasons, and it could be more of a effect rather than a cause. However, hypoalbuminemia is also associated with poor outcomes. What does the evidence say? There's one trial which tried to keep albumin around 3 and demonstrated that the delta SOFA group is SOFA scores are better in albumin use. But even here, the effects were not sustained, and since then, no other study has proven this. So here also I'm saying probably it's not to be used, but however, in situations where the hypoalbuminemia is very severe, such as when it's very less than 2 and protein losing conditions, the evidence is less clear and it is up to interpretation individually. So putting it all together, where do we use it? Cirrhosis with SBP, definitely. The evidence is good. Cirrhosis with large volume paracentesis, definitely. Intradialytic hypotension, yes. Evidence sketchy, small RCTs. Hepatorenal syndrome, yes. Use in caution when you're using along with Lasix. In resuscitation of any unclassified shock, also use with caution. In sepsis, not as a resuscitation, more as a supplementation, maybe it's borderline between yes and no. Where you should not use, and the data is very clear, cardiac surgery, traumatic brain injury, less clear, maybe cirrhosis with extraperitoneal infections and hypoalbuminemia. So thank you, and I end this talk. Just keeping note of some recent trials whose results are due. One is the Alta AKI studying albumin use in AKI, other one in CAP, and other one in septic shock, the ARIS. Thank you.
Hello. Thank you, Dr. Ajay, for giving such good description of indications and contraindications of the albumin. Now the house is, if there are any questions for the.
Hello. Thank you for your very interesting speech. Okay. My experience, I am not young like you, okay, says that during the capillary leak syndrome in some patients with sepsis, we have a paradox effect because albumin pass in extravascular space. And so we don't succeed in take the fluids inside the vessel, but we have an effect that we don't want to increase the edema. What is your suggestion?
Yeah, that's a very good question. So it is in situations where there is a capillary leak, when like this could be early in sepsis, burns, or any severe stress. It seems that albumin, at least if you look at it physiologically, is likely to cross the endothelial barrier, go into the interstitial space, and probably worsen outcomes. This could be one of the major reasons that many authors, and I too am feeling very cautious about using albumin routinely as a fluid in ICU. I didn't have the slide here, and I could say that albumin use in Europe is almost nil. If I'm right, I could look at it. It's almost nil. However, in India, it's used quite commonly. So the answer to you is it is not clearly proven in based on the evidence that is available that this particular phenomenon happens. But looking at the other results, especially if you look at the cardiac surgery subgroup where the harm happens, maybe it happens. So as of now, I think the answer is we have to be very cautious. It probably could be there. So albumin as a resuscitation in the initial phase, when the endothelial integrity is not good, is questionable. I can't say no without unquestionably, but definitely needs to be evaluated further. Maybe the ARIS trial will give us an answer. But once the endothelial barrier is stabilized, once a little later in sepsis, like the group of patient subjects studied in the albuos group, maybe it's helpful. I hope that answers your question.
Hello. Good afternoon, sir. Okay, in patients where the patient was already on IVIG therapy, where the profound third spacing is already going on. So we need to combat the ongoing losses with hypoalbuminemia, where the already patient is on IVIG therapy. So
I'm going to say if such a patient exists, I don't think you need to consider albumin at all. IVIG is already a costly molecule.
Yeah.
Albumin benefits are in hypoalbuminemia are questionable or nil actually.
Yeah.
And I think there is no real added benefits that albumin brings to the table in such a patient.
Yeah. Okay, thank you, sir.
Okay, I think there are no more questions probably. Shall you close it now?
Yes.
Okay,
Thank you, sir.
Thank you.
I request our chairperson, please felicitate our speaker with memento. And I request our chairperson, please collect memento from the memento podium. And I request, give them big round of applause. I request Dr. Shamik Dave, please present mementos to our chairperson at the memento podium. And now, here we have to close our big Criticon. And I request Dr. Vishal for his final conclusion and vote of thanks. Thank you.
So good evening, everyone. As the Criticon 2025 conference draws to a close, my distinct honor to propose the vote of thanks. First and foremost, our deepest gratitude to our esteemed chief guests and keynote speakers for sharing their profound knowledge and inspiring insights, which have been the foundation of the enriching experience. Gratitude to our patron, Dr. Sandeep Dave sir, Dr. Abbas Naqvi sir, for being a pillar of strength all the way and providing us with the opportunity and support to conduct the mammoth task. We extend our sincere appreciation to the organizing secretaries, scientific chairpersons for crafting this beautiful program, organizing team, executive committee of our hospital. A special thanks to all the delegates, researchers, participants who traveled to Raipur and engaged so passionately in the discussion and making this conference a vibrant platform for advancing clinical excellence. I will say clinical excellence. Looking at on the sideline of the conference, I saw the discussions, the level of discussions and the level of questions which were asked throughout. I think I can say hats off. I have been to the many conferences, as a faculty, but I can personally say the amount of science which was discussed in the conference was what is to a great level, right? So we also extend our sincere appreciation to organizing committee, secretariat, our dedicated team of volunteers. Your tireless efforts and meticulous planning and hard work behind the scenes ensure the seamless success of this event. Our thanks also goes to our sponsors, partners for their generous support, without which the event of such scale would not have been possible. Finally, thank you. Thank you to the wonderful staff of this Mayfair Resort for helping us organizing this conference seamlessly. And with hearts full of gratitude, we conclude this Criticon 2025. Thank you all. But the last but not the least, I will thank my critical care team at Ramkrishna Care Hospital. I am proud of them. And a special thanks to one person, which I have kept for the last, is Dr. Srinivas. I would like him to come to the dais, and I would like Dr. Ujjwala Mahatre to present him with a token of appreciation for the hard work which he has done for the conference. And a special thanks to Dr. Manoj Soni, Dr. Ujjwala Mahatre for conducting this beautiful conference. Thank you one and all, and wish you a safe journey home and continued success in your future endeavors. Thank you all.
photo session.
We already concluded this is only for the sponsors. Right? They wanted few slides. So,
And at the conclude, I request our RKCS team please assemble near the stage for a group photo. I request all the team who are presented here, please assemble.
अच्छा उसने लिया ठीक ठीक
रामकृष्ण केयर टीम के सारे सदस्यों से मेरी एक रिक्वेस्ट है, आप स्टेज के पास आ जाएं एक ग्रुप फोटो के लिए। जो भी यहाँ पे मौजूद है, रामकृष्ण केयर हॉस्पिटल के जो भी सदस्य यहाँ मौजूद हैं। आइए आइए। अरे शमिक, जस्ट फोटो, ग्रुप फोटो, फॉर ग्रुप फोटो। आ जाओ। Please come forward. Please come forward for the group photo. Sir, please come forward for a group photo. Bye. I will catch you.